Good morning everyone and welcome to Paediatric Emergencies. I'm Chris Flannigan. So that feels really good to say eventually, because that was something I wasn't going to be sure if I was going to be able to say this year or not at all. As a lot of you know, we had originally planned a 3-day physical conference in Belfast back in June, and unfortunately when COVID hit we had to cancel that. We then underestimated how long COVID was going to last for and pushed things back to November, initially planning a physical event. It very quickly became clear that wasn't going to be an option, and we rescheduled to a live stream. Unfortunately, again, with everything that was going on in Northern Ireland, we had increasing COVID restrictions. We had to cancel the live stream, and we had to cancel what we were planning to do with the live stream. We were originally planning to make a very interactive day. The speakers all come into the venue with me today, giving their talks, interacting with you during the talk, but we couldn't actually physically do that with all the restrictions in place. So what we've decided to do is we've pre-recorded all the talks, but we're still really keen to make today interactive. And what we're going to do, the speakers are all available on a Zoom call at the end of the talk. They're going to be able to take your questions. So what we're asking you guys to do is, over in the YouTube chat, you're going to find the YouTube chat to the right of the video that's just playing. And you are going to need to be signed in to use the YouTube chat. So while in YouTube, you can watch the video without being signed in. To actually interact with us, you are going to need to sign in. So it's worth sorting that out this morning. So as the talks are playing, leave your questions for the speakers. I've got a panel of people with me today. They'll be picking the best questions out, and then we're going to ask those to the speakers at the end of today's talk. So try and work out the YouTube chat as you go along. So I'm very fortunate. I'm here by myself with all the equipment that is going to let me do my talk live. And my talk is going to be very interactive. So I'm going to be stopping at various stages, looking for you guys to interact with me in the YouTube chat. And then I'm going to be using your interaction to completely shape my case. So the case is going to vary completely depending on the choices you make in it. So more on that later on. What I'll do is I'll give you a look at our programme for today. The programme is over on the Paediatric Emergencies website. Unfortunately, as I was expecting, the website has crashed already this morning. It's just not designed to have lots of people visiting at once. So I'll leave this on the screen for a little bit longer than what I would otherwise in case you haven't seen it. So what we're going to do, we're going to have 4 talks over the morning session. We're going to take a brief break for coffee, and then we're going to have another 4 talks before lunch. After lunch, you've got a further 4 talks before we go into another coffee break, and then a further 3 talks before we sign up for the end of the day. So if you look at our speakers, you'll notice we have quite a different range of speakers than what we did last year in our Waiting for the Retrieval Team event. You'll notice there's much more paediatric subspecialists rather than just intensivists and emergency department doctors. And that goes with our theme for this year. Our theme this year is working with other specialties. So these guys are all great speakers. We've got some great talks, and there's a lot of really good learning for you. So I think you're going to enjoy today. So as you're aware, this is a free event. There was no registration fee to pay, and you were just able to visit the web link and be able to watch this today. So this is because of these 4 guys. So that's AirTrack Ambu, Healthcare 21, and Northern Hospital Supplies, our course sponsors. So when these guys originally agreed to sponsor our event, they were expecting a 3-day physical event in Belfast, which was completely sold out. They were going to have a table at the event. They were going to be able to bring their products along and show them to you guys. When we had to change things over to a live stream, they were really good and stuck with us and continued to support us, which is great. So I am going to show you some of their products in video form over the coffee breaks and over the lunch breaks. And I would encourage you to keep a look at these products during those breaks, because the reason you're able to watch this today for free is because of these 4 companies. So a big thank you to them. So the reason we put these events on is because we're hoping that something we share with you, you're going to be able to use it somewhere to help a critically ill child somewhere in the world. That's the reason we do these. We're also hoping to do some good with this event in our local children's hospital in Belfast. by asking you guys to support our local hospital charity, Helping Hand. So Helping Hand do a great deal of really good work in Belfast. They've donated a lot of equipment to our PICU and to our retrieval service. And I personally have used that equipment to save the lives of a number of children over the last few years. If I hadn't had that equipment in those particular occasions, the outcome for those kids could have been very different. So they do a lot of really good work. So in lieu of any course fee for this event, what we're asking, if you've had a good day, come the end of the day, you consider making just even a small donation to Helping Hand. To make that donation, you're going to find it over in the Paediatric Emergencies website, so hopefully I'll have got that up and running again by then. I'm going to try and get that up during the first talk. You're going to go to paediatricemergencies.com. Importantly, paediatric is spelt the UK way with an A in it. Find the conference tab at the top and then click on Paediatric Emergencies 2020. What you're going to want to do then is scroll down to the bottom of the page, and beside the Helping Hand logo, you'll find that button where you can make your donation to Helping Hand. You are going to want to visit this page because there's going to be a lot of other information on it that you're going to want. The first thing you're going to get is your course certificate. The reason we have gone with YouTube is we wanted to make this accessible to as many people as possible, as easily as possible. And today you can just visit the web link and the videos will play without needing to sign in or register. The only downside to that is we're not able to keep a record of who was here or how long they were here for. So the best I can do is self-certification certificates that you can click on, download and sign yourself, specifying the number of hours that you watched the live stream. So not perfect, but I've added them by popular request, and hopefully they'll be good enough for most appraisal purposes. The other thing we're really keen to collect today is your feedback on this event. Obviously this wasn't our plan A, and it certainly wasn't our plan B or plan C, what we're doing today, but we think we've come up with a good way of doing it for you, and hopefully a way that you're going to enjoy. But what are we going to do going forward? What we're going to do depends entirely on what you think of today's event. So we can do another live stream next year. We can do a live stream with some modifications, or we can go back to the physical conference in Belfast like we were planning to do this year and like what we did last year. That's completely up to you. So take 2 minutes at the end of the day when you're thinking about the Helping Hand donation and getting your certificate to leave us a bit of feedback. And I'm not exaggerating, literally 2 minutes will fill this survey in, but it will really help us out an awful lot. Final thing to mention is over in that page you are going to want to visit it. It's the most popular question I'm getting asked: will these videos be available afterwards to watch? And the answer is yes, they will. Certainly I've got all the individual talks available as separate files, and I'm going to be putting them up to the Paediatric Emergencies website on the conference homepage. Whether the live stream stays up or not will depend. I'm still deciding the ins and outs of that. Okay, so I think that's everything I want to tell you for now. Hopefully we can make a start. So our first speaker is Dr. Costas Kanaris. He's a consultant paediatric intensivist and retrieval specialist. And I think most of you will know Costas from his famous Friday quiz on Twitter. And those of you who are following Costas will know that he's already released the case that he's going to be discussing about today. And I'm sure a lot of you are his followers signing in to find out the answers to that quiz. So we're going to head over to Costas now.
Hello, I'm Costas Kanaris and I'm a consultant in paediatric intensive care and retrieval medicine. Today I will be speaking to you about a difficult intubation. This is based on a real case. The initial format was intended to be interactive in nature, but we will have to do a question and answer version instead. So please grab a pen and paper and get ready to answer some questions. Hermione is a 4-year-old girl that was brought in by ambulance to our emergency department. She's had chest pain for the last 24 hours. On the background of that, she's had a 3-month history of shortness of breath and static weight. Her vital signs are SATs of 94% when upright, and these drop to 84% when she lies flat. Her respiratory rate was 16. She had a heart rate of 180, a capillary refill time of 3 seconds, both central and peripheral. Her non-invasive blood pressure is 92/45, and her GCS was 10. She was afebrile at 37 degrees. On examination, her chest was dull to percussed bilaterally, and she had subcostal recession. She had warm peripheries, and would develop facial cyanosis and congestion whenever she lifted her arms up for a cuddle. A chest x-ray and a capillary gas were taken, both of which are shown on your screens. Please take a minute to interpret them both and write your answers on a piece of paper. You now have 5 minutes to answer these 5 questions. What clinical sign is Hermione exhibiting? What are your top 5 differentials? What worries you the most about the gas? What worries you the most about the observations? And what is your airway and breathing plan? What clinical sign is Hermione exhibiting? Well done to those that said the Pemberton sign. This was named after Hugh Pemberton, who was a Liverpudlian physician born in the late 1800s. The Pemberton maneuver is a physical examination tool used to demonstrate the presence of latent pressure on the thoracic inlet. In this case, it is likely to be due to obstruction of the superior vena cava. The maneuver is achieved by having the patient elevate both arms, usually 180 degrees anterior flexion at the shoulder, much like trying to get a cuddle in a child, until the forearms touch the sides of the face. A positive Pemberton sign is marked by the presence of facial congestion and cyanosis, as well as respiratory distress after about 1 minute. The large mediastinal mass on the X-ray is pretty hard to miss. Be aware that for a child to be exhibiting respiratory symptoms with an X-ray appearance like that, there is likely to be more than 50% narrowing of any part of the airway. Symptoms associated with mediastinal masses, especially anterior in nature, include air hunger, dyspnea, wheezing, anxiety, and the child having a preferred position of comfort, usually upright or semi-upright. If the mass is anterior in nature and is large enough, then usually a child is unlikely to be able to lie flat. In superior vena cava obstruction, the symptoms include facial swelling, upper limb swelling, periorbital edema, conjunctival suffusion, dizziness, and headache. You need to have a high index of suspicion in inexperienced clinicians that may label this combination of symptoms as anaphylaxis, and you need to be ready to question it. Question 2. What are your top 5 differentials? You need to be aware that up to 55% of all mediastinal masses in children are anterior in nature. Differentials for anterior mediastinal masses include Hodgkin's and non-Hodgkin's lymphomas, germ cell tumours, thymic tumours, and thyroid tumours. If it's a middle mediastinal mass, then the differentials are slightly different. These include parathyroid adenomas, tracheal tumours, pericardial cysts, and esophageal tumours. If they are posterior, these tend to be neurogenic or neuroendocrine in origin. Questions 3 and 4. What worries you the most about the observations and the gas? This is perhaps the most subjective question. The combination of hypercarbia and altered sensorium should always ring alarm bells. This child has a respiratory acidosis that is no longer able to compensate by blowing off its own CO2. This, coupled with orthopnea, should put the differential of anterior mediastinal mass very high up on your list. The inability to compensate one's own CO2 is a concern, as it suggests that the patient is tiring, with a very high possibility of a respiratory collapse or arrest unless we do something about it imminently. I will spend the rest of the talk trying to answer the final question, which is, what is your airway and breathing plan? It is vital to understand that in cases of big anterior mediastinal masses, intubation should be postponed unless absolutely necessary. We need to consider using non-invasive ventilation to improve oxygenation and improve blowing off CO2. And if possible, we need to see if there's another way in which to alleviate that pressure effect that the mass has both on the airway and the superior vena cava. With the help of our oncology and hematology team, we may be able to use steroids or chemotherapy or radiotherapy to shrink the mass enough in order to have further tests and imaging done. It's important for big masses to think about the possibility of tumor lysis syndrome. Tumor lysis prevention regimes include hyperhydration, usually 2.5 to 3 liters per meter square of fluid, using allopurinol and or rasburicase to try and minimize the risk of tumor lysis. Remember that in most cases, the masses are distal to the point where the endotracheal tube will be inserted if it comes to that. This is clinically significant as we are not going to be able to splint the airway using a tube as the obstruction is distal to the tube. It is therefore vital to explore the possibility of having some imaging, ideally a CT, as the child is unable to lie flat. We need to see whether our friendly radiologist is able to do a sitting up or semi-upright CT. There may of course come a point where you will have to intubate children with anterior mediastinal masses. This is not a decision to be taken lightly, nor is it a skill for the faint-hearted. So you need to be absolutely clear about the indications for intubation for such patients. Hypoxia is perhaps the commonest indication. So if the child is receiving 100% supplemental oxygen and is still hypoxic, then you are likely to need to intubate. If the child has a GCS of 8 or less and is getting worse, then the patient is unlikely to be able to maintain their own airway for much longer. So you're again likely to need to intubate that child. If the patient is becoming fatigued, as shown by the inability to compensate their CO2, which is rising and with worsening respiratory acidosis, then again, you're likely to need to intubate. The final indication for needing to intubate such patients is significant cardiovascular compromise. Recommended anesthetic techniques for children with anterior mediastinal masses include inhalation induction with maintenance of spontaneous respiration, usually using an awake fiber optic technique. The use of continuous positive airway pressure may help to maintain functional residual capacity that is otherwise reduced under anesthesia. Remember, it's ideal to have venous access in the lower extremities as the superior vena cava is likely to be obstructed, impairing therefore drug and fluid delivery to the right place. By keeping the head of the bed elevated, you may decrease the deleterious effects of supine positioning, including the upward displacement of the diaphragm and the secondary reduction of thoracic volume, which will make your ventilation much more difficult. Keeping the patient in partial or even full right lateral decubitus position, you may be able to help them to maintain airway patency and reduce cardiac and vascular compression, i.e., you divert pressure away from the heart. Performing tracheal intubation under deep inhalational anesthesia without the use of muscle relaxants and positive pressure ventilation may result in a more normal transpulmonary pressure gradient and improved flow through the conducting airways. The decrease in chest wall tone associated with paralysis is thought to increase the risk of severe airways compression. You should almost never use paralysis in patients with large anterior mediastinal masses. As an alternative to tracheal intubation, the use of laryngeal mask airways have also been described. The use of a helium-oxygen mixture has also been advocated to allow laminar flow and decrease resistance to gas flow in the conducting airways. In the event of tracheal or bronchial collapse under anesthesia, a rigid bronchoscope may prove to be life-saving. It's also worth trying to prone the patient after intubation if this happens, as you will be using gravity to divert pressure away from the affected airways. It is also worth remembering that intubating a patient in an ECMO center whilst having ECMO on standby is the gold standard of intubation in these patients. In the UK, we have mobile ECMO capabilities for children, so if your patient is heading towards the direction of intubation, it may be well worth exploring by discussing it initially by your critical care retrieval team regionally. There is some evidence to suggest that Krupp tubes or armored tubes are superior and a safer option for use as endotracheal tubes for intubating patients with anterior mediastinal masses. Many of you may appreciate an algorithm to put all your thoughts in a row as to how to manage a child that presents to your ED department with an anterior mediastinal mass. This flowchart is taken from the seminal paper quoted above, and it is open access in nature, and I would highly recommend that you have a read. It will also give you access to this flowchart. It's worth remembering that predictors for safe general anesthetic in such patients include an echo to evaluate cardiac motility and venous return, pulmonary function tests, and peak expiratory flow rates or more than 50% predicted, and also a CT-directed tracheal cross-sectional area of more than 50%. So essentially, anything that suggests that the airway is obstructed by more than 50% makes these a high anesthetic risk case. Above all, remember that the acute management of a child with a mediastinal mass that presents to your ED department is a team sport. You're likely to need the pediatric team, the hematology oncology team, your anesthetic team, as well as pediatric critical care. If you're in a hospital without PICU support, you will almost definitely need advice from your PICU transport team, who may also put you in touch with a regional ECMO centre. You might also need the help of your ENT surgeons. Always remember to make time for the family. Have someone allocated from within your team to update them every 20 minutes to half an hour and to check in on them to make sure they're okay. This may well be a bad day at the office for you, but this is almost certainly the worst day in that family's life. Thank you very much for your time, and I'm happy to answer any questions.
That's you, Ben.
Good morning. Listen, thank you for joining in and welcome to the Paediatric Emergencies online session. As Chris said at the start, it would generally we have these days in a a normal practical day where we all get together. So, but the beauty of going online is that it does allow us to open it up to a wider audience. Just by way of introduction, what the format of this area. So we will be after each talk joining with a panel, some of whom will be here all day and others just joining in for their particular talk. And I'd just like to start just taking a brief opportunity to introduce the panel.
Ben, you need to put your microphone back on. Sorry, that's your microphone as well as your earphones.
Based in the Children's Hospital in Belfast. We have Chris Flannigan, who is a Hello, Chris, can you hear me now?
Oh, that's much better now, Ben, yeah.
Sorry, guys. My name is Ben McNaught and I'm an ST at Paediatric Trainee in Belfast. We have Chris Flannigan, who's PICU consultant in Children's Hospital in Belfast. Tudor, Oman, who is a PICU an ED consultant in RBHSC. Costas, Kanaris, who you've just heard from, who is PICU consultant Royal Staffordshire Children's Hospital and consultant with the Newts Retrieval team. Conor Jackson is an ENT consultant in Children's Hospital in Belfast, and Peter Donnelly, who is a PICU consultant in Glasgow. So I suppose without much further ado, we are hoping that we'll get some questions through the YouTube chat as the talks are going. A lot of good mornings there and great to see so many from around the world, but actually not that many questions. So we do encourage you to submit those. One question we did have as a panel for yourself, Costas, was we're just wondering, you talked about potential ECMO. Is ECMO always going to be possible in these patients, or is it, is that always an option that we will have to treat?
No, that's a very good question, and it's quite common on the Twitter quiz as well. That remember, ECMO is not a panacea, and it's not available everywhere. So this child has a significant airway obstruction and significant superior vena cava obstruction. The importance of the latter is that most ECMO centers, pediatric ECMO centers, use the big thoracic vessels to cannulate. So if you don't have good flow in those because they're compressed by an external mass, then it will be a no-go area. So there's occasionally capability to use femoral vessels for ECMO. That depends very much on the size of the child and local expertise. So femoral might be a possibility. In terms of how do oncology kids fare on ECMO, the stats are pretty dire. So ideally, you need a tumor that is likely to be responsive to chemo, so a tumor with a good prognosis for the child to be eligible for ECMO at the first instance. But also we know that if a child has a reversible airway obstruction, then that is one of the main indications for putting these kids on ECMO. A lot of kids initially, when they started ECMO on chemo patients, died on ECMO, and that's probably one of the worst ways to go. So it does have a place. It can save the day, but it's certainly not a panacea.
Yeah. Okay. And there was also questions about the use of steroid.
So I highly doubt there's any oncologists listening in. But I've had this discussion amicably with a number of oncologists in real life settings. So oncologists feel there's a role for steroid, but they like to postpone it as far as possible because it affects the biopsy results, and it affects what they see and how correctly they make the diagnosis in the first instance. But when you have a child like as sick as Hermione, which was in the presentation, my argument is always this child had impending airway obstruction. So if it's a choice between getting a definitive diagnosis in the post-mortem or a delayed or even no diagnosis without a live child, then it's an easy solution to me. So I would always back steroids if a child is as sick as Hermione, because remember, even if it shrinks the tumor by a tiny amount, by 5-10%, that will improve laminar flow immeasurably, exponentially. So it might just give us the time to manage her appropriately, or even transfer her to an ECMO center if needed.
That option. That's great. Thanks, Costas. Any other panel, any comments or questions before we move on to the next talk? No. Okay, in that case, I'll maybe hand over Chris to introduce our next speaker.
Okay, thanks very much, Costas. So our next speaker is Mr. Conor Jackson, who's one of our paediatric ENT surgeons in Belfast, and he's going to be talking about front of neck access in a paediatric airway emergency, tips from an expert.
Good morning, my name is Conor Jackson. I'm a paediatric ENT surgeon working here in Sick Children's Hospital in Belfast. I've been asked to chat today about front of neck access in a paediatric emergency patient, and obviously that's a difficult subject. The one bit of the title I wasn't particularly happy with was tips from an expert. And usually it's a good thing to be an expert, but in this scenario, I'm going to explain why I hope that I don't see this type of scenario very often, and that there are some things we can do in the assessment of children and in their management to hopefully avoid those really critical episodes. So I suppose my disclaimer today is that I am not an expert, and I'm thankful about this. But why am I talking to you about it? Because as a paediatric ENT surgeon, we do deal with difficult airways on a regular basis. This is a video of a young baby who is in theatre, obviously. I've got my really skilled anaesthetist at the top end of the table, and it's obvious that she's in some airway distress. We can see pectus, we can see her working hard. There are lots of lines and tubes coming in and out of her. But on the whole, we're pretty relaxed. We're doing all those simple things that you'd want us to do in that sort of situation. She has a bilateral vocal cord palsy, but we're able to oxygenate her, and we're able to control the situation. The good thing for the majority of us working in paediatrics is that really critical paediatric airway emergencies are incredibly rare. For all you clever guys, I have got a reference in my talk, and this is from a study that was done in Melbourne Children's Hospital over a period of around 4 years. They looked at all the emergencies that were coming into the unit, and they found that this happens through A&E about once every 2 months, so pretty infrequently. And the vast majority of all of those cases, whether they be foreign bodies in the airway or trauma, were managed with simple APLS measures. So what might we see when we talk about children's airway emergencies? The obvious ones are foreign bodies, which are inhaled. Then we've got inflammatory conditions such as croup. This x-ray shows a little metal ball bearing which had been aspirated into the left main bronchi. There can be cases of trauma, either laryngeal trauma, although this is pretty rare in children given their anatomically high larynx. But we've got a case later on where we do demonstrate some significant trauma and how we might deal with that. Other cases that might be a bit more common, post-tonsillectomy bleeds, and as part of that they can clot, and that clot may be aspirated, and that can be a very significant and difficult situation to deal with. Kids being kids, actually a lot of these cases are not going to have textbook answers. Kids are annoying and they do silly things. This is a picture of a 3-year-old boy who was brushing his teeth and came in with the toothbrush embedded in his left cheek. He just told us that he brushed his teeth incredibly hard. It was only a couple of weeks later when his sister owned up to pushing him off his stool in front of the sink. Any of these traumas or unusual things that involve the tongue, the lips, the oropharynx or penetrating injuries have to be dealt with in a slightly different way. Blood can complicate these views, and because they are unusual, there isn't a protocol to deal with them, you do have to have a framework on which to base your management. So, when thinking about this talk, it is unusual for us to have to do front of neck access in an emergency. So what scenarios might there be that I've encountered or that could be theoretically encountered by any of you guys? So foreign bodies which rest in the larynx are particularly difficult to deal with. The larynx is incredibly narrow in the paediatric population, and if something occludes that completely and sticks there, it's usually a very difficult situation very quickly. We have had incidents where there's a foreign body in the larynx which is very thin, such as a leaf or a sticker, and they may present with some symptoms but not be critical. Unfortunately, if a child aspirates and the larynx is occluded, say choking on a sweet or a sausage that doesn't move, those patients unfortunately often don't make it to accident and emergency. Other patients who might have swelling of the lips and tongue would be anaphylaxis. And part of my job as a paediatric ENT surgeon would be to deal with lots of congenital anomalies. This is a very fancy fetal MRI scan. And what it's showing is that the fetus here has a complex congenital venolymphatic malformation involving the cheek, the jaw, floor of mouth, tongue and neck. So obviously this is going to be a very complex condition to deal with, and we need lots of planning put in place before the birth, and maybe even something like an exit procedure, which is an ex utero intrapartum treatment whereby the baby's partially delivered. We deal with the airway whilst on maternal placental circulation. Other conditions such as Beckwith-Wiedemann syndrome, where they have a large tongue, may present with acute airway obstruction in the neonate. Our treatment of that is usually a flexible nasal tube. Historically, the big group of patients who required this front of neck access were epiglottitis patients. Thankfully, since the advent of the Hib vaccine, this is really not seen on a regular basis. So, when considering this group of patients, essentially there has to be a high obstruction with potential for normal trachea beyond the obstruction, and that's a very narrow group of patients. So our main issue when dealing with all of these patients is that they have airway compromise, and really simply the solutions are to oxygenate and secure an airway. Our acute management of these conditions should be along the APLS principles, and the biggest take-home message I have today is that it has to be a team-based approach. You have different skills, everybody has something else to add, but really the key guys are anaesthetists who may be in the hospital, intensivists, paediatric nurse specialists, paediatricians, and also an ENT surgeon there if required. They can augment the A&E experience if a patient is coming in via that route, or often via the neonatologist in the neonatology unit. Initial assessment is quick. This is often an emergency situation. By the time ENT get phoned, there's often a fair bit of panic and distress. Often our first question is, have you contacted the anaesthetist? Who else is going to be there? We want to get as many hands available as possible, as much expertise in the room. So we'll ask for other people to be alerted and to come in whilst we're making our way there. For anybody who's on the ground, we ask them to listen to the chest. A silent chest is particularly worrisome. We'll ask them to look at chest movements, respiratory rate, and also respiratory effort. First things first are to try and establish an airway. And really simple measures would be chin lift and a jaw thrust, bag and mask ventilation. If required, an airway adjunct such as a nasopharyngeal airway work really well and are simple to put in. Once the bag mask is ongoing, we'll give high flow oxygen and think about some medications. Those can be steroid treatments or adrenaline in the case of anaphylaxis. The next step, if that isn't working, or if there's still jeopardy, is to consider an ET tube or a surgical airway. So when we consider this, ET tubes are our best weapon. To get this done, I like to use a Miller blade. I'll have suction available. I'll have a selection of tubes, age appropriate, but if it is tight, such in the case of a difficult croup, then we might want half a size smaller. The tube can be loaded over a bougie to make it stiffer, but in ENT, our little trick is often to remove the connector from the ET tube and then load the tube over a rigid endoscope. This can then be placed under direct vision through the cords, looking at any pathology on the way, and then the tube slid off and the connector replaced, connected up to the ventilation circuit. This is not a baby, this is a rabbit. But what happens when things are going badly? Sometimes these measures just don't work and we are considering surgical access. When considering this, it's really important to understand that surgical front of neck techniques are a last resort. Death is imminent. It's a can't intubate, can't ventilate scenario. If ENT are not around and you have a blue child and nothing else will do, that is the scenario to consider this. But it's important not to feel that you're alone. My advice is always, and if I'm doing this, my advice is always to ask everybody around the room, can you think of anything else? Do you agree with the plan? And once everybody agrees, and it's time critical, try and get on with it as soon as possible. This is the slide that surgeons love and nobody else does. The picture on the left is really there to show that there is a lot of important stuff in the neck. And my advice would be to clear your mind and try and forget about just about all of it. This is a life-saving procedure. The most important thing is accessing that trachea. It runs in the midline. There is less important stuff in the midline than laterally. So my advice when doing the procedure is to stick midline at all times. The picture on the right is to try and reiterate that the child's airway is different than the adult's. The neck is shorter and therefore we have to do our incision slightly lower down. The larynx is hidden a bit higher up and this protects it from trauma. Tongue is bigger proportionally, so there are some elements that you need to pay attention to. What methods can we use? So probably the simplest method out there, which might buy us a bit of time, would be a needle cricothyroidotomy. And APLS will recommend that this is performed from around 5 years of age onwards. Other guidelines have suggested around 8 years of age. It allows us to provide oxygen, but not to ventilate. If we're going to do this, it's approach the patient from above, as in the picture of the mannequin here. A 5 ml syringe is loaded onto an 18 gauge cannula, and this is inserted at a 45-degree angle inferiorly, whilst aspirating in the midline, looking for some air, and that gives us the idea that we're in the airway. It's passed through the cricothyroid membrane, and in an emergent situation, I do understand that this can be complicated, and there may be a bit of doubt in your mind, 'cause it's not always particularly easy to feel in children. If you're looking for a spot, usually 2 centimetres above the sternal notch is a good starting point. Once it's in, you confirm its position. Some people have recommended having some saline in the syringe, that bubbles can be seen on aspiration. And once you've seen that, you want to attach the oxygen directly to the end of the ventolin. Percutaneous trachea is more often seen in adult practice. It's really not recommended unless you've got a much older child. It's really only suitable for the over 12s. You often need quite a bit of pressure, and that can cause damage to the underlying airway in very young babies. The procedure is the same as we would use for adults, and if you've already done a needle cricothyroidotomy, that technique can be converted. But on to the main event. So tracheostomies are performed by ENT surgeons on a very regular basis, but these are usually under very controlled conditions, and they differ completely from an emergency procedure. The good news is that ENT docs are usually fairly kind, and they have an emergency tracheostomy set, usually in clear view in theatres at all times. So if you think you're going to require one, get someone to request the trachea set, and there will be a tray delivered with all that you might need on it. It's important to get the positioning of the patient right. This is an Albert chin strap, so basically tape goes round the chin and secured to both sides of the bed, and that, along with a shoulder roll, gives you good access. Lignospan is probably not going to be of benefit in the real emergency, but if you have time, it's much more pleasant. You don't want to use too much because it can sort of disrupt your view. You want to make sure that you have a tube available. If there's no trachea tube there, an ET tube will do as a temporary measure. So, in terms of what we normally do for tracheostomy, we define anatomy using skin markings first. We use a vertical incision in the emergency. It's usually positioned around 1.5 centimetres above the sternal notch. The key aspect is to stay in the midline. This keeps you away from other important structures such as the big blood vessels. And to do this, I often put a little small mark on the chin, small mark on the sternal notch, just to make sure I don't start to deviate when concentrating on the dissection. I wouldn't encourage you to drape because this can distort your view, and the anaesthetist needs to be able to see this baby as well. So as I mentioned, a vertical incision using a 15 blade. Underneath the skin there'll be a small wad of fat. We take this usually, but in the emergency it would be straight down using blunt dissection in the midline. I would encourage palpation as often as possible. You're feeling for those little rings. Once you identify the trachea, it can be difficult to identify which rings are which, but we usually recommend between the 2nd and 4th. The incision again will be in a vertical plane, and once you have identified the trachea, made the incision, and suctioned away any secretions, your tube can be inserted. This is a tracheostomy tube. When ENT put this in, we will confirm that there is a CO2 trace. It's also really important to hold this tube in place manually to make sure it's not dislodged accidentally until it's secured with some tapes. And then you can have a beer for a job well done. So, having discussed the procedure, it sounds quite daunting, and we know that we're not going to see this on a regular basis. So how can we gain the skills required in order to familiarise ourselves with a difficult procedure in an extremely difficult and challenging scenario? My recommendation is to use simulation. I know it's a hugely important topic at the present time. I am one of the faculty in the Paediatric Airway Management course, which is run between Boston Children's and the Royal College of Surgeons in Ireland every 2 years in Dublin. They have world-class facilities and high-fidelity models, which makes practice easy. These are some simulation models provided by TrueCorp. This equates to about around a 5-year-old child, and anatomically we can use replaceable parts which give really good experience in terms of how to feel for the cricothyroid membrane, how to orientate yourself, and how to do the procedure under stable circumstance. So I've got a few cases here which describe when we might have an airway emergency and what steps we might do to secure the airway. This is case 1, which is a recent case, a 4-month-old child with Goldenhar syndrome, which is hemifacial microsomia, and a cleft palate, had significant sleep apnea. They also had significant cardiac history, which needed a procedure performed in a different hospital. Before that procedure, we were asked to perform bronchoscopy. So these were the CT scans that we had reconstructed beforehand. This demonstrates the right side of the face is small, the TMJ is dysfunctional, they have micrognathia, and this is where my advice would be: try and put a good plan in place beforehand. Before her procedure, we discussed the case with our consultant anaesthetist and agreed that we would need 2 consultant anaesthetists in who have got airway experience. We got the difficult airway trolley out, and we had a tracheostomy tray standing by. These are some other scans of the patient. So we can see in the top right of the picture the small jaw. The scan on the left shows large tongue, small short neck, narrow airway. It really wasn't good to start off with, and unfortunately when she was put to sleep, we attempted to spray the cords. There was a grade 4 view, so no view of the larynx whatsoever. She also had a macrostomia, which is a gap between the lips on the right hand side, so bagging was very difficult as the mask couldn't create a good seal. Whenever we tried to perform jaw thrusts and chin lift, her jaw was fixed. So all of these meant that her sats dropped and we couldn't tube her. We were in a can't intubate, can't ventilate scenario, and we discussed options. It was felt that we should proceed with an emergency tracheostomy, and this was done within 5 minutes. The anaesthetic gases were simply piped into the patient's mouth, and the tracheostomy will remain for the foreseeable future. These were some live pictures of me during the procedure. We obviously don't have videos of those really difficult airways because it's kind of frowned upon videoing that sort of embarrassment. So case 2 is a 4-week-old girl in a different country. Mum unfortunately had some postnatal psychosis and at home tried to decapitate the baby. She cut across the whole neck all the way down to the vertebral body. This was a hugely distressing case for all involved, and Dad rushed the child to A&E, and the initial management was very difficult. There was a lot of blood. The plan at that stage was to intubate directly through the neck. So an ET tube was placed into the open trachea, cuff was inflated and airways was secured while they were transferred to a different hospital. And the child did very well. The ET tube was changed for a tracheostomy by the ENT surgeons in theatre, and at 2 years of age, the only repercussions she had of this were bilateral vocal cord palsy. These are a series of pictures starting in the bottom left corner of her bilateral vocal cord palsy, and this is how we would manage these ENT patients. So we spread the cords, incise through the cricoid ring, and the middle picture at the top shows us inserting a rib graft posteriorly, and the one on the top right shows glue squirted over this. A tube was then placed for a week, and this next video shows when we took the tube out how things look after a week, and it demonstrates that she has a good wide subglottis, and she was able to be decannulated following this. So this is the third case. This is a 20-month-old child who had been experiencing and diagnosed with recurrent croup on an increasingly frequent and severe basis. They had attended accident and emergency and had been referred as an outpatient to ENT. We like to see patients after the third bout of croup and pay particular attention to kids who are getting worse over time with increasingly frequent bouts. In the meantime, the child went for a routine urological procedure, and at the time of induction they were unable to pass a tube. This video shows what ENT saw when they were called to the patient. It's a bronchoscopy which identifies an extremely narrow airway due to laryngeal stenosis, which was congenital. This child had been breathing through a hole up just less than 2 millimeters and was obviously having difficulty at home, but this was worsened whenever they had their induction. The management of this patient was to have bag and mask ventilation and be transferred in an ambulance to a specialist hospital where we performed tracheostomy the same day on a planned emergency list. The longer term plan for this patient was that we did an elective laryngotracheal reconstruction, which means opening the neck, doing a laryngo fissure and putting a rib graft at the back of his larynx and at the front, securing these and putting a stent in. And this video shows the stent being removed after 3 weeks, hopefully to reveal an excellent airway. This patient was then able to be decannulated from the tracheostomy at 3 months. This fourth case, I suppose, is an excellent example of airway, foreign body, and how to manage them and how they can be extremely difficult. It's often a bone of contention in terms of the management of patients who come to a peripheral hospital, whether or not the airway, foreign body should be attempted to be removed there or they should be transferred. And if they're transferred, how does that happen? Should they be intubated? Should they be put in an ambulance? Should they go in their own car? So this 9-month-old, without a great history of a possible foreign body, developed some stridor. They attended a peripheral hospital, and Dad wanted to bring the patient directly to the specialist centre. I think this video shows just how difficult a tracheal foreign body can be. As we move down, we can see that there's a jumbo peanut obstructing the entire airway just above the carina. In these circumstances, if the child is attempted to be intubated, that's not going to work, and you can make a very bad situation much worse. The recommendation was to put the child into an ambulance along with an anaesthetist and bring them straight to theatre in the specialist hospital, where we were able to remove the foreign body using optical grasping of forceps. I have helpfully edited out the 2.5 minutes of panic with SATs of 25. The patient did very well and was fit enough to go home the next day. So I suppose my take-home messages today are that surgical access to the anterior neck is an absolute last resort. It should be done as a life-saving intervention. Before that, get all the expert members of the team that you can involved and manage these airways as you would in APS guidelines. I would welcome any questions.
Thanks very much, Conor, for that great talk. A lot of scenarios that I suppose most of us hope we never find ourselves in, but good to have a sort of structured or practical approach or some sort of knowledge of what to do if situation arises where we had to act. We have a few questions coming through in the chat. I suppose just as a bit of a plug, we are trying to sift through the questions and pick some out. So I noticed with Costas' talk at the start, there was a lot of questions came through in the chat right at the very end. So if we could try and get them coming through as the speakers are talking, that would be great. And it allows us to cherry pick them, and there's more chances of them getting selected to be asked. I suppose we'd like to start, Conor, just asking you, going back to Costas's case and the mediastinal mass. From an ENT perspective, I assume you'd like to be involved early in that sort of scenario. And have you any comments about the approach and whether you would do anything differently, or any key elements to the management that you can think of from your perspective?
I suppose absolutely we want to be involved as early as possible in these cases. If there's a mediastinal mass and there's potential for airway obstruction, particularly in those kids who when they lie flat or obstruct, we like to be there to offer help and support. Management is from Costas was brilliant. If ENT are involved and the airway is really compressed, sometimes what we can do is get one of our rigid bronchoscopes in terms of securing the airway. That allows us to pass, and because it's firm, more rigid, we can move any external obstruction out of the way. And sometimes that can be what's required to stabilize the child, and then swap that for a bougie, and then put the tube in over the top, railroad the tube in. So we do like to be involved. We think we've got something to add.
Yeah. Grand, perfect. Thanks, Chris. And I think, Tudor, you picked up on a question about the thymus.
So Justin has asked, does the thymus cause problems as you are performing the procedure?
Not
doing front of neck access.
It's often thymus is a consideration in a very young child. Obviously, it shrinks down reasonably quickly. It's usually very soft, and you retract it out of the way. It doesn't need to be. It's not a physical thing that you need to dissect out. You can just push it out of the way. And whenever you see an ENT surgeon doing a tracheostomy, literally they've got their finger in, having a palpate for those tracheal rings multiple times. And what we do is get somebody with a retractor in and pull down, and that retraction will move that thymus out of the way. But if they've had a chest X-ray beforehand and get the chance to have a look at it, can seem intimidating. But if they're an airway emergency and you want to proceed, it usually doesn't complicate matters too much. We would sometimes perform those exit procedures and a tracheostomy within minutes of birth, and it doesn't really present us with too many problems. If you've got a bit of enthusiasm and a strong wind behind you, you kind of forget about it.
Thanks, Conor. And I think there's a question coming through, James Yates, on age and whether your approach varies with age. And I know, Chris, you had something along those lines that you were wanting to ask.
Yeah, I suppose from a non-airway expert, surgical airway expert point of view, what would you expect us to do, and does that vary from age? Really looking at cricothyroidotomy versus tracheostomy, and particularly looking at the neonate. I think there's a lot out there for a bigger patient or an adult, and the approaches are fairly clear. But if I suddenly had a 3 kilo baby, no ENT surgeon about, and needed to do a surgical airway, what would be your recommendations? And then I suppose any tips you would have for us doing that?
I think the tip is that you want to stay in the midline, and with any of these techniques, the important clockwork, the blood vessels, the nerves are off to the side, and it's much easier than you imagine to stray, especially in a neonate. Their trachea is very small. It's often external diameter, less than a centimeter, and so in the very young kid, if you've got a Venflon that you can try and put in, if you stick in the midline and you're aspirating, particularly if you've got a wee bit of fluid in the syringe, you can, once you see those bubbles of air, you know you're in. I think that is what buys you some time, and allows you to think about other options prior to doing the tracheostomy. Things like percutaneous tracheostomy, not really an option in that age.
Okay, so that would be a needle procedure rather than a surgical procedure you'd be recommending?
Well, if you depends what kit you have. If you've got a needle there, that's available in most rooms. If there's a trachea kit and the kit and you've got 5 minutes, I think that's the way to get a definitive airway, because that needle will need transferred to be a trachea fairly quickly. And if you're an hour away from a hospital, I think go for the tracheostomy.
Okay, perfect. But certainly if ENT's on their way in, the needle to buy time to
buy
get there would
some time.
be the preferred option. Okay.
Thanks, Conor. I think we've probably time one more question. Gavin Tunnard has just posted foreign body at the Creanus scenario, as long as an emergency medicine doc in a rural non-ENT hospital is advancing the foreign body into the right main bronchus, a last Hail Mary option.
Absolutely, and in that last case with the peanut, one of the whenever the stats started to drop, my initial thought was to push that foreign body down deeper. That's sort of counterintuitive, but if both lungs aren't ventilating, it's much preferable to have one lung that is. So push it down either of the bronchus and get the child saps up, and then go after it again. I think that's a great shout. It is tricky to do. It may be pushed down with a tube if you don't have a bronchoscope, and if you don't have a bronchoscope handy, I think that's the tricky bit.
Yeah. Grand. Thanks, Conor. Well, listen, in the interest of time, I think we probably need to move on to the next talk. If we can just encourage us again to post the questions through as the speakers are talking, that would be great. And I'll hand back over to Chris to introduce the next speaker.
Okay, thanks very much, Conor. So our next speaker is Dr. Peter Donnelly. He's a consultant paediatric intensivist over in Glasgow, and he's going to be talking about symptomatic hyponatremia.
Good morning, everyone. My name is Peter Donnelly. I'm a consultant paediatric intensivist based in Glasgow. I'd like to thank the organisers of this conference for inviting me to present a case focusing on symptomatic hyponatremia. So what I'm going to do is I'm going to outline a case of symptomatic hyponatremia, and I'm going to use that case to facilitate some learning and some discussion around emergency management, an approach to making a diagnosis using this particular case as a basis, and then we'll work towards solving the diagnosis for this case. So I'll start and get right into the case itself. This is a published case that's freely available, and it describes an 8-month-old child who is 6 kilograms in weight, who presents on day 3 of antibiotics being treated for a urinary tract infection. And you're also told that they have 2-day history of diarrhea and vomiting. Now, on this particular occasion, their presenting complaint is of seizures. You are informed that they have had 2 doses of midazolam before they have made it as far as A&E, and a resus call has been put out. So, as with all of these cases, we start with an initial assessment using an ABC approach. The first thing you notice when you arrive in resus from the end of the bed is that this patient is clearly still seizing. So that's the first and most obvious thing about the patient. With regards to their airway, they have a mask on, giving them 10 litres of oxygen. Their saturations are 100% on that. They have a respiratory rate of about 8. You don't notice any particular airway sounds, no stridor, no stertor. They're certainly not vocalizing. They look pale. Their capillary refill time is prolonged, around 6 seconds. Their heart rate is about 140, varying between 140 and 160. And their blood pressure is 82/61. They currently have a temperature of about 38.4. Their pupils seem to be reacting equally, but clinically you feel this patient is a little bit dry, a little bit dehydrated. The emergency department team have already cited 2 peripheral cannulas. You're told that they have sent off routine bloods, and they have performed a blood gas, which they hand to you as you arrive. So this slide describes the blood gas that you're presented with. The pH is 7.66, the PCO2 is around 6, the PO2 is 8, the bicarb is 49, and the base excess is positive at 22.8. There's also electrolytes provided on that gas. The sodium, surprise, surprise, for a case of symptomatic hyponatremia is 111. The potassium is 1.7. The chloride is 62. The blood sugar is 8.1. And the lactate is 2.1. So my first question to everybody listening would be, how would you describe this picture? How would you describe the abnormalities in this blood gas? This blood gas shows a hyponatremic, hypochloremic, hypokalemic, metabolic alkalemia. And I have put the patient's blood results there on this slide alongside the normal range just to indicate where the abnormalities are. So there are a few key points before we go further regarding hyponatremia. Firstly, how would you define it? Well, hyponatremia is defined as a serum sodium less than 135 millimoles per litre. In paediatrics, most children with a sodium greater than 125, they're usually asymptomatic. But as it falls, they become increasingly symptomatic. And usually a sodium less than 120 will present with features such as headache, lethargy, and, as in this case, seizures. So let's move the case forward and think about how we're going to start and initiate some emergency management for this case. If we thought about that airway, as I mentioned earlier, the saturations are 100%. They're not making any particular added sounds, they're not vocalizing, the respiratory rate is 8. So what do we want to do about this patient's airway? We probably have a couple of options here. We could intubate them and ventilate them. We could do nothing and accept that we're happy with how they are right now, but we're going to keep a close eye. We could support their airway, give them a little bit of positive end expiratory pressure with a mask and a T-piece. Are we going to call for help, get some more senior input? What would you do in this particular circumstance? I'll tell you what I would do. My approach would be to support the airway, to give some positive end expiratory pressure, to ask for assistance, and to start thinking about how I can manage the underlying problem. Why have I done that? Why have I not gone ahead and intubated this patient? Well, intubation is not without risk. Every patient is a little bit unknown when they first present and they've never had any airway instrumentation before. This particular patient has got abnormalities in their blood gas, and they also have abnormalities in their electrolytes. That adds additional risk to giving this patient any anesthetic agents and to performing any airway procedures. As you know, when a patient has a metabolic alkalemia, they will try to compensate for that by letting their CO2 rise, trying to balance out the acidity levels with the alkalemia. So the question would be, when you give this patient an anesthetic, how easy will it be for you as the intensivist or as the airway practitioner to try and match that patient's own response? And I think it's really important to always remember, a lot of the time what we see is a patient having a physiological response to pathophysiology. If we start to interfere with that, it is not difficult for us to make things worse. And you see this with conditions that result in acidemia, such as DKAs. If you intervene and perform airway procedures, there's high risk that you can't match what that patient is actually trying to do for themselves. So I would think very carefully about performing an airway procedure on a patient like this and giving them an anesthetic. There is a caveat to that, in that if they are unstable, if their airway is not maintained or you're concerned about it, or there is hemodynamic instability, then you may indeed have to go and intubate and ventilate this patient. And in this case, although I'm not ventilating them now, I may need to as the case progresses. So I'm thinking, I want to stop this seizure because I'm concerned. How am I going to do that? Now, there are a number of medications that we can think about, and this is not an exhaustive list, but I want you to think about what you would like to give as your first agent to try and stop this patient's seizure. Do you want to give them some glucose? Do you want to give them some Keppra, some levetiracetam, some hypertonic saline, some phenytoin, maybe some phenobarb? Do you want to give them another dose of a benzodiazepine, maybe try lorazepam or more midazolam? Do you want to give them paraldehyde, or is there another agent you want to give them? And I want you to think about that. We're reflecting all the time back on our ABCs, and we've made a plan for our airway, and we're happy with our saturations. Cardiovascularly, if you remember, I mentioned that they were a little bit on the dry side, a little bit tachycardic, a little bit cool peripherally with a prolonged cap refill time. So you're going to want to give this patient some fluids. So you're thinking about fluids in terms of managing the C at the same time that you're thinking about stopping the seizure, which falls under D. So I would also question, is there any option that you can give that might try and address both of those issues? What would I do? My approach would be to give this patient hypertonic saline. What does the evidence say about doing that? Well, The evidence suggests that hyponatremic seizures may be refractory to anticonvulsants. For hyponatremic seizures, usually an increase in sodium of between 3 and 7 millimoles per litre is enough to terminate a seizure. A standard dose of 3 mils per kilo may actually be enough to increase your sodium by 2 to 3 millimoles per litre. And a lot of people will have concern about correcting sodiums because rapid correction can result in osmotic demyelination, central pontine myelinolysis, and these present as quite significant irreversible neurological morbidity. So there's understandably some concern, but my approach would be to use hypertonic saline to try and correct the underlying problem of the seizures, and that has the additional benefit of also providing some fluid resuscitation for the patient. So how much hypertonic saline do you want to give? Well, most places will have their own recommendation, and usually it's based on either published evidence or published guidance. And the first caveat to whatever you do, given that you're concerned about rapidly correcting sodium, is to note that the risk of morbidity from delayed treatment is greater than the risk of any osmotic demyelination problems from an overly rapid correction. Seizures are not good for the brain, and it's really important that we try to treat the underlying problem. So what I've included here is a treatment algorithm from the Department of Health. Again, this is freely available from the Paediatric Emergencies app. And it suggests giving 2 mils per kilo as your initial fluid bolus over 10 minutes. And if the patient remains symptomatic, to repeat that and give another 2 mils per kilo over 10 minutes. And if they remain symptomatic, to give a third bolus dose. If they're still symptomatic after 3 doses, it suggests that you reconsider the diagnosis. Now, there are different volumes suggested in different guidelines, and they can vary from the 2 mils per kilo you see here up to 7 mils per kilo. It depends what guidance you're following, but they all would suggest giving it in 10 to 30 minutes, roughly as a duration. Once you've corrected that, you also need to then think about, I don't want to correct the sodium too quickly, so how quickly should I then correct it once I've dealt with the acute side of things? And this algorithm quite clearly says that for the first 48 hours, you want the maximum rise in your serum sodium of about 20 millimoles per litre. Most guidance will agree roughly with that and suggest that in 24 hours, you want your serum sodium to have risen by 12. So approximately half a millimole per litre every hour. This slide shows another guideline, and this was taken from the Royal Children's Hospital in Melbourne. And this is a quite nice diagram because it allows you just to follow, using this flow chart, how you can manage your patient. And you can see from this chart that it starts off with, does your patient have seizures or encephalopathy? And of course, in this particular case, relating it to our case, they do. So this immediately puts them into the right-hand side of this diagram. So let's focus on that for the purposes of this case. This is a medical emergency. Let's make that clear. Contact ICU urgently. So you'll note earlier, one of the options was calling for help. So this guideline makes it very clear that we should be doing that early. They suggest giving 3 to 5 mils per kilo of 3% saline over 15 to 30 minutes. Measuring urea and electrolytes, they suggest that you correct the sodium by no more than 2 millimoles per hour in the first 3 to 4 hours. So roughly increasing it by 8 in 4 hours. So that's significantly faster than the chronicity with which you want to raise your serum sodium after the seizure has terminated. And that's very clear in this flowchart. You move on then to the question of, have your seizures terminated, or is the sodium risen to greater than 125 millimoles per litre? And if it has, you're then into the realm of slow sodium correction. And again, this suggests 12 millimoles per litre in the first 24 hours, with careful 4-hourly lab monitoring. My personal approach in cases like this is to do your lab bloods every 4 hours, but I would supplement that with doing blood gases every hour initially to track my sodium rise. And as I'm happy with what I'm doing, I can space that to 2 hourly. But I'd be very, very careful about monitoring this sodium level closely. What about maintenance fluid? We've talked a little bit about how we manage the initial presentation with hypertonic saline and how we try to get that fast initial rise in sodium followed by a slower rise. But how do we achieve that slower rise? What maintenance fluid do we want to give to our patient? And again, as with anything else, there are options. Do you want to continue a hypertonic saline infusion? Do you want to use 0.9% saline? Do you want to use balanced solutions like Hartmann's or Plasmolite? Do you want to use albumin, or do you want to use something else? And I would let you think about that for a second. What fluid would you like to use in your institution? And then when you think about what fluid you want to use, then how much do you want to give? So again, there are options. Do you want to give this patient full maintenance fluids plus a deficit because you think they're clinically dry? Do you want to just give them full maintenance initially? Do you want to restrict them a little bit to 2/3? Do you want to give them half maintenance? What do you want to do? What would I do? My fluid of choice for this patient is 0.9% saline. And the reasons for that are because this patient is low in sodium and low in chloride. So this is an appropriate fluid to use in this particular circumstance. There are intensivists throughout the country, throughout the world, who are keen advocates of balanced solution in favour of the acidemia that you might get and the renal impairment you may get from using lots of 0.9% saline. That differs between the intensivists that you speak to, but those who prefer balanced solutions would largely be in agreement that in this particular circumstance, 0.9% saline is actually the fluid of choice. In terms of deciding what rate you want to run your 0.9% saline at, there's a few considerations that you might want to think about. The first is the clinical status of the patient. We know they're a little bit on the dry side, but what do they actually need in terms of fluid? What we fundamentally want to achieve is a safe and steady rate of rise in their serum sodium. So my approach to this would be to calculate out this patient's deficit and maintenance requirements. Their deficit in terms of their sodium can be calculated using the equation on the slide. 135 minus our patient's serum sodium times 0.6 times their weight in kilograms, and that will give you how many millimoles of sodium you want to give them to replace their deficit. You then want to consider what their maintenance sodium will be. That is largely 2 to 4 millimoles per kilo. If they're an older child or slightly bigger, I'd be keen to start that at 2 millimoles per kilo because their requirement is slightly less. So what you can do is work out maintenance fluids over 48 hours, 2 millimoles per kilo per day, and then add on your deficit and calculate out how much sodium you want to give this patient in the first 24 and subsequent 48 hours. Then, because you have decided to use 0.9% saline, you can look at the bag of fluid, you can see how many millimoles of sodium are in each bag, and you can calculate out in a 24-hour period and in a 48-hour period, how many mils of this fluid do you want to give them? And that can be adjusted to give you your mils per hour hourly rate. And that's how I would approach my starting point to how much fluid I'm going to give this patient. The subsequent rate and how you adjust that depends on the rate of sodium rise. So what's really important is that we have recognized that this patient has got deranged biochemistry, and we need to take an ACR approach, act on it, check it, repeat it. And we need to continually do that. We need to check that we are happy that we are achieving a rise of 0.5 millimoles per litre each hour. We don't want to overshoot it because of the complications that we might get from that. So you can adjust your rate of fluid up and down depending on what your sodium's doing. And that's why I would be keen to do blood gases hourly initially, just to make sure that I'm being as safe as I can be. Okay, so for our case, the seizures have stopped. You have replaced their electrolytes in that you have got maintenance fluids going. You have tried to optimize their other electrolytes. If you remember from the initial slide, the potassium was also low. So you've added that onto the fluids and you're watching that carefully. And there are ways to replace potassium in a faster and safer way using a peripheral approach or using a central line. I'm not going to go into those for the purposes of this talk, but they also are included in the Paediatric Emergencies app. So you're happy, congratulations, you've managed through this acute event, but we've got some more thinking to do. Hey, How are we going to find out what is actually going on with our patient? What's our approach to making a diagnosis? Well, fundamentally, if you look up most textbooks, look up online, most approaches to making a diagnosis about the etiology of hyponatraemia center around clinical assessment of the hydration status of your patient to help guide you in a direction. So that's something that I think is really fundamental. And what I've included here is an excerpt from Harrison's Manual of Medicine. And it does exactly that. It tells us to assess our patient's volume status to point us down which direction of the flowchart we want to move in. If you remember again, our patient was tachycardic, peripherally a bit cool, prolonged cap refill time. We thought clinically they were a bit dry. So that puts us into the hypopholemia side of this flowchart, which is on the left. So let's move to that. So we're hypovolemic. We have a reduction in total body water, but a more pronounced reduction in total body sodium, which is why the overall sodium concentration has fallen. Now, this textbook suggests that we should then look at the urinary sodium, but unfortunately that can take a little bit of time to come back, certainly where I work. So we'll park that for the moment, and we'll just have a look at these differentials in terms of what the diagnosis might be. So we might be losing sodium from extrarenal losses, vomiting, diarrhea. That was certainly evident in our history. And burns, pancreatitis, trauma, or it could be renal losses. Is there a renal tubulopathy? Have we got some mineralocorticoid deficiency? Have we got cerebral salt wasting? There's a number of potential diagnoses here. And I think it's worth us thinking about what do we think is likely, what do we think is not likely, how would we prioritize our list? And this is my thought process on this one. Could it be a tubulopathy? Absolutely it could be. I don't really have enough from the story to say definitely not or definitely yes as yet. Could be Barter's, could be pseudobarters, could be Gittelman's. Those are all options. In terms of the non-renal losses, thinking about burns or trauma, well, there's no history of that, so I don't think that's likely. Vomiting and diarrhea, I don't believe that. You know, 2 days of vomiting and diarrhea to have such a profound effect, that to me seems unlikely. I can't totally discount it, but it's not high up on my list because I think it's just the clinical presentation is so severe unless there's something else going on. Diuretics, patient isn't on any diuretics. Cerebral salt wasting, well, we can say that this patient had a prolonged seizure. Let's assume that they've went through a CT scan. As far as you're aware, there are no intracerebral lesions of any description. You don't think that's likely. Could it be a chloride-losing enteropathy? Could be. Could it be something else? Absolutely. It can always be something else. So although you're trying to tick some things off in terms of likelihood, always remember to keep an open mind, just in case you've got something wrong, just in case there are other things confounding your clinical assessment of the patient. You may need to revisit this. So what is at the top of my likely list? I'm thinking, is this a tubulopathy? I'm thinking, could this be a chloride-losing enteropathy? Does this make sense? It's quite a severe presentation. So I'm thinking, I am only an intensivist. I need somebody smart. I need somebody intelligent that's actually going to help me work this out. I'll support their organ systems, but maybe some extra brains on this would be really helpful. So I want to phone somebody. And just as I go to phone a friend, my phone rings, and it's one of my trainees. My trainee says, I sent off some bloods and they've come back. And the urinary chloride is low, the aldosterone level is normal, the renin is high, ionized calcium is low, the ammonia is 82, and we did an ECG that shows a long QT interval. What does that mean? So at this stage, what do I want to do? I absolutely want to phone a friend right now because I've just been given all of these complex renal investigations I have to try and put into some sensible pattern that would explain what's going on here. So I want some extra brains. So I ring one of my friendly nephrology colleagues because I said to them, I think this sounds renal to me. I've got renal investigations sitting in front of me. They're abnormal. Can you help me put them into some sort of context? So your friendly nephrologist is on their way down, but you're thinking to yourself, what can I do until they arrive to try and figure this out? Take the challenge. So there's a couple of papers that are quite useful in this scenario if you do think it might be something renal. And one is called Approach to Renal Tubular Disorders, and one is called Barter and Gittleman Syndrome's Questions of Class. And what's really nice about these papers are that they go through a diagnostic approach to try and help you determine whether it actually is one of these disorders or not. So for example, they include a nice table of features suggesting that you're on the right lines here. This probably is some sort of tubulopathy. Do they have growth retardation or failure to thrive? Do they have polyuria, polydipsia, unexplained hypertension? And actually, that shows that it's really important that we go back and take a really full, thorough history for this patient to find out what signs and symptoms they may have had. And in terms of laboratory findings, I've circled a really key important one here, a metabolic alkalosis with or without hypokalemia. So that fits perfectly with the case that we've described earlier today. And again, in these papers, it has a really nice flowchart that helps us try and work our way down the list to find out what the potential diagnosis might be. So if you've got a metabolic alkalosis, hypokalemia, you want to fundamentally check the urinary chloride. And that will quickly determine whether you're in a pseudo-Barter's algorithm sort of side, or whether it could be something else. It could be Barter's, it could be Gittleman's, it could be hyperaldosteronism, it could be other things. So the urinary chloride is really, really important. And luckily, that was one of those investigations that your trainee had phoned to give you over the phone. So I've just put them into a table here just to try and help us delineate what our case is most in keeping with. Now, normally when you do these tables, it doesn't quite fit with what the textbooks say. There's something that's just not 100% as you'd expect, but it helps us narrow things down a little bit. So if we look at the metabolic alkalemia, yes, that's present in Barter's, Gittleman's, pseudo-Barter's, this case. Hypokalemia the same, hypochloremia the same. The urinary chloride is where things differ a little bit, and our patient had a low urinary chloride, which puts us down the line of pseudo-Barter's rather than Barter's or Gittleman's. Again, if you look through the table, the renin, the aldosterone, there can be variation in these things. And in our case, the renin was high and the aldosterone was normal, which might be a little bit surprising when you think that they were hypovolemic. So we'll come back to that. So just to be clear, when we look at this table, it seems like our patient is quite well in keeping with having pseudo-Barter's. So you think you've got it. You think you're happy. This patient has got pseudo-Barter's. But unfortunately, they don't have real Barter's, do they? So why do they have pseudo-Barter's? So we've got some more work to do. So what I'm just going to do is just recap some of the salient points of this case, just to try and point towards what the overall diagnosis was. So let's recap. The original story, this patient's weight was 8 kilos. Is that significant? What do you think? They presented with a urinary tract infection and subsequently had some diarrhea and vomiting. Diarrhea and vomiting isn't good for your electrolytes, regardless of what the diagnosis is. And in terms of the original investigations, they had a normal aldosterone. And I've already mentioned that's a bit surprising because the patient was hypovolemic. Why would they have a normal aldosterone? And they had a long QT on the ECG. Additional details that you then find when you speak to the family were that they weren't born in this country, so they haven't actually had their newborn screening performed. And when you ask a little bit more about the urinary tract infection, you find out that they're currently on trimethoprim for treatment. Now, when you look up trimethoprim, incidentally, that's associated with a long QT. So suddenly you've got something that actually makes sense. Okay, so we can explain that long QT. They also have faltering growth whenever you plot them. So when you plot their birth weight and you plot their subsequent weight that they presented at, they seem to be faltering a little bit. They've crossed centiles. So you're thinking we have something going on that when they have diarrhea and vomiting, their electrolyte loss becomes even more pronounced than you would expect. They haven't had newborn screening and they have faltering growth. Is this pointing you towards a particular diagnosis? Well, what are the likely causes of pseudo-Barter's? What are the common causes? And those papers I referred to earlier quite nicely list some. Could this patient have a congenital chloride diarrhea? Well, they've only had 2-day history of diarrhea, so that wouldn't be in keeping. Could they have laxative abuse? No story of that. Could they have cystic fibrosis? Yes. Could they have cyclical vomiting? They've only had 2 days of vomiting. So very quickly, we're starting to think, could this child have cystic fibrosis? And indeed, that is the underlying diagnosis for this case. And that was confirmed on subsequent testing. So I'd like just to finish just by mentioning a few key learning points for me whenever I reflect on cases such as this. And the first thing is that ventilating patients with abnormal acid base is risky. Now, you may have to do it, but it's just an extra consideration, and I would think very carefully about doing it. The best way to protect the brain in these cases is to stop the seizure. And it's important to recognize that in situations of hyponatraemia, the way you stop it is to correct the sodium rather than working through lots of other anti-epileptic drugs. The risk of morbidity is higher from delayed treatment than from rapid correction of the sodium, and that's really important. But that does not take away the risk of continued rapid correction in your serum sodium. I would say not to dismiss 0.9% saline for balanced solutions, and this is a prime example of when it really is the appropriate fluid of choice. And careful volume status is really important. Consider it, plan your fluid replacement, and plan it very carefully. And fundamental to that is having a really, really close eye on your electrolytes. When you get to thinking about etiologies, urinary chloride is a simple way to differentiate your Bartter-Skittlemans from your pseudo-Barters when you get to that point. And what's really interesting, and I haven't talked much about this, is that there are papers that now talk about how hypokalemia inhibits aldosterone secretion more so than the hypovolemia stimulates aldosterone. And that explains the aldosterone result that we had for our patient. I would also suggest you make friends with the nephrology team. They will be your saviors in cases such as these, and never be afraid to ask for help, because I think that's really important. I've included some references. I'm happy to share those. And I'd like to thank Costas for sourcing the case. And I encourage you all to follow him on Twitter and get involved with his weekly quizzes and the discussion pertaining to each of those. It's really interesting. And the course organisers and Chris for having me. Thank you so much.
Perfect. Listen, thanks very much, Peter. That's a really interesting, challenging case. Lots to think about, lots of learning, and good to see how you would approach a case such like this. Been a few questions coming through in the chat. One or two people mentioning the potassium. So obviously we've talked a lot about the hyponatremia and how you're going to manage that. There's hypokalemia. At what point is the right time to start worrying about that, and how would you approach your management of that particular electrolyte abnormality?
Yeah, that's a question, and people are right to point it out. And obviously, I didn't focus on it because the talk was about the hyponatremia. But I personally am worried about all the electrolyte disorders, and I want to correct all of them in as safe a way as possible. So a potassium as low as 1.3, I would be expecting that to be contributing to some hemodynamic instability potentially. I would expect to be looking to see if there are any ECG changes. So my approach to that would be to start thinking about how I'm correcting that during the resuscitation phase. Obviously, in terms of preserving brain, we need to get on top of the hyponatremic element to it, but I would also be thinking alongside that what I need to do to correct that potassium. Got a couple of options on that. So for broad brushstrokes, for any patient, you can replace it orally or you can replace it IV as a first way of thinking about it. For this patient, obviously, you're going to be thinking about replacing it IV. And again, you have different options on that. So you can put some into your maintenance fluids and watch and see how it corrects. With a potassium as low as that would make me a little bit nervous. I'd want to correct it relatively quickly. And then you need to think about how you're going to do that safely. So do you have a central line in? Well, probably not. You're probably going to have peripheral access at this stage. And then the next question is it safe to give potassium through a peripheral line? Well, luckily there is a Paediatric Emergencies app that will tell you how to safely do this.
Shameless plug.
Shameless plug. And you can put potassium into a 500 ml bag of saline and run it between 0.1 and 0.25 millimoles per kilo per hour, and that should give you a nice correction. But I would be making sure that I have a continuous ECG on and checking a gas every 30 minutes. But I'd be thinking about that during the resuscitation phase.
Perfect. Thanks.
Thanks,
and Tudor, you had a question about boluses?
Sorry, maybe Ben, just before we go on to the next question.
Yeah.
I think the only slight downside to that, Peter, I think is the volume of fluids that you would need to give, obviously, to replace that with the peripheral fluid, and with the low sodium as well.
Exactly right. So you have to think about what you think is safe and prioritise your electrolytes.
It's weighing things up, isn't it? Versus maybe an early femoral line under a bit of local might be a useful way to go as well.
Which will again depend probably a lot of the time on their age and compliance and what you can achieve and what's safe to achieve, and are you giving some sedation and what's their acid base doing at that stage and how safe is it to give them some sedative agents. So all of those things are risk benefit, I think.
Yeah, so definitely there's no easy answer, and it's weighing things up based on the individual risks, and there's nothing that's no risk at all here.
Yeah. Thanks, Chris. Tudor, you.
Yeah, so Thomas Kelly has asked, if you have a shocked patient and you're wanting to give some fluid boluses to stabilize their cardiovascular system, but you've got hyponatremia, what's the risks with overshooting with your treatment of the hyponatremia?
So my first thought on that question is, as we said during the talk, seizure is bad for your brain, essentially, and we want to stop that. So we need to correct the sodium. If you think the child's shocked and you're thinking, I want to give them fluid, well, you've got two problems there, don't you? You've got a shocked patient and you've got a seizing hyponatremic patient. So my question then would be, well, is there a fluid that I can give to this patient that could actually address both of those issues? And that's another benefit of using hypertonic saline. So you can give hypertonic saline as a fluid bolus, and it's hypertonic, so it will help draw fluid into your intravascular space. And it will also help address the sodium issue as well. Because we know that actually the big key here is protecting the brain, and the seizure is worse from the brain than correcting the sodium too quickly. So given hypertonic will address both of those issues. There are some intensive cares around the UK who will give hypertonic saline as their fluid of choice for fluid boluses, particularly in postoperative cardiac patients, because it's lower volume, but will still give you the clinical benefit of giving a fluid bolus.
Great, thank you.
Thanks, Peter. Any other comments from any of the panel before we move on? No, grand. Listen, thanks very much, Peter. Another great talk. If I can encourage you, just keep your questions coming through the YouTube chat. We have had a few more through from Costas from the first talk. I think people just maybe slow to get up and running with the YouTube chat. So I think after Dr. Richardson's talk before lunch, we'll have a slightly extended question and answer session. We'll be able to go through some of those with Costas again. So stay tuned for that. Otherwise, I'll hand over to Chris to introduce the next speaker.
Okay, thanks, Ben. So our next speaker is Tudor Oman. He's going to be talking about pediatric cardiac arrest perils.
Hello, my name's Tudor Oman. I'm one of the Paediatric Emergency Medicine Consultants in the Royal Belfast Hospital for Sick Children. I've been asked to talk to you today on pediatric cardiac arrests and maybe give some of my tips in this field. I do recognise that this audience is probably quite a mixed group, with some of you only starting off in your training and maybe haven't had that much exposure to any arrests in children. However, I know that there's probably a lot of you who are battle-hardened pros who have seen it and done it all, and nothing's going to faze you. However, I must admit that I haven't met anyone who hasn't let out a little wee when they hear the pediatric arrest bleep go. I'm hoping to have something for everyone here. From a statistical point of view, there's no way that I can compete with adult medicine in the volume of patients that you have probably seen in cardiac arrest. And that's just down to statistics. Pediatric cardiac arrest is quite a rare presentation, but can be quite specific in its cause and different in its causes to adult arrest. So without further ado, we're going to move into the statistics, and as usual we break the statistics into pre-hospital and in-hospital cardiac arrests due to the difference in presentation and CPR delivered and management. So out of hospital cardiac arrests in adult, it's estimated about 70 per 100,000 per year is the number, and when we look at children, that's all the way up to sort of 18 years old, there's 7.2 to 11 per 100,000 cases a year. So quite small numbers. It is a rare presentation. Of those, there's a very small amount that is caused by traumatic cardiac arrest. And a study in 2017 showed that analysis of the TARN data in relation to cardiac arrest in children due to trauma, well, there was only 15 cases, which accounts for about 0.6% of the TARN data. Now that's a very small number. I'm sure over the recent years with the increase in knife crime that we've seen that this number is now increased, but at the minute it's still small figures. Most of these are not going to be shockable. Only 7 to 10% of out-of-hospital cardiac arrests are due to VF or VT, the majority being asystolic arrests, and that comes down to the etiology of pediatric cardiac arrest, and we'll talk about that in a minute. Within this age group, there's stratification of risk as well. So less than 1 year old is the majority of patients that we see in cardiac arrest, and they have the poorer prognosis as well, with only 3.3% of them surviving to discharge. The second peak we see is in adolescence, and then middle-aged children between 1 and adolescent age being the least affected. And their survival rates indicate that as well. So there's better survival in children, and then teenagers, there's another dip in survival. Survival with no neurological deficit is also very poor, and we'll talk about this. Often out-of-hospital cardiac arrests can be unwitnessed, and they can have a prolonged no-flow phase, which results in poorer neurological outcome. So survival with no neurological deficit is around 0.3 to 4% in out-of-hospital cardiac arrests. What contributes to survival? So as I said, short no-flow stage. The no-flow is when there's no circulation occurring. So bystander CPR has been shown to be very important in the management of out-of-hospital cardiac arrest to reduce that no-flow stage. Ventilation, and I mentioned this, and I'll mention it later as well, ventilation is very important. Adults are moving to chest compression only CPR in the community due to the etiology of adult cardiac arrest, but ventilation is very important in pediatric cardiac arrest. ROSC return of spontaneous circulation before arrival in ED is a good prognostic indicator. Shockable rhythm, and also adrenaline. So adrenaline is a bit of a questionable topic here. A Paramedic 2 study came out showing that those in out-of-hospital cardiac arrests that received adrenaline had a more returned to spontaneous circulation. However, the neurological outcome wasn't as good. We haven't extrapolated that data to pediatric studies as yet, and there are some studies that show children who have early adrenaline in bradycardia with shock in hospital have poorer prognosis than those that don't get it or have returned to circulation prior to receiving adrenaline. Either way, there's not enough evidence to make a decision on adrenaline in pediatric cardiac arrest as yet, so the algorithm still stands. We follow the APLS guidelines. Adrenaline should be given in pediatric cardiac arrest. In-hospital CA is about 100 times more common than out-of-hospital cardiac arrest, with 1 to 6 per 1,000. And a majority of these, a lot of these, about 2 to 6% of these occur in PICU admissions. And this is common sense. You've got children who are admitted to the hospital because they're unwell, they've got comorbidities, and therefore they're a higher risk population already. 71 to 88% have pre-existing conditions, and ROSC is achieved in 64% of those, with a better survival of 12 to 25%. It's still poor, but it's better than the out-of-hospital cardiac arrest. And that's also sensible because you have monitored environment in which quick, effective CPR should be able to be provided. And these children often have better neurological outcome. Again, only 10 to 14% of these are shockable, the rest being asystolic. I've kept etiology to the end of those two groups rather than separating them because it's similar in in-hospital and out-of-hospital cardiac arrest. Most children progress to cardiac arrest from a respiratory or cardiovascular failure, leading to hypoxia, hypocarbia, increased acidosis, hypotension, eventually impaired cardiac function, and then asystolic arrest. And this is the usual pathway that children follow, and therefore treatments need to be aimed at trying to minimize these and deal with the hypotension and the hypoxia that they're experiencing. So, as I've mentioned, there's different phases to cardiac arrest. There's pre-arrest, there's no flow, low flow, and post-arrest. Okay, no flow where there's no movement of blood in the body, low flow when CPR is commenced, and post-arrest. I'm not going to talk about post-arrest very much here, but if I had a further point to make here is that as I was going through my training, it was all about trying to get return of circulation. We worked hard in a cardiac arrest to try and get that, and very little thought was often put into the post-cardiac arrest management. And what I would say, if I had another point, was to ensure that while you're going through this, you're preparing as well for success. If we don't prepare for success, then what will happen is that the child will get ROSC and over time may drift back into cardiac arrest again, or have a worse outcome, neurological outcome, because you weren't prepared for that. And Dr. Kanaris, who's teaching on this course as well, has written an excellent article on post-cardiac arrest management, which you should read. So I won't take his thunder. So my first pearl. Now, please don't go to sleep on this, all right? It's not what you probably all want when you come to an emergency conference, but I think it's highly important. Prevention is better than cure, and we need to look at this in our pediatric population. I'm sure in adult population similar issues are there, but in prevention in children, as a pediatrician, that's one of my responsibilities, to look to see what I can prevent happening so that I don't have to deal with a pediatric cardiac arrest. And in hospital, one of the things that comes across and has been extensively researched is the use of early warning scores. Now, in our hospital, we use early warning scores. These show you the trend of observations a child who has been admitted is having, and gives you early warning that something is not right, either a persistency in a tachycardia or increasing oxygen requirements. And that score then gives you an alert, the nurses an alert to say either increase the period of, reduce the period of observations or get a doctor to see, and allows you to consider early intervention in preventing this child's decline to cardiac arrest. And when you look at the etiology of pediatric cardiac arrest, most of these are progressive conditions. They are declining over a period of time, and if you can pick that up early enough, treat your hypertension, treat your hypoxia early enough, you can prevent this child stepping into cardiac arrest. Along with this goes education of staff to recognize key features in history, examination, and also observations to prevent missed cases. And when we look in our department at serious adverse incidents over the years, those that were missed often had predictors in their history or in their observations when they were discharged. For example, a common one would be a persistency in tachycardia, an unexplained tachycardia, and then they come back either in cardiac arrest or severely unwell. And so therefore we tell our staff that they are not able to discharge a child with abnormal observations unless there's a good reason. For example, you've had them on salbutamol inhalers and therefore they're tachycardic, but there's otherwise well. But if you are unable to explain abnormal observations, then a senior needs to see them or they needed to be admitted for observation. So I think this is key in prevention of pediatric cardiac arrest. We deal with a population where the signs of cardiac arrest can be seen in most cases and prevented if we are observing them well. I also have the privilege of working in a department that is very good, has a very good public health involvement, and we run a number of different campaigns. So we see a lot of SUDIs, sudden infant deaths, in our department each year. And this last year has been particularly bad. And educating the public on safe sleeping patterns and safety with children in general can reduce the chance of seeing babies coming in dead to your department. I think we all have a role in that. If we are seeing severe conditions coming in with decline that result in cardiac arrest, death, or increased morbidity, then we have a responsibility to look at how we can prevent that. And sometimes it's about doing the work with Public Health Agency and bringing awareness to the public. Other examples are button batteries, the recent increase in magnets and perforated viscous due to magnets, residential speed limits, car seats, seat belts. These are all campaigns that have reduced traumatic cardiac arrest, traumatic or other causes of cardiac arrest in children. Carer education comes into this. An admission to hospital is an important time to teach parents what to look for in decline in their children when they go home. In our department, we emphasize every child who gets discharged should be told what signs they are looking for deterioration in their child, and if any of these occur, to come back to our department. So parent education is key, and part of that is doing CPR training. And there have been studies showing that children with chronic conditions who have received education and basic life support actually do better in cardiac arrest because they get early intervention at home. So those who have out-of-hospital cardiac arrest with chronic conditions actually have a better survival. Bystander CPR is very important, and that comes down to public involvement and training and availability of AEDs. So survival with bystander CPR, you get 9.4% out of hospital cardiac arrest versus no bystander CPR at 4.7%. This comes down to a reduced no-flow stage. And if you have a look at the statistics, if you wait 1 minute before starting CPR, you're providing about 20% of normal cerebral blood flow. If you wait 9 minutes before CPR is commenced, you have no flow, cerebral blood flow. And the outcome is a lot worse. So early intervention with bystander CPR is important. Now, children have less bystander CPR than adults do, and this may come down to the fact that most pediatric cardiac arrests occur at home, and therefore in an unwitnessed or have limited supply of people who may know CPR, and that's where parent education comes in. My second pearl is about providing early, good basic life support. And there's good evidence to show that if you provide good basic life support in children, that the outcome is better. So you get higher survival, you get better neurological outcome. But evidence is also there that shows that even in hospitals, even in pediatric hospitals, we provide inconsistently good CPR. And it's up to the team leader during a resuscitation to be brutal about pulling up people who are not providing the correct chest compression, both the rate and the depth. And there was a study done in an intensive care unit showing that regular short periods of simulation, just giving real-time feedback on depth of compression and rate of compression, improved survival of the patients. And the importance of this is depth of compression. You're not going to get flow if you're not pushing hard enough. Rate of compressions, if you go too slow, you're not providing enough circulation for the brain, and you're not providing enough coronary circulation. If you push too hard and too fast, then you're not allowing full recoil of the chest, and you're not allowing time for the coronary arteries to perfuse, and therefore this can actually be detrimental to your resuscitation. So effective high-quality CPR is key. And my second point, the main point I want to make, is that running regular simulations with your team, teaching them the depth and the rate that they should be doing chest compressions will improve your outcomes from your CPR in your department. And I'm trying to instigate that in our A&E department with regular interval training on both bag and mask ventilation and chest compressions to ensure adequate basic life support. So debrief is also very important after post-arrest to ensure that learning comes from it, but my main point is made. My third one is tied to that. Ventilation. Now, as I said, adults are moving towards chest compression only resuscitation, and that's because the etiology is different. You have an arrhythmia, you suddenly collapse. These people are not generally hypoxic initially. So the etiology is different. In children, you have hypoxic or circulatory collapse, in which there is a low oxygen store in the body already. Children have a higher metabolic demand and increased oxygen requirements. So therefore, this is the reversible cause in initial cardiac arrest in children. So if you do not provide ventilation breaths, you're not going to get anywhere with your CPR. So at the minute, standard bystander and out-of-hospital cardiac arrest still recommends providing ventilation breaths to children. I've got in here oxygen or air. Neonates use air due to the risk to the premature brain. Due to the hypoxic nature of pediatric cardiac arrest, it's still recommended to use 100% oxygen during your resuscitation, but maybe in the near future, we'll see some more studies coming out in the concentration of the oxygen we provide during our resuscitation. The main point I want to make here is that there's been studies, it's a question I actually get asked a bit by ambulance crews, is should we intubate or not? And evidence has shown that bag and mask ventilation is as effective at providing good CPR to the good resuscitation to these children, and that intubation in inexperienced hands can actually lead to prolonged delays in providing effective basic life support. So my recommendation is that unless you are experienced and you know that you can intubate this child quickly, if you are getting good chest lift, and you are able to ventilate this child, bag and mask ventilation is your tool of choice. There are some papers that have indicated that intubation in hospital results in poorer prognosis of children, and again this may be because of the delay in or the pauses in attempting intubation with delay in providing chest compressions. So if you're getting chest lift and you are able to bag that child, then bag and mask ventilation, unless you are an experienced operator, should be your choice in ventilation. Remember that we're all panicking a little bit, or we all feel stressed in a pediatric cardiac arrest, and over ventilation can be detrimental to your patient. One of the indicators for poor prognosis is persistently low CO2 in a child. So if you are over bagging, and I know I have a tendency initially, and I have to check myself when I have an arrest situation, that I am bagging at the right rate. All you're trying to do is lift the chest. You don't need to over ventilate them. So just be aware of your bagging skills and how much you are providing. And this comes down to training again, and should be regularly simmed with your team. My last point is more about when to stop resuscitation. And I know as a pediatric trainee, as I went along, you're involved in a resuscitation, and the fear of missing something or not doing something that could have reversed the situation leads you to going into prolonged resuscitation. And I remember prolonged resuscitations as I waited for a senior person to come in and make the decision to stop resus. And this is my word of the day. I don't even know if I can pronounce it properly. Dysanthesia. And this is prolonged resuscitation just to preserve life with no real benefit. Okay, and therapeutic perseverance or medical futility are other words that you can use. And this is when treatment offers no hope of recovery or improvement, or for which the patient is permanently unable to experience the benefit. And more we're looking at neurological outcome for these children. And prolonged resuscitation, even if you get ROSC, often leads to a poor prognosis with a severely disabled, neurologically deficit child, or someone who then later progresses to further cardiac arrest later on. Factors which may influence your decision are the cause of arrest. So if there's a massive traumatic cardiac arrest, which is not compatible with life, or there is an underlying medical condition that the outcome is not going to be good, these are indicators that maybe your resuscitation attempts are futile. Whether it was witnessed or unwitnessed, as I said, reduced low flow states, a no flow state is a better prognosis. Prolonged no flow has poor outcome. Bystander CPR, duration of CPR. So it is thought that if you have asystole and you have no reversible causes identified, if you have resuscitated for 20 minutes or more, then the outcome is not survivable. The initial arrest rhythm, as said, VF arrest is got a better prognosis, although in children we see mostly asystole. So my experience is that I've seen more children recover from an asystolic arrest, but that's just statistical. if you look at the outcomes of VF arrest, the more chance of survival if you have a reversible cause. Change in rhythm from asystole to VF gives you something to treat and has a better outcome. Persistently low EtCO2 I've mentioned. Reversible causes. If you've run out of reversible causes and the child is still in arrest, then the outcome is poor. I put in here echo, and there's been a little bit of research in looking at cardiac standstill and echo. I like a bit of point of care ultrasound, but the evidence is that not great for making a decision on cardiac arrest, stopping cardiac arrest based on cardiac standstill. 14% of adults who had cardiac standstill progressed to have recovery of circulation. And therefore it's not currently recommended in medical cardiac arrest. However, in our traumatic cardiac arrest algorithm, it is there as part of your decision-making tool. If you see cardiac standstill and you've done all your surgical procedures to try and return circulation, then echo can help you make a decision to stop. If you have standstill, futility is there. Premorbid conditions we've talked about. And then when definitely dead. As I've mentioned, we see a lot of SUDI cases coming in, and often these cases, these children have been dead for a while, and they arrive in with CPR ongoing. They have rigor mortis and pooling of blood. They're cold, and at this point, resuscitation is futile. So early cessation of CPR is beneficial, not necessarily looking specifically at the child at that, but trying to take your team through a resuscitation that everyone knows is futile is not good for the team morale in that respect. So there are times to continue resuscitation. VF arrest is one of those, and you can get this electrical storm that you may need to continue resuscitation until you've dealt with all reversible causes and given a chance for that to settle down. Hypothermia, such as in your drowned patient, is an important time to continue resuscitation, and the saying is that you're not dead until you're warm and dead. Sometimes this can be difficult to call, but that is the general rule. In asthma, you get this hyperinflation due to air trapping, and so resuscitation should be continued until you're able to decompress that chest a bit and allow circulation, because you get this effect of tamponade on the heart with these hyperinflated lungs. Toxins are an important cause of pediatric cardiac arrest, and if there's toxins related, there's evidence to show that prolonged resuscitation can result in good return of circulation and good neurological outcome if prolonged. So the decision to stop resuscitation is the team leaders. I have to emphasize it is not up to the parents. The parents are emotional, they have a lot more riding on this, but it's a medical decision to make. Don't ask the parents whether you should stop. It's not their responsibility, it's your responsibility. It doesn't have to be a responsibility that you bear alone. You have a team there, and I would often discuss termination of care with my team, highlighting what we have done, the things that we have reversed, and the length of resuscitation that has gone on before I make that decision. You need to continue CPR until you feel like you have enough information to make that decision. So initially when they come into the hospital, you often don't have, and you may need to do a round of CPR just to get a hold of all the information that you need. Each case is individual. But prolonged resuscitation can be devastating, have devastating consequences if return of circulation and the child is significantly neurologically knocked off or has a later cardiac arrest and death can be traumatic to the family. And in all of this, don't forget your team. This is traumatic to the team as well. And post-arrest debriefing, both hot and cold, have been shown to improve outcomes for future resuscitations and also help with team mental health. So in summary, I'm not the guru here. I'm giving you my thoughts on cardiac arrest, but prevention is better than cure. High quality CPR is key, and practice that over and over again with your team. 4-yearly APLS doesn't provide enough practice for that. Children need to be ventilated, and bag and mask ventilation is as effective in the untrained, instead of intubation if you're not trained specifically for that, and know when to stop. So that's it, guys. Any questions?
Great. Listen, thanks very much, Tudor. Really interesting talk, and I suppose something that unfortunately all of us who work in paediatrics have experienced, I'm sure, at some stage. Some real useful pearls there. Chris, I know I'm going to go to you to start. I think you sort of wanted to discuss around the evidence for whether to intubate child early or not. So I'll hand over to you to have a chat through that.
Thanks, Ben, and thanks, Tudor, for your talk. I suppose you covered this really well in the talk, Tudor, but it was more just as maybe to emphasise the point rather than to have any meaningful discussion on it, because I think you've covered it rightly. It was certainly the evidence is against intubating in a paediatric cardiac arrest, but we've had a little bit of a chat among ourselves here just offline, and certainly for most of us, we noticed if you're going to get ROSC, it tends to come in the minute or two after the tube goes down. So it was really more of a point rather than a question, but I think if you have the expertise there, I think the best way to get ROSC is to have that expert put the tube down very close to the start. But I think the point you were making is in that scenario where there's not an airway expert, and I think this is what the papers show. Maybe
so basic. In my practice, and in our, you work in the same hospital, is we get a tube in as quickly as possible in a cardiac arrest. But generally that is with an experienced operator. And I think the advice is if you are unsure that you're going to get the tube in, or there's going to be significant delay in getting effective chest compressions and bag and oxygen delivery, then you should leave it to the experts. I get asked by the paramedic crews about providing some form of airway for the child. And I think if you're getting effective chest lift with bagging, then that's what you should continue doing unless you are the experienced operator.
Okay, but I suppose given a scenario where you've got vomit in the airway, or your LMA or your bagging isn't effective, even if you're not the expert, maybe in that scenario, actually attempting intubation would be in the child's best interest.
Yes, when you're not going to able to get a good chest rise, yes, because then you're not providing oxygenation anyway,
which we know is the biggest cause of pediatric cardiac arrest.
Yeah.
Okay, perfect. Thanks.
Okay, thanks. Hopefully, Costas, I know you got a text from the newt retrieval team that you work with regards to intubation, so hopefully that answers some of that questions. Peter, you want to comment just to make about ECMO, I think, in terms of.
I just wanted to make a point that if you have an in-hospital cardiac arrest and you work in an ECMO centre, it's really important to consider early whether this patient is an ECMO candidate or not. And if you're not sure, I would advise you to call your ECMO team in, because we can always be stood down. And we're happy to be called and to stand down if needs be, but you have to get everyone mobilised early because it takes time. The outcomes from ECPR aren't fantastic. It's about 40% survival to discharge for paediatric patients, but considerably higher than it would be for adults. But if you thought that these patients weren't going to potentially survive, 40% is better than nothing. So I would just advise people, if you work in an ECMO centre, to call early.
Yeah, perfect. And I guess that kind of takes us on to a bit of post-resuscitation care, because quite often a lot of the APLS courses will talk through sort of APLS, ALS and BLS until the point of return of spontaneous circulation, and then it ends and you pat yourself in the back. But actually that's kind of only the start of the management of these patients. And I know, Tudor, you alluded to an article Costas had written in that regard. So I don't know, maybe Costas, if you could give us a minute just of a kind of brief key points in that post-resuscitative phase.
Yeah, so the article is on, if you go on to Don't Forget the Bubbles and you type in post-resuscitation care, then it should pop up. I'll put it on the Twitter feed as well so you can see it. Now, we're good at knowing the ropes around getting resuscitation in hospitals, but I think we could, and that's largely down to APLS, but I think we're not very good at the post-resuscitation care. And there's some measures that we can do that could really have a meaningful impact on outcomes, or meaningful outcomes, should I say, if the child survives. The number one tip is to aggressively monitor the temperature. So there's variation as to whether people cool or not. What I would say is you should absolutely avoid hyperthermia. You need to slow down the metabolic demand on the brain, and anything more than 37, you should try and avoid. Similarly, anything less than 33, you should try and avoid, as that can cause a significant coagulopathy and is shown to worsen outcomes in other ways. We forget a lot about seizure prophylaxis in post-resuscitation patients. These patients have been hypoxic. They're likely to have a hypoxic brain injury. They're likely to fit. So you need to preempt them with a long-acting anti-epileptic. What's probably safer, given recent evidence, is Keppra rather than phenytoin. It can be given faster and less likely to cause an arrhythmia. So have a low threshold of giving 40 milligram per kilo of Keppra. Avoid hypoglycemia and correct the electrolytes to minimize the risk of arrhythmias. Try and nurse them at a 45-degree angle that optimizes cerebral perfusion, not flat, not upright. Anything between 35 and 45 is fine. And then keep an eye on your blood pressure. So depending on which hospital you're at, you might have the skill set to put an outline in a small child or not. If you don't, then you need to have a blood pressure cuff on 1 minute or 2 minute cycles, so you can have almost a real-time picture of what the blood pressure is. So you need to aim for a higher normal BP and use inotropes. It doesn't matter what you use in the beginning. That will be guided by your PICU retrieval team, but aim for a high normal BP. Remember, if it's a trauma, try and avoid saline and just use blood products to plug the hole, because the patient doesn't need salty water. They need to replace what they've lost, and that's blood. And in terms of ventilation, you must absolutely have an end-tidal CO2 monitor in. So aim for a target of PCO2 between 4.5 and 5.5 to try and improve that cerebral regulation a bit better. And
that's great. Thanks, Costas.
Can I maybe just echo one of the points Costas has made there about the temperature, because that's one I've seen a number of times done badly, and I think it's since we have now moved towards targeting normothermia. These kids are often cold when they come in, and people like to warm them up towards normothermia, but the problem with that, it's so easy to overshoot. If they're cold, as long as they're over 33, which we used to do, I would leave them at that temperature until they're in an ICU environment where they can be warmed up gradually and safely. I've seen it a number of times, people warmed to normothermia, and by the time they've arrived in the ICU, they're pyrexic, and obviously the downside of that. So just echoing what Costas has said there.
Perfect. Thanks, Chris. We have time for a couple more questions just before we go to our first break of the day. So I think Lorraine Redmond had posted in the chat just asking about whether or not you think all parents should be taught BLS before either discharge from hospital or as part of their antenatal classes. You any thoughts on that, Tudor?
Well, I think that there's good evidence that bystander CPR has a good effect, has better outcomes in children who arrest out of hospital. And often children with chronic conditions who go home with basic life support training do a lot better than other children whose parents don't have that training. So I do think it is beneficial. I think we should be opportunistic in our education of parents, that when they are with us, that we teach them the basic skills of recognizing when their child is deteriorating. And not only the BLS, basic life support, but also the recognition of early signs so that they can get into hospital quicker before the child actually arrests or becomes seriously unwell. And I think we were having a chat about it earlier, and Peter's concern would be that if you just teach them BLS, then they wait until the child's arrested, start CPR, and then call for help. Whereas actually there's lots of signs, and I think that was one of my main points in the talk, was there's lots of signs that you can see that a child is deteriorating. It's just knowing what to look for. And if you can get them into hospital earlier, then we can potentially prevent that arrest from happening in the first place. And that outcome is so much better than if they've arrested and we get a ROSC after that.
Yeah, so it's about that early detection. And just one more question I suppose we have time for, which is obviously quite topical given the current climate that we're living in, and it's regards to the fact the aerosol generating procedure and approach to PPE in resuscitation. And I know there's college guidance. There's some variation in terms of local practices.
Yeah.
So it's just kind of get your feeling on that, Tudor, and where you stand in that regard.
So the guidance for resuscitation at the minute is that if someone comes in requiring resuscitation, you're bagging, aerosol generating, you're possibly going to be intubating, aerosol generating. So resuscitation providers should be in full PPE. Now that is all well and good, but as I've said already, the time of the downtime for a child in cardiac arrest has significant knock-on effects. So minimizing a child's period of hypoxia and poor perfusion is key. So in our department, although we recognize college guidelines, we haven't felt that it fully meets our patients' needs. So what we do is we recommend that 2 rescuers put on PPE masks, visors, gloves and an apron, go in and start CPR and bagging while everyone else gets into their PPE. And then those people then come in and take over from the care, and the other 2 are then excused. We recognize it's not what college guidelines are, but we also recognize that if we take the 5-6 minutes that it takes to get into full PPE, the outcome for our patient would be significantly reduced.
Yeah, I mean, it sounds like a sensible, pragmatic solution to what is, I suppose, a difficult issue. And I guess everywhere will have their own guidance. So it is important, if you haven't thought about it wherever you're working at the minute, that you do try to have a think and put plans in place locally as to how you approach that situation. I think that's us kind of at time for the first break. I'm going to hand over to Chris just to wrap up this session.
Yeah, that's right, Ben. We're now heading to our coffee break. We're going to come back at about 11:10. We are going to play a few of our advertisers' videos over the coffee break, so please do take a look at them. Like I say, the reason we'd have been able to put this on for free and put the live stream on to the quality that we have done is because of our sponsors' contributions. So please do take a look at their videos. Thank you.
With reusable scopes, setting up a bronchoscopy can involve a lot of waiting. Waiting for the respiratory therapist to call you back. Waiting for a time slot. Waiting till a bronchoscope is available. The Ambu A-Scope 4 Broncho is ready when you are. You simply grab the scope and monitor and are ready to go. With reusable scopes, contaminants can hide in the bends and channels even after high-level disinfection, bringing risks to your patients. With Ambu A-Scope 4 Broncho, you get a brand new, sterile bronchoscope straight from the pack every time. With the Ambu A-Scope 4 Broncho, you get more than just a bronchoscope. It's a fully integrated solution with 3 scopes, a tailor-made sampling solution, and a high-definition monitor to help you deliver the very best in patient care. Ambu A-Scope 4 Broncho. Guaranteed sterility, ready when you are.
TrueBaby X represents the appearance, weight, size, and movement of a 5-month-old. The Pediatric Clinical Skills Training Model is ideal for anaesthetists, nurses, and other pediatric emergency medical professionals practicing directly observed practical skills, pediatric advanced life support, and critical emergency medicine. Techniques and skills which can be taught include infant airway management, CPR, peripheral venous cannulation, PICC line insertion, needle thoracentesis and chest drain, intraosseous infusion, urethral catheterization, and lumbar puncture. The model has been designed to be fully interchangeable. All the parts are cost-effective and can be replaced quickly when required. The initial setup time is less than 5 minutes. This model is part of the AirSim X range, which provides realistic and durable training and comes with a 5-year warranty on the airway and 1-year warranty as a standard for all other parts. For more information or to speak to a product specialist, email info@truecorp.com or call 4428 3888 2714.
The A-Scope 4-Rhino-Laryngo Endoscope is a flexible, high-quality, single-use rhino-laryngoscope. It is sterile and easy to use right out of the package. The A-Scope 4-Rhino-Laryngo comes in 2 configurations, Slim and Intervention. The Rhino-Laryngo Slim has a 300 mm long insertion cord with a diameter of 3 mm. It features 2 LED lights and a CMOS camera at the distal tip of the cord. The Rhino-Laryngo Interventions insertion cord is 350 mm long with a diameter of 5 mm. It features the same LED-assisted CMOS camera on the distal tip, but also offers a 2.2 mm working channel for passing tools and endoscopic accessories up to 2 mm in size. Additionally, the handle of the intervention has a suction button, suction connector, and working channel port, which allow for the installation of fluids and the insertion of endoscopic accessories like forceps and brushes. The intervention comes packaged with a Luer lock introducer, which facilitates the introduction of forceps and other endoscopic accessories. Before using the A-Scope, visually inspect the pouch to ensure the seal is intact. Open the pouch carefully and remove protective elements from the handle and insertion cord. Check to make sure that there are no rough surfaces or sharp edges which may cause harm to the patient. Connect the A-Scope to the A-View by aligning the blue arrow on the white male connector into the corresponding blue female connector on the A-view. Press the power button on the top of the A-view once and verify that a live video image appears on the screen by focusing the distal end of the A-scope towards an object. Carefully slide the control lever forward to confirm that the bending section of the cord operates fully and smoothly. If applicable, prepare suction equipment according to the supplier's manual and attach the suctioning tube to the suction connector. Press the suction button to check that suction is applied properly. Verify, as needed, that endoscopic accessories of appropriate size can be passed through the working channel without resistance. To begin a procedure with the A-scope 4 rhino-laryngo, lubricate the insertion cord to the gray mark using a medical-grade lubricant. Take care not to get any lubricant on the tip of the camera. Holding the handle of the A-scope in either hand and guiding the insertion cord with the other, advance the cord into the patient's nose following standard procedures. The control lever is used to flex and extend the tip of the A-scope in the vertical plane. Moving the control lever distally will make the tip bend anteriorly, and moving it proximally will make the tip bend posteriorly. Rotating the handle controls horizontal movement. Fluids can be instilled through the working channel of the rhino-laryngo intervention by inserting a syringe into the working channel port at the top of the A-scope. When using a Luer lock syringe, make sure to utilize the included introducer. Insert the syringe completely into the working channel port or introducer before instilling fluids. If a suction system is connected, suction can be applied by pressing the suction button with the index finger. Make sure to not apply suction during the installation process, as this will direct the instilled fluids into the suction collection system. To expel fluid left in the channel, flush with 3 to 4 milliliters of air. When working with an endoscopic accessory, make sure to select one 2 millimeters or smaller and inspect the accessory closely before using it. If there are any irregularities in operation or appearance, replace it. Insert the accessory into the working channel port and advance it carefully through the working channel until it can be seen on the A-view monitor. After the procedure and before withdrawing the A-scope, ensure the control lever is in the neutral position. Slowly withdraw the A-scope, checking progress against the live image on the A-view.
Okay, so I've got a case of the collapsed neonate for you, and as promised in the introduction, I'm going to make this a very interactive case. And I don't know if you all remember the books you used to get as a child, the Choose My Own Adventure books, where you would come to a certain page. On that page you maybe would have 3 options. You picked option A, you went to a certain page, option B another page, and option C another page. Each of those pages you would have a completely different story. And as the book went along, you would go to another page and have further options. So the story you chose as the book went along was completely different, and then you would have a completely different ending as well. So this is how this case is going to work. I'm going to stop at various points in this case, and I'm going to ask you guys to vote over in the YouTube chat on an intervention or a series of interventions as to which we should choose. I'm going to go with the most popular answer, even if that's a bad answer. And the story in this case is going to change completely based on your interaction. So it's good, as the day's gone on, we've got more and more questions and comments coming through in the YouTube chat, so hopefully this is going to work okay. Although when originally I had planned this idea, it was meant to be to the live conference of 300 people in the room. So we'll see how this works over the internet in various different countries. So I'm going to talk about a collapsed neonate today, and our case, we've got a 3-day-old baby boy, born by full term, normal vaginal delivery, birth weight of 3.5 kilos. The baby was born after an uneventful pregnancy. Mum's scans were normal during the pregnancy, and there was no risk factors at all for sepsis. Day 1 of life, the baby check was done, everything was normal, and the baby went home very shortly after that. Day 2 of life, no real concerns by the parents. Maybe towards the end of the day, the baby wasn't feeling quite as well as they had the first day, but nothing that really alarmed them. They were, however, more concerned on day 3 when they got up. They couldn't get the baby to wake to feed, looked much paler than what it had done previously. And as the day went on, the baby started having episodes of stiffening. So an ambulance was called and the baby was taken to the emergency department. So initial assessment in the emergency department, so there's clear signs of airway obstruction. We've got seesaw breathing and a gurgly noise coming from the airway. From a breathing point of view, there's hypoventilation with a respiratory rate of 18. SATs are only 82% despite being in 100% oxygen via an non-rebreather mask. Listening into the chest, there's poor entry throughout the chest and lots of transmitted sounds as well. Going on to the circulation, there's clear signs of shock. We've got tachycardia, heart rate of 187, hypotension with a MAP of 34, and a prolonged central capillary refill time of 4 seconds. Peripheries are cool all the way up to the trunk, and our peripheral pulses are actually quite difficult to palpate, although we can feel the central pulses, and importantly the brachial pulses and the femoral pulses are of equal volume. Listening to the heart, there's a 1/6 ejection systolic murmur, which is heard all over the precordium. Going on to D, there is clear signs of seizure activity. So we've got lip smacking, cycling movements of the limbs, and episodes of stiffening. Coma scale is 3 out of 15. We've got a BM of 4.2 millimoles per litre, and pupils are large at size 6, and although they do react to light, they're quite sluggish on reaction. The anterior fontanelle appears full. Going on to exposure, the abdomen is soft and non-tender, there's no masses or organomegaly, there's no other signs of injury or trauma in the baby, and the baby's hypothermic with a temperature of 35.7. So we go on ahead and do the interventions you would expect to happen in any emergency department. So the airway is open with basic airway opening manoeuvres. The back of the throat is suctioned out with the anchor sucker, and we put a Goodell airway in. Important thing to note, the baby tolerates the Goodell airway. So we put the baby onto an Irish T-piece, give them a little bit of PEEP, and as well, we said the baby's hypoventilating, and during some of the longer pauses between the breathing, the baby does need the odd ventilatory breath as well. Peripheral venous access is attempted. Unfortunately, this is unsuccessful. So an ILO line is sited in the right tibia. 20 mils per kilo of normal saline is pushed in, and we also take a capillary blood gas off as well. To treat the seizure, a dose of lorazepam of 100 mics per kilo is administered. So going back to reassess following those interventions, the airway is now patent with a Goodell airway in situ. However, following the lorazepam, the baby has become fully apneic and is now needing continuous bagging. Saturations on that are 92%. Going on to look at the cardiovascular system again, so we've given her 120 mils per kilo fluid bolus, but the cardiovascular system really remains unchanged. Still tachycardic, still hypotensive, still got a prolonged cap refill time. Going on to D, the lorazepam has worked from a seizure point of view, so the seizure has now terminated. Coma scale remains at 3, and although pupils are a little bit smaller now, the seizure has stopped at size 4, the pupils are still quite sluggish to light. And that capillary blood gas that we sent, we'll take a look at it. So we've got a pH of 6.982, so a fairly severe acidosis, and that's made up of a mixed respiratory and metabolic acidosis, CO2 at 12.4 and a base excess of -8. Looking at the metabolic component, that's made up mostly of an elevated lactate. We can see we've got lactate there of 6.4. Other important things to point out in the blood gas, and you get a lot of information on the electrolytes and other things as well. So we've got a sodium which is in the normal range, which is good, 140. So we're not going to be able to use any of the tips we've learned from Peter so far. Potassium is slightly on the high side though, at 5.9. Although it's important to remember this is a squeezed capillary sample that was very difficult to get in a shot down baby. Calcium is low, 0.8. And importantly, hemoglobin is within the normal range for a baby of 3 days of age at 182. And got a BM of 4.2. So this brings us on to the first decision-making point for you guys. So I want you to go over to the YouTube chat and give me a yes or a no as to whether we should intubate this baby now. And I'm going to wait for your answer and go with the most popular answer. Okay, so you guys have voted yes, so we're going to go with that. I'm going to click on yes. So we go ahead and give an induction agent and a muscle relaxant. No trouble getting the grade 1 view, as you can see on the screen. No trouble putting the tube down. But shortly after we pass the tube, we get a bradycardia, which proceeds into cardiac arrest. CPR is carried on for 30 minutes, but unfortunately it's unsuccessful. Okay, so we're going to have to try that again. So intubate now, I'm not going to ask a yes or no, I'm going to go ahead and click no. And we've got a series of interventions on the screen that we can potentially do at this stage. So again, I want you to vote over in the YouTube chat as to which of these we should do at this stage. So in your list, include everything that you want to do. If you leave it out from the list, I'm going to take that as a vote for a no on each of these interventions. So go ahead now and vote over the YouTube chat. Your choice here is nasogastric tube, adrenaline push dose or infusion, a further fluid bolus, a second line, calcium gluconate, antibiotics, a chest x-ray, starting a McCrossan infusion, or a CT brain. So go ahead and vote now. Okay, so we're starting to get some answers coming through. So I think with this baby, there's two main things that concern me and why I think intubating right now is maybe a bad idea. The first is the saturations of 92% despite being bagged at 100% oxygen. So anybody who intubates small babies on a regular basis knows that they desaturate incredibly quickly when you try to intubate them. And that's even with good pre-oxygenation. The problem is with our sats of 92%, we're already at that steep part of the curve where the sats are absolutely going to plummet the moment we stop bagging them. And this is a baby I think who's going to tolerate hypoxia incredibly badly and is likely to arrest with a significant hypoxia that we're expecting if we try and intubate them. The second big problem is the hypotension. We're all taught in resuscitation courses that hypotension is a peri-arrest sign. It's a late feature of shock. And if we go ahead and try and intubate this baby with the blood pressure where it is, there's a very real risk that this baby is going to arrest. So the two things I think we need to optimize are the blood pressure and also the saturations. Michelle, that is going to just time-lapse out the TV. Okay. Yeah, the TV remote control. Sorry, just a few technical issues in the stream there. Just press any button on it. That's us. Okay, just making sure the things don't time themselves out during the talk. So going back to the list of options that we have, so nasogastric tube, that would be something I would really encourage you to put in anytime you have to start bagging a small baby. And the reason for that is when you're bagging a patient, you're hoping that the gas you're giving goes into the lungs, but inevitably a lot of it goes down into the stomach. And with each breath you give, more and more gas goes into the stomach, and as the stomach becomes distended, it splints the diaphragm. And I've seen this numerous times over my career where small babies in particular are absolutely impossible to ventilate because of diaphragmatic splinting. So I find whenever I'm having to bag one of these small babies, even for a short period of time, putting a nasogastric tube in, aspirating it at the start isn't enough. You need somebody to continuously aspirate it while you're continuously bagging. And quite often you avoid any problems as well from doing this. And I think the risk of vomiting and aspiration is also going to be less if you're not distending the stomach. Now, adrenaline push dose would be my preferred method of actually correcting this baby's blood pressure. And I think the reason for that is we don't have all day to get this baby stabilised and tubed. Bagging a patient is not a good place to be, and you don't want to do that for a long period of time. The other problem is there's a very serious process going on with this baby, and we need to actually get on with diagnosing it and treating it. So I think probably we need to get this baby tubed in the next 3 to 5 minutes. And given that we've given one fluid bolus, it has made absolutely no difference. I think it probably wouldn't be in the baby's best interest to keep working down the fluid bolus route, realising it's not worked after 60 mils per kilo, starting an infusion and intubating the baby after half an hour. I think push dose adrenaline is the ideal way to fix the blood pressure in this patient. I would, however, give another fluid bolus. We've only given 20 mils per kilo, and I think another 20 mils per kilo, but I would chase the adrenaline in with the fluid bolus rather than giving it and waiting to see if it works. Second line, most of you did vote for a second line, and I'm going to be argumentative here and say I probably wouldn't put a second line in this baby at this stage, and I'll explain my reasoning for that. The first thing is, over the next 3 to 5 minutes, we have quite a few jobs that we want to do. So we're going to need to fix the oxygenation, hopefully with an NG tube that will improve. We're going to have to fix the hypotension with a push of adrenaline and hopefully a bit more fluid. And we're also going to have to prepare to intubate. So that's a lot of jobs to do, even for a big, experienced team. And if we send a person to try and get a second line, one, that's one less person to help with those jobs. And two, it's a distraction for the rest of the team. And given that we can actually manage with a single access, everything that we're giving is going to go via a push into the single line. I would leave this for now. We're certainly going to want a second line, but I don't think we need it in the next 5 minutes. The next two drugs are exactly the same story. All our vasoactive drugs work by increasing intracellular calcium. If our calcium is low, as it is in our baby, they're not going to work very effectively. But the problem is we've only got one line. Calcium is going to go over about 10 minutes. Does it really make sense to tie our single line up with that calcium infusion, meaning we can't give adrenaline, we can't give fluid, we can't give our induction agents? That doesn't make sense to me. We're going to have to fix the calcium, but I would leave it for the next 5 minutes and do the other 3 essential jobs that we need to do. Antibiotics, exactly the same story. But you'd be surprised the number of times I go down to a sick child and that line over that first 5 minutes is tied up with somebody running antibiotics. They absolutely must be given early, and sepsis is a definite potential cause in this baby, but I wouldn't be doing them in the next 5 minutes. I'd leave that line free for drugs which are slightly more up the priority order. Chest x-ray, really important when you've got a collapsed neonate. I find you pick up a lot of the cardiac babies by having a big heart on the chest x-ray, and that can often be one of the first features that points you down that route. But we're bagging a patient, we're about to put a tube in. I don't think the time to do that is just now. After the tube is down is the ideal time for the chest x-ray. Prostin infusion, again, I would encourage you early to start a prostin infusion in babies you think are potentially got a duct-dependent cardiac lesion. But again, we've got one line. The next 5 minutes, I think I would see how the intubation goes and then strongly consider starting a prostin infusion if we're still unhappy. CT brain, again, the baby has features that may make us want to do a CT brain, but at a time when you're holding an airway open, bagging, and you've got a hypotensive patient, the CT scanner is the last place we should be taking this baby in the next few minutes. Okay, so let's go back and reassess our baby after the interventions that we have done. So the airway remains patent with the Goodell airway in, and actually after we put the nasogastric tube in and got somebody aspirating continuously, the bagging has improved. We've got SATs up to 100% and they've been there now for 3 minutes. The cardiovascular numbers have also improved. We've got a heart rate down to 172, MAP is up to 41, cap refill is down to 3 seconds, and that's after 40 mils per kilo of fluid and 1 mic per kilo of adrenaline as a push. D really is unchanged from what it was before. Okay, so this brings us back to the second decision-making point, and the question is, should we intubate this baby now? So go ahead now and vote over in the YouTube chat, yes or no. Okay, so you're all voting yes again, so we're going to go for yes. And, ignore that, we're going to go for yes. So yes, I think is the right answer here. You often get a window in these children as to when you can safely intubate them. And I don't, as we mentioned already, this isn't a child I think we can take all day trying to get the numbers absolutely perfect. There's a downside to that. One, you can lose the window. The baby could vomit and aspirate at any seconds. And as well, we've got this process going on that we don't know what it is and we haven't done anything about it as yet. So we're going to have to get on and find that out. So this brings us on to your intubation plan, and there's 4 parts that I want you to vote on for this. So I want you to pick your blade, pick your tube, pick the drugs that you want to use, and yes or no at the bottom as to whether you want to use prophylactic atropine. So for the blade choice, you've got a Miller 1, Mac 2 or CMAC. Tube is a 3.0 microcuff, 3.0 uncuffed or 3.5 uncuffed. For the drug choice, we can go with no drugs, ketamine only, ketamine rock, ketamine sucks, propofol rock and propofol sucks, and then a yes or no at the end to prophylactic atropine. So go ahead and vote now over in the YouTube chat. I'll just give you a minute or two to get those votes in. Okay, so for the blade, you guys have voted CMAC. Okay, I'll click on CMAC. And I think this would probably be my preferred choice. Looking at the options we have, the Miller 1 is obviously the traditional choice. In general, a straight blade in a baby of this size where you lift the epiglottis directly is going to give you a better direct view than a curved blade in the vallecula. And that's due to the big floppy epiglottis and the lax glossoepiglottic ligament, which is often incompletely lifted with a curved blade in the vallecula. What I would say though is if you're somebody who uses a Mac blade all day every day and intubates a neonate maybe once or twice a year, you might actually want to stick with your tried and trusted Mac blade rather than using a Miller blade if you don't have a video laryngoscope available. And as long as you combine that with a lot of external laryngeal manipulation and use a stylated tube, 9 times out of 10 you're going to get an intubatable view. It's likely to be a grade 2 view, but you'll be able to intubate 9 times out of 10. And you may have more success with that than you do with a Miller 1 and trying to lift an epiglottis, which isn't something you often do. As I've said, my choice would be a video laryngoscope. I use a video laryngoscope for probably 99% of my intubations, a whole variety of different ones. And if you're in that same situation where you infrequently intubate babies, my advice would be to get familiar with a video laryngoscope in your adult patients. The technique to using it in a small baby is exactly the same as in an adult. You don't have to lift an epiglottis, you go into the vallecula. Even if you're using a straight blade, I normally use the straight blade in the vallecula. You've got a big magnified view of the airway, and it's really simple to intubate these small babies. I think it takes a lot of the worry out of doing it. So that would be my advice. For the tube, you've gone for 3.5 uncuffed. So I would prefer a cuffed tube in these patients. Obviously practice varies throughout the world. In my experience, where you've got a baby this sick, you want to tube them once and once only, and a cuff tube is really the only way to guarantee, well, it doesn't guarantee it, you could have a cuff rupture, but to give yourself the best chance of tubing the baby once and once only. We know from studies that up to 30% of the time you use an uncuffed tube, you're going to have to go back and upsize that tube because of cuff leak. This is a very sick baby, a baby you might need to do CPR on, where high pressures are going to be on the chest. I would put a cuff tube down and your job is done. But we'll go with a 3.5 on cuffed. What about the drugs then? Ketamine and rock. And I'm very boring with my intubation drugs. I tend to use the same stuff again and again. And ketamine and rock is one I would use for this particular patient. I think the no drugs and ketamine only isn't probably a good choice for this particular patient. And the reason for this is a really sick baby who you need to get tubed on the first attempt. So you want to give yourself the best chance of doing that. So I think a muscle relaxant where you have the cords wide and open, where you have no difficulty with the tongue muscle tone low, is going to be your best way of doing that. As well, although this baby's unconscious, their airway protective reflexes may still actually be present. So if you put a blade into the back of the throat, this baby may gag and vomit, and then you've got aspiration to deal with, or they may develop laryngospasm. So I think a muscle relaxant makes sense, particularly given you're bagging this baby anyway. From a sedative point of view, you've got a choice of ketamine or propofol. And propofol is absolutely contraindicated in this patient. It's highly likely to make the baby arrest. If you've got it, given the hypotension and the instability of the baby, your ketamine dose, you're going to want to significantly reduce the ketamine dose down. I would probably use about 0.5 milligram per kilogram of ketamine in this baby, and I've found babies that are unconscious like this, they will go out like a light with a little bit of ketamine. You don't need to give a big dose, and a big standard dose of ketamine, 1 or 2 per kilo, may well make this baby arrest given their hypotension. Muscle relaxant choice, we could argue all day about rock versus sucks. I use rock most of the time because the lower side effect profile. I think the big side effect you're going to be worried about in a small baby is a bradycardia with sucks, and it's fairly common with sucks, particularly with a second dose in these small babies. And this is a baby who's going to tolerate a bradycardia incredibly unwell. So I would avoid sucks for that reason. The other reason might be the high potassium you've got in the capillary gas. Although we have to remember it was a squeeze sample, and you could also argue that actually the serum potassium is likely to be in the normal range. So you could argue it either way. The other slight advantage to sucks in this scenario would be that your neuro exam is going to come back that bit sooner. And given that our patient has been seizing, it would be useful to see that. But I think weighing everything up, the stability and lower side effect profile of rock would be the reason I would go for it. Prophylactic atropine, what was the answer to that one? So you've gone for yes for that. That would be my personal preference. I don't use atropine prophylactically for all my intubations. Where I tend to use it is the smaller babies. The sicker babies are babies that have already started to have bradycardias. We had a bit of a chat over this when some of the other talks were playing earlier on with the panel, and I seem to be an outlier on my use of atropine. But again, I'm quite happy to be an outlier. I don't mind the tachycardia that comes after the intubation, but I really don't like the bradycardia that comes during an intubation attempt. And I would much rather prevent that and deal with a little bit of tachycardia afterwards. And like I say, I don't use it for all the patients, but the smaller, sicker ones where a bradycardia is going to be, could be the end event for this child. Prevention is better than cure. So I'm going to go ahead and click on yes. Okay, so we go ahead with the CMAC. We don't have any trouble getting a grade 1 view. We do need a little push of adrenaline because the blood pressure drops slightly after the induction agents are given. And we go ahead and put our 3.5 on cuff tube down. Unfortunately though, there's a large leak around the tube after it goes down, and we need to go back and change it over for a microcuff tube. The baby tolerates that fairly well, and we don't need to give any atropine, we don't need to give any further adrenaline for the second tube change. Okay, so we'll go back and reassess the patient following intubation. We've got a microcuff tube, 9.5 centimeters at the lips, and a useful formula for you to remember is you take 6 and add the baby's weight to it. So our baby's 3.5 kilos, add 6 onto it, gives you 9.5. And that's where the tube should be at the lips. add an extra centimetre on for a nasal tube. We put the baby onto the baby pack ventilator, fairly standard settings, 25/6, rate of 30, I time of 0.6, in 40% oxygen. On that, SATs are 99%. Listening into the chest now after intubation, the air entry is much better, but there's still a few transmitted sounds about. Going on to the circulation, things have improved there as well. We've got a heart rate down to 162, we've got a MAP of 44 and a cap refill down to 3 seconds. We can now feel the peripheral pulses as well, which is good, and our systolic murmur 1/6 remains audible all over the precordium. That's after 2 20 mL per kilo fluid bolus and 2 pushes of adrenaline, 1 mic per kilo each. One of those pre-intubation and one of them for the slight drop in blood pressure during the intubation attempt. But we're now 10 minutes past that and haven't needed any further adrenaline. Going on to look at D, no further seizure activity, although it's important to remember we are sedated and muscle relaxed at this stage. As you'd expect in a sedated muscle relaxed patient, coma scale is 3 out of 15. Pupils are size 4, they remain sluggish to light. We've got a BM of 6.7 and the anterior fontanelle remains full. Okay, so the next interactive slide then, we've got a series of potential interventions we can do at this stage. So again, I want you to go over to the YouTube chat, vote on which of these we should do at this stage. Importantly, if you leave it out from your list, I'm going to take it as a no, you don't want to do it. So the potential interventions we can do, we can convert the oral endotracheal tube over to a nasal tube. We can do another blood gas. We can start an adrenaline infusion, put a second line in, send off some bloods, put a central arterial line in, give some antibiotics and a cyclovir, do a chest x-ray, start some Proston, do a lumbar puncture, and do a CT brain. So I'll give you a few minutes to get your answers in. Okay, so starting off, I know your answers are still coming, but I'll start off with the oral to nasal endotracheal tube conversion. Your answer to that one was a no, and I think this is absolutely the right answer. Why would you even think of doing that? Well, it varies, the practice varies throughout the world, but certainly in Northern Ireland, we do like a nasal tube in our patients in the PIC unit, if possible. And that is very much if possible. The patient has to be stable enough to tolerate it. And the reason for that is the failure risk with a nasal tube is higher. It's a technically more difficult procedure. Rather than passing a tube straight down the trachea, you're having to bring a tube all the way up and then turn it down. So your failure rate is higher. And our baby is a baby who will not tolerate a failed intubation very well at all. Even if you were to change the tube over and have no problems, you've gained yourself nothing in the District General Hospital, because the advantages of changing the tube to nasal, it's more comfortable for the patient, so you can run them on a bit less sedation, and it's less likely to fall out. But you're going to keep this kid sedated and muscle relaxed. So you have no advantages. There's potential disadvantages of failure. And the biggest disadvantage, I think, in this scenario, even if it goes smoothly, is while you're doing an unnecessary job, there's 20 other necessary jobs that you're not doing. So I wouldn't recommend this at all. Repeat blood gas. Did we want this? Okay, so I'll click on this and show you your repeat blood gas. Okay, so we can see the pH is improving. Are you okay just to mute your Zoom chat, Ben? Yeah, pH is improving. CO2 is still up a little bit at 6.5. Probably the best way to bring that down would actually be to do a bit of suction rather than turn the ventilator up. We can still hear some transmitted sounds in the chest, and that's a very important thing to do shortly after you intubate a patient. Base X is improving, lactate is starting to clear, sodium still normal, potassium is still high, but importantly it's still a squeeze sample. Looking at our calcium, it's come up nicely over 1, which would be our target. following a calcium correction. And the hemoglobin's dropped a little bit down to 178, but that would be in keeping with the baby who's had 40 mils per kilo of fluid and a little bit of dilution from that. Okay, adrenaline infusion. So that was a yes. So we can go ahead and start an adrenaline infusion. I would maybe be tempted not to start it at this stage, given the fact that we've given a push of adrenaline last 10 minutes ago, and despite that, the blood pressure has actually continued to improve from where it was even during the intubation. The fact that our lactate's clearing, the fact that our pulses are improving. Starting it, I don't think there's anything wrong with it, because it's probably the safer option to start it, and then you can always wean it down to stop. An alternative option would of course be to get it prepared, because that's one of the slow bits. Have it attached so it's ready to run should the blood pressure drop again, and we're not going to have to go back to push dose adrenaline. Peripheral adrenaline is really easy to make up. I'll just do a quick recap on it. What you want to do is put 1 milligram of adrenaline in 50 mils of saline, and I appreciate we're people watching from all around the world and there's lots of different ways of doing this, but I'm going to tell you my way, and if you don't have a way then you can copy this. So 1 milligram of adrenaline in 50 mils of saline. So that's one of those little ampules of 1 mil of 1 in 1,000, or one of the pre-filled syringes, 10 mils of 1 in 10,000, made up to 50 mils with saline. What you want to do is run that at 0.3 times the patient's weight in mils an hour. So for our 3.5 kilo patient, it's about 1 mil an hour. And that's going to give you roughly 0.1 mics per kilo per minute, which is the starting dose I would use for most hypotensive patients. One of the key things about starting this, and this is the commonest mistake I would see, and this mistake causes you more problems in a small baby, is forgetting about the dead space. If you look at the picture I have on the slide, the little cannula has a dead space of 0.1 mils. The connector going onto it has a dead space of 0.3 mils. So a total dead space of 0.4 mils. If we were to start that peripheral adrenaline infusion on our baby, it would take over 20 minutes to get through the dead space and reach the patient. So one of the key pearls I would share with you today is know the dead space of the equipment you're going to be using, and particularly when you're dealing with small patients. So you can bolus the drug through that dead space and it's going to reach the patient without any delay. Okay, so we'll go ahead and start that peripheral adrenaline infusion. Second line, and I think that makes perfect sense now. We've got time to do that. So we go ahead, and luckily now the baby's perfusion's a little bit better. We're able to get a cannula in the back of the left hand. And as we get that cannula in, we are actually able to get a little bit of blood from it. It's not enough blood to do all the blood tests that you can possibly think of, but we can do 3 from the following list. So I want you to go over to the YouTube chat and vote on which of the 3 tests we should do from this list. So your choices are full blood picture, coagulation screen, UNE liver function and CRP are one test, bone profile and magnesium are another. We've also got blood gas, blood culture, ammonia, group and cross match, and meningococcal PCR. So go ahead and vote now. Okay, so the 3 tests that you guys have chosen were blood gas, UNE liver function and CRP, and ammonia as well. Okay, so we're going to come back to those a little bit later on. Okay, central and arterial line, did we want that? Okay. So there was a no to a central and arterial line at this stage. Antibiotics and acyclovir? Yeah, I think this is a must. Sepsis is probably the most common cause of a collapsed neonate. So I think it makes sense to cover for that, and I think you're going to have to do that with every collapsed neonate that you encounter. So cefotaxime and amoxil should cover any bacterial infections, and we also need to cover herpes as well. So I would add acyclovir in, particularly given the abnormal neurology in our patient. Chest x-ray. Okay, so you've said no to that. I'm assuming that's an admission in the YouTube chat rather than you wouldn't really do that. So I'm gonna be kind and show you the chest x-ray. I don't believe anybody would intubate a small neonate and not do a chest x-ray. So I'll show you the result of that one. So you have a look at the x-ray there. You can see the endotracheal tube is adequately positioned. We've got a nasogastric tube down below the diaphragm. Heart size, I've said, is really important and one of the main reasons for doing the x-rays in these collapsed neonates, and we can see we've got a fairly normal looking heart size here. Lung fields are a little bit hazy, but there's no big focal changes in them, so a reasonably normal x-ray with adequately positioned tubes. Starting a McCrossan infusion. Yeah, you've voted no to that, and I would at this stage agree with that. Wouldn't have been wrong to have started it earlier on, but I think at this stage, given the information that we have, we've got an improving hemodynamics, a blood pressure that's improved, our peripheral pulses have come back and are now palpable, we've got a clearing lactate, and we've got now a normal looking heart size on a chest x-ray. So I think it's unlikely this baby has a duct-dependent congenital heart disease because things have improved. And if it was this, we haven't actually done anything that would have made it better, and I wouldn't have expected the baby to improve if this was the cause. So I would agree starting it at this stage was probably not the right thing to do. Lumbar puncture? No, and I would agree with no here. It's completely contraindicated. We've got a baby who's postictal. They're potentially septic, so we may well have deranged clotting, low platelets. So lumbar puncture completely contraindicated at the moment. CT brain. So yes to CT brain, and I would agree with this at this stage. We're always keen in paediatrics to avoid doing a CT brain given the radiation involved with it, and particularly when we have an alternative, which is ultrasound. We can look in at the brain without any radiation. Now there's one major thing that's concerned. There's a couple of things that concern me, but one thing that really concerns me about this patient, and that is the sluggish pupils. The bulging fontanelle is a concern, the seizures are a concern, but the sluggish pupils to me are a real concern. So I would be doing a CT scan on this patient. So I'll go ahead and show you that. Okay, so our CT scan showed generalized cerebral edema in this patient, so worth doing. In the past, I have used the argument that I'm going to try and avoid radiation. I'll maybe do an ultrasound, and if the ultrasound is okay, I'll reassure myself that I don't need to do a CT. I have learnt from this, and I have had patients that have had significant intracranial pathology but had a normal ultrasound. So this baby I would recommend doing a CT on. Okay, so we'll go back and look at our bloods. So the ones you had chosen were, we wanted UNE liver function CRP, we were going to do a blood gas, and we were going to do ammonia. So I'll let you have a look at the results on the screen there. So I think to maybe point a few of them out, so we've got a normal sodium at 138. Potassium is actually normal in the serum at 4.9. Urea 2.6. Creatinine maybe a little bit out of keeping with that low urea at 82. Bilirubin's up a little bit at 139, but we're a 3-day-old baby. Liver enzymes are a little bit deranged. CRP less than 1. Going over to look at our blood gas, we can see things have continued to improve, which is what we would expect. Lactate's down to the normal range, 1.8. Calcium's up following the correction, and the hemoglobin remains stable. But the big important result here is the ammonia of 983. So this was the test you had to send off, because if you hadn't sent it off, you wouldn't have actually known about this. So let's go on and look, and I'm going to ask you now to vote over in the chat. Which of these do you think is the most likely diagnosis given the information that you have at the moment? And I'll give you a few minutes to get your votes in. Yeah, so we can see the results coming in are very clearly metabolic. If you didn't have that ammonia, You might go down a different route. Sepsis meningitis would very well fit into this. As we know with ammonia, one of the key things is picking it up early. So I would strongly encourage you to send this off early in any collapsed neonate. Okay, so we're going to go on to our last lot of potential interventions that we can do. So we've got a list on the screen. What I want you to do is go over to the YouTube chat and include everything in your list that you think we should do at this stage. Leave anything out that you don't want us to do. So I'll run you through the options while we're waiting. So we've got hypertonic saline, 2/3 maintenance fluids, normal saline and 5% dextrose, neuroprotective measures, an arterial line, loading doses of sodium benzoate, sodium phenylbutyrate and arginine, time critical transfer, and discussion with a paediatric metabolic consultant. So I'll give you just a minute or two to get your answers in. Okay, we'll make a start at going through the list. I know more answers will come in as we're working our way through them. Hypertonic saline. So the vote was no to this. I probably would give this baby some hypertonic saline. And the reason is we've got clear signs of cerebral edema on a CT brain. We've got a baby who is suffering from the effects of that. They've had seizures, they've got a coma scale of 3, and they've got pupils which are now sluggish. So it makes sense to me, a swollen brain, to try and relieve it, give some hypertonic saline, draw some fluid out of the brain, and potentially fix that problem. So I personally would give this baby some hypertonic saline and would recommend you do the same. The 2/3 maintenance fluid is normal in 5. No, and no is the right answer here. The dextrose concentration is the error here. When you've got a metabolic baby like this, you want to make sure they're anabolic, switch off catabolism. And to do that, you're going to need a glucose delivery somewhere between about 8 and 10 milligrams per kilogram per minute. So 5% dextrose in restricted amounts aren't going to do that for you. So you're going to want to hit the baby on 10% dextrose, and any of the infusions you're making up, you're probably going to want to put in 10% dextrose as well. Neuroprotective measures, yeah, and again, that makes sense. That goes with the hypertonic saline. We've got a baby with raised intracranial pressure, cerebral edema. We're going to do simple neuroprotective measures. I'm not going to dwell too much on these because Stephen's going to cover these later on in his talk, but simple things like keeping the baby head up 30 degrees, making sure you control their CO2 and their oxygen, making sure you've got a good blood pressure to perfuse the swollen brain. Simple things like that. Arterial line, no, and no is the right answer here as far as I'm concerned in most of the cases. And the reason it's a no, a lot of you may be questioning that, is because you need to take a step back and look at the big picture for this baby. So this is a baby that has a significantly elevated level of ammonia. And what we know is that the higher the ammonia is and the longer it's elevated for, the worse the neurological outcome. So we need to get this ammonia reduced as quickly as possible. There's a range of treatment options, and Siobhan, who's going to follow me, is going to talk on a lot of these after me. You do simple things. You put the baby nil by mouth. You're going to maximise their glucose delivery so that you make them anabolic rather than catabolic. You're going to start some of the metabolic drugs that Siobhan's going to touch on later on as well. But these will maybe bring an ammonia that's 300 down in a timely manner to a safe level. But an ammonia of 900, they are not going to bring down quickly enough to preserve this baby's brain and give them any chance of a good neurological outcome. The only way to do this is with filtration or dialysis. So your goal now is to get this baby as quickly as possible, but it has to be safely, but as quickly as possible to a centre that can put them on to a filter. So anything that delays that unnecessarily is not going to be in this baby's best interest. So this, I would not recommend you put additional lines in, particularly given our baby's now cardiovascular stability at the moment. If you give me a choice of being on a filter 30 minutes earlier or being on a filter 30 minutes later with an art line in, I would certainly pick the first one, being on that filter 30 minutes sooner. The one circumstance, if you have a massive team of people involved and the art line can be put in while it doesn't delay the time critical transfer, by all means do that. But in my experience, it distracts the rest of the team from the true goal, which is the time-critical transfer to definitive care. The metabolic drugs, I think, are exactly the same story. Do you know where you're going to get these in your hospital? Do you know how to make them up? I would imagine it's going to take the best part of 45 minutes to an hour to work all this out. That is going to distract the rest of the team. It's going to take team members away from preparing this baby for a time-critical transfer. So most of the circumstances, if you can get this baby out the doors and on a filter, that's probably in their best interest. If there's some unnecessary delay with the transfer, or you have a really effective team where these can be made up in series to getting the baby prepared for transfer, by all means go ahead with them. And Siobhan's going to talk a little bit after me about some tricks and tips for actually preparing these drugs and show you how you can get a reference to do it. Time critical transfer, I've already answered that one. This is the key goal. And I'm going to share a peril with you that one of my consultant supervisors taught me in the past. And that is the very moment you realise you've got a time critical transfer. And that is the moment somebody tells you the ammonia is 900. You call a blue light ambulance at that stage. And the reason for that is if you have two paramedics standing at the bottom of the bed with their arms folded or their hands on their hips, you are not going to do any unnecessary interventions for that child. You're not going to put arterial lines in, you're not going to put catheters in. That is going to be your prompt to get that child out the door and to definitive care as safely and as quickly as you can do it. And then the final one, discussion with a metabolic consultant, is an absolute must, and we're going to do this in our case. We're going to go to Siobhan shortly. The other team you want to discuss with is the PICU, so that when you arrive through the doors, they have a filter run through and they have somebody scrubbed and ready to put the VAS cath in. So there's absolutely no delay in getting this kid on a filter. Okay, so in summary, the differential diagnosis of a collapsed neonate is sepsis, cardiac, metabolic, and non-accidental injury. I'm going to add a fifth one to this, and this is from having edited some others' talks from Paediatric Emergencies 2020, and then reflecting back on my own experience over the last few years. And the fifth one I would add in is the surgical abdomen. Think of things like a malrotation and a volvulus and ischemic gut as a potential cause of a collapsed neonate as well. We always learn as we're doing these, and I've added this on. This used to start as an original 3, non-accidental injury got added into it, and I'm going to add the surgical abdomen on as well. Remember to resuscitate the hemodynamically unstable patients before you intubate them, otherwise you'll find yourself doing CPR. Don't forget to send an ammonia. If you hadn't sent the ammonia in this case, you wouldn't have got the diagnosis so quickly. And then remember, once you find out the ammonia is elevated, remember reducing it quickly is time critical. So try and get that done straight away. Okay, so hopefully you do have a few questions for me. In the purposes of time, I'm going to take my questions together with our next speaker. It's also going to avoid me having to deal with any of the difficult metabolic questions. So our next speaker is Dr. Siobhan O'Sullivan. She's one of our consultant paediatric metabolic consultants in Belfast, and we're going to head over to her talk now, which is dealing with hyperammonaemia.
Good morning, ladies and gentlemen. Thank you for asking me to come to talk this morning. And today the question I'm posing is, what if this is hyperammonaemia? And this is very much a follow-up from Chris's talk earlier. So the way this talk is structured is, the most important thing is to recognise high ammonia. It's the what, when should I do the test, why, when and how. Then we'll look at some case studies, some diagnostic triggers just to make you think when to do an ammonia, making a diagnosis, and then your treatments, particularly if you have a patient out in the DGH who's got a high ammonia. The question is, what are you going to do next? The practicalities, the challenges, the acute management, and a little bit on long-term management. So ammonia is the breakdown of protein catabolism, and it's converted to urea in the liver by a series of enzymatic process in what's defined as the urea cycle. I'm not going to elaborate too much on that. And urea then is harmless and it's excreted in the urine. Why is it even important? Ammonia is toxic to the brain. It causes neuronal toxicity and astrocyte swelling. It is actually a medical emergency. It's time critical. And the problem is, particularly when you're speaking about a neonate, encephalopathy is very vague, can be very difficult to pick up, and even very experienced clinicians can have a problem, let alone people who aren't used to pediatrics or neonates. And the important thing is it's early recognition, because the earlier you think, oh, is there a problem with ammonia, the quicker the test is done, and then it can be actioned. So the question is when to think of ammonia. It's whenever there's a sick neonate. And again, as already alluded to in Chris's case scenario, is you have a sick neonate. Is it normally people are thinking, is it sepsis, cardiac, but also in the differential, is it metabolic? And the times that you particularly think about is was the baby a term baby who was born in good condition, who then had a period for 24, 48 hours where they were actually feeding well and clinically a well baby. And then what happens is the baby may just go off the feeds, may have a little bit of vomiting, not quite waking up. They may be breathing a little bit faster, or if they get sicker, then they may have poor perfusion, full fontanelle. So it's unexplained lethargy, a floppy baby, vomiting, or much further on, it may be seizures. So it's a sick neonate and you're not really sure what's happening. And your differentials really for a sick neonate are sepsis, which we're very good for treating. Then people think of cardiac, and what I want to do is raise the profile of maybe is this metabolic and to do the appropriate investigations. The other one that's very important for a neonate is it a trauma and consider NAI or a low sugar. Older patients can also present with problems, I know, and this may also hold true for the adult population as well. And the symptoms are a bit more vague. Are there episodes, and there can be cyclical episodes where they have episodes of headache or not quite with it, in an extreme case coma, or they may have periods where they have quite bizarre behaviour and acting totally out of character, or they're presenting with seizures, or some patients can present with episodes of vomiting, abdominal pain. Some patients will present, they really don't like eating large amounts of protein. And they have protein aversion or have a bit of vomiting, or they can have hepatomegaly. Or another story is particularly a woman around childbirth can get quite unwell, and that might be a trigger to make you think of, is this some sort of a urea cycle defect? So for older patients, they can be episodes of unexplained encephalopathy, episodes of bizarre behaviour, psychosis, or cyclical vomiting. So the question is, how are you going to make measure ammonia? So it's 1 ml of free-flowing and an ETTA sample. It has to get urgently to the lab. It's on ice, so you need to phone the porters, phone the lab, and get it there on ice as fast as you can. Every hospital who does acute 24/7 call should be able to measure an ammonia. There are problems, and sometimes there could be some fraught with difficulty, particularly if you're doing ammonia, and sometimes things like jaundice can falsely raise the ammonia, or lipids can lower the ammonia, and the lab will say, oh, sorry, we're not going to give you a value. Particularly if you've high levels, it's important you say to the lab, actually, if you're in the thousands, the important thing is I actually want a rough number. The specific number isn't important, just I need to have a number and then look at the trend. Because sometimes they say, oh, there's a bit of interference, and they won't issue the number. If you're really suspecting a high ammonia, you have to push them for it. What numbers are you going to get worried about? Preterm neonates, particularly sick neonates, can have higher ammonia. So anything over about 150, you start getting worried. Is there an inborn error of metabolism? Or neonates over 100. And then for children and adults, you would have said anything over 50, you'd start getting worried of. If an ammonia is high, and if you're talking about 300-400, you need to repeat that ammonia straight away. So you get your porters, bring them up, and you repeat this straight away. What are the causes of a high ammonia? One of the difficulties is the sampling. There can be then primary or secondary causes, and I'm going to do a little bit about these. So I'm going to go through a couple of cases with you because, I think this is how people learn. So the first case is a term baby who was breastfed and breastfed very well initially, and then just became a little bit lethargic, poor feeding, the end of day 2, early into day 3. By day 4, this baby was very sleepy, and the mum was anxious. An older sister had died, query sepsis, on day 7 of life. And on looking at this gas, what we can see is a respiratory alkalosis, which is quite uncommon. The pH 7.6 and CO2 1.2, and the other thing is the urea is 1.5. So in these cases, wherever you see a respiratory alkalosis with that history, you're thinking of, is there a urea cycle defect? So the causes of a respiratory alkalosis is there hyperventilation, anxiety, but the one, particularly in this context, is there high ammonia, because it acts as a central respiratory stimulant and it reduces CO2. And the other clue there maybe is a low urea, because you're not making the urea in a urea cycle defect. The ammonia was elevated at 284. Whenever you have a history of an inborn error of metabolism, you're going to stop feeding, give the child as much dextrose as you can. And this child was transferred to paediatric intensive care, where they repeated the ammonia, and it was 120. The next case, again, I'm just going to go through was a term male, again, bottle fed, was initially very well, discharged home on day 1. But on day 2, the midwife went out, and what she noticed was actually this child was breathing very fast. He had a respiratory rate of 110 and was referred urgently into ED department. And initially the child looked reasonably okay. Respiratory rate was 80, SATs were good, and the child was bottle feeding, and the questioning was there sepsis, cardiac, and then you come down and look at the gas, and again there's a respiratory alkalosis, pH of 7.53, with a CO2 of 2.2, and again you're raising questions, is this a urea? That's kind of your early sign, is this a urea cycle or some sort of a problem with ammonia? So the ammonia was elevated at 380. Again, you're stopping feeds, give as much dextrose and scavenger medication. I'm going to elaborate a little bit more on these later. And they started hemodialysis. The next one is a term baby. Again, a big baby who was discharged home. And this probably one is a bit more like Chris's case, where the child is much sicker. Day 2, the child was sleepy, poor feeding. It was again, this family history is very suspicious. There was a baby with neonatal encephalitis, mum's brother and mum's uncle. So there were 2 deaths on the male neonates. And this child was hypothermic, seizures, lip smacking and apneic episodes. Differentials when you're seeing a baby like this is, number 1, is it sepsis? Low sugars, is there some hint of NAI, or the other differential would be a metabolic. And again, this child was much sicker, so the gas now, you've gone more acidotic, but the ammonia in this case is extremely high at 983. On CT of brain, there was some cerebral edema. The repeat ammonia was 1,600. The child, as in Chris's case, was started on antibiotic, anticonvulsants, started on dextrose, intubated and transferred to PICU, had ventricular tachycardia. The ammonia was huge at 2,500, and at this stage the decision was made to withdraw care. Your triggers for what makes you, if you don't ask for the ammonia, you're not going to know it. So things that make you think about it is, are there posters around ED, PICU, on sepsis packs, on gas machines, are people thinking, if it isn't sepsis, is there an underlying metabolic disease, and to think about it. And if you're giving antibiotics, at least consider, are there other causes? So when we're doing ammonia measurement, it's a very difficult test. There are special ammonia-free tubes. There's always a delay, can be a delay in assay, and in neonates, it can be difficult venipuncture. In the metabolic world, the biochemistry network, how they want your ideal sample is ammonia should be free-flowing, venous sample, should arrive to the laboratory within 15 minutes, ideally on ice. This is very difficult to achieve in the real world. The causes of high ammonia are, could it be an pre-analytical problem? Is an acquired high ammonia, or is it due what we call the primary inborn errors of metabolism, such as urea cycle defect, organic acidemias, disorder of fat metabolism, or other ones? The secondary causes can be transient hyperammonaemia of the newborn. Children with sepsis can have high ammonia, liver failure, herpes simplex children can have very high ammonias, or anybody with liver failure, or the other one is children with UTIs with stasis. I was just going to go a little bit about the urea cycle. So ammonia through the urea cycle is converted to a harmless metabolite urea, and all of this happens in the liver. This is the reason why we ask for certain investigations, because you're trying to work out where the problem is. So this is why we will ask for ammonia, orotic acid, and plasma amino acids. Depending on the blood level of ammonia, you may have an idea of what the condition is. In sepsis, the levels can be high, but they're probably about 200. Disorders of fatty acid oxidation, the ammonias can go up to 500, whereas conditions such as the organic acidemias or the urea cycle defects, the ammonias can be incredibly high, up over 1,000, and urea cycle particularly can be over 1,500. When we're asking for investigations, in metabolic terms, we normally say we do our first line, which is our test in any sick infant, and these results are available in minutes and hours. Second line, you're specifically looking for the disorders of inborn errors of metabolism, and these results are available in hours or could be a day. And then third line is confirmatory testing, which are probably genetic testing, which could take weeks or months. So when we're making a diagnosis, our first line investigations, full blood count, use and ease, a blood gas, an anion gap, ammonia, lactate, sugars, and blood ketones, CK, LFTs, and urine ketone bodies. Second line investigations we're asking for are plasma amino acids for the urea cycles. Acyl carnitines would help us, which should be a dried blood spot and a plasma acyl carnitine, and this is particularly useful for the organic acidemias and also the disorders of fat. You look for urine organic acids and also urine orotic acids. So the approach is the ammonia, you probably repeat it. Is there an acidosis? Is there an anion gap? Ketones present or not? Because that will, what's the amino acid profile and orotic acid? So all of this would help us work it out. The important, if you're in DGH and you have a high ammonia, this is really the bit that you probably want to get to, is how am I going to manage this and transfer this child? This is a time critical transfer. This child needs to get to a unit, ideally with a filter, within 4 hours. You need to do a discussion with your PICU colleagues and also the metabolic team. When we look at Northern Ireland, you can see that some of these hospitals like Achnagevin and so on are almost 1.5 or a little over distance away. So for a retrieval team to go out and come back, you're almost at 3 hours without doing anything. So the onus really is on the local team to transfer these patients to a centre with a PICU with a filter available. So the reason why it's a time critical transfer is because your outcome is dependent on your age of onset. It's worse in the neonatal period. How long if the child's in a coma and seizing, how high is the ammonia and what the underlying condition is. The outcome is probably worse for a male OTC who's coming in, who's in a coma presenting in the neonatal period. The emergency management, supportive care, and Chris did a lot of that care, and I'll elaborate in a minute, replenish depleted products, removal of your toxic metabolites, which is through your scavengers, drugs, and to prevent load on the affected pathway, which is to stop your protein. Supportive care is essential, and what you're trying to do in all metabolic conditions is to reduce further catabolic stress, reduce energy expenditure, and to prevent secondary complications, and to correct dehydration, any disturbance in acid-base disturbance, treat hypothermia, electrolyte disturbance, and treat hypoglycemia or hypocalcemia. The emergency management is to stop all feeds. You stop protein because you don't want that, and you stop all amino acids. The way you stimulate anabolism is you're going to give as much sugar as possible, glucose as possible, and you're aiming for at least 8 to 10 milligrams per kilogram per minute. So as much sugar as you can, glucose as you can. And if you're in a DGH, the important thing is to stop feeds, get them on 10% dextrose. Then the next important is to start scavenger medication. And these are sodium benzoate, sodium phenylbutyrate. You're also going to give arginine. These drugs, the scavenger drugs, are in sodium, so it's important you don't give too much. So 10% dextrose and add in the scavengers. Most of the DGHs don't have the scavenger drugs. We may discuss whether or not you should have them. They probably should. The important thing is not to delay transfer. It's to stop protein, stabilise the child, start them up on 10% dextrose and get them to the centre. The question is whether or not you're going to, not all of these patients will need a filter. The numbers you're thinking about whether or not you decide to filter is above is about 400 or 500. It's again a risk versus benefit, because to put somebody on a filter, they're probably a neonate, so you need to have the correct size of the equipment, you need the team available, the experience to use the equipment, and do you have all the staffing? There are other issues are, could there be bleeding problems, hypertension, how used to the staff of using this equipment? How long are you going to have to continue them? And that's depending very much on the condition and when to stop it. And this will depend very much on how fast your ammonia comes down and at what level. In metabolics, we have the British Inherited Metabolic Disease Group, and these are guidelines. Included in this are the guidelines for all the metabolic emergencies. So this is what we use here and also everywhere in the United Kingdom. What you're going to do is go onto the British Inherited Metabolic Disease Group and go in under hyperammonaemia undiagnosed. And then this will open up and it will give you, also included, it'll give you the guidelines, and it will also give you a calculator. For people who are not used to using the scavenger drugs, it can be quite difficult and people aren't used to doing the calculations. So what you would do is open up this calculator, put in the child's weight, and then for benzoate and phenylbutyrate, you give a loading dose and you start a maintenance dose. And these are all very standard. So you type in your 4 kilos and they will give you how to make it up. The important thing for arginine is you actually have to know what your arginine dosage that your particular site uses. All of these medications, the sodium benzoate and phenylbutyrate, can be made up in 10% dextrose. What I'd like you to do is, over the next minute or so, is to actually go into the BIMDG, have a look at the guidelines and go into the undiagnosed hyperammonemia, look at the protocol and make sure you can find it. And then actually go in and open up the calculator. And try it out for a 4 kilogram baby. So as I've already alluded to, your prognostic factors are really your age of onset, how long the child has been in a coma or unresponsive or encephalopathic, how high the ammonia is, and what the underlying condition. And so the important thing is, if you don't think of doing the ammonia, it won't get tested and we may not make the diagnosis. I just wanted to have a look at the survival figures, and these are the older figures before really ICU went to having filters. So this was an open labelled uncontrolled study of 299 patients where there were over 1,000 episodes of hyperammonemia. 93 were of neonates. The overall survival rates were 84, but the survival rates were much worse for the neonates, 73%. Survival rates for neonates with ammonias over 1,000 were only 38%, and they were by far the worst in the male with the OTC deficiency, who were coming in comatose or who had seizures at admission. So we want to catch them before the levels get to these, if possible, to those levels. This is a study which is a more recent study, but that was carried out in Japan. But at this stage, in the latter part particularly, it's where ICU management was much better, hemofiltration and CVV was much better as well. So the 5-year survival for the OTC deficiencies were much higher, 86% of the neonatal onset type. What they felt though, which was children were likely to have some sort of neurological problem if their ammonias were higher than 360. And this is why they were proposing the more long-term management. They're suggesting early onset liver transplantation is able to prevent the complications and provide a good chance for outcome. And I'm just going to go through some of these in a little while. So you get these patients through the acute episode, but every time potentially somebody with a urea cycle defect has an intercurrent illness or a vaccination, they're prone to have another further episodes of hyperammonemia. These patients go home with what we call a grab bag, in which they go home with the IV sodium benzoate phenylbutyrate and also the arginine, so that when they go into their local hospitals, they can present to the local team, here's my emergency plan, here's my medication. The local team should also have it available in their ED department, because they can't always come here to the RBHSC. They will initially have to start their treatments and be transferred. Long-term management, these patients are going to be on dietary management, which is they're going to have a protein restriction. They're going to be on lifelong scavenger medication, and we have to manage their intercurrent illnesses. So potentially they could come in and the neonatal, the ones who present in the neonatal period are normally have less enzyme activity, and they're ones who are probably going to come in recurrently. Liver transplantation, looking for particularly for urea cycle defects, the literature is very good. The overall survival rate is over 90% for 5-year survival. These patients, after liver transplant, can go back onto an unrestricted diet, eat as much protein as they want, stop the scavenger medication, and their ammonias can normalize within a couple of days. But liver transplantation is not for all of them. It's much more likely to be discussed for the neonatal ones or children who are going to come in for recurrent episodes. It's a question of, like all conditions, risk versus benefit. You are substituting a urea cycle for somebody who's got liver transplant. So it's one condition for another. What you're doing in transplantation is giving them enough enzyme. There are ways to carry it out. It can be elective, which is, you do not want to do this when somebody's having a high ammonia, critically unwell. Ideally, you get the patient in as good a condition as you can. An elective will have a much better outcome. Living donor is an option. Ideally, you want the perfect operation for the perfect donor, and we also in metabolics can do domino transplants as well. There is also another therapy, which is cell therapy, hepatocyte transplantation. It will happen. What you do is give liver cells, hepatocytes. It normally would happen after somebody's had a neonatal presentation of high ammonia. It's a bridging procedure until they're big enough or until a liver transplant potentially can become available. It's used for stabilization, get them better, but again, you have to get that patient through that initial hyperammonemia crisis, get them into an episode of stability. This could then stabilize them until you're going on to potentially doing a liver transplantation. So coming to the end, really, hyperammonemia is treatable. The outcome of severe hyperammonemia is poor. This is why it's time critical. It's important you think about it and treat them early. Early consideration can be and is life-saving. And ammonia, if you don't request it, it doesn't get done. You have to think about it to do it. And if anybody has any questions, concerns ever, please just phone the metabolic team. We're more than happy to discuss these cases. Thank you.
Listen, thanks very much, Chris, for that interactive talk, and Siobhan for a real useful summary of this metabolic issue. And it's obviously something which is very complex for a lot of paediatricians and scares a lot of us. I know for you during the chat you were saying that it's very logical, it makes sense, and it's easy. But I guess it all depends on your level of comfort. So really good, engaging talks. I'm going to hand over to Tudor. He's a couple of questions, I think, for Chris first, and then we have a few for yourself, Siobhan, but we'll maybe go to Chris first.
Okay, so Chris, one of the first questions that came your direction during your talk was about the timing of medications, and there was a couple of them. I'm going to combine those together. So the first one was, why not give the antibiotics early? Because it can be given as a push, it can be given quite quickly. And along with that was the comment as to the use of the scavengers in the metabolic condition. Why not just give them while waiting for the retrieval team?
Yeah, they're both excellent questions, Tudor. And I think you can answer them all with the two words, human factors. Every intervention you do has a positive as well as a negative. And if you follow a piece of paper which says do this, 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 and this, by you doing one of those interventions, there's a negative to them. So I am by no means advocating delaying antibiotics in a sick, unwell child, but I don't think there's any downside to giving antibiotics at 5 minutes versus 2 minutes, and using those 3 minutes to do other slightly more important jobs. So the jobs I would have done at that stage would have been fixing the blood pressure. I think fixing the blood pressure trumps giving antibiotics. Pre-oxygenating the child properly, I would say that trumps giving antibiotics 3 minutes earlier. So they would be jobs I would prefer to do, but by no means am I saying they should be delayed. It's just when you have 10 essential jobs to do, you have to prioritize them. Moving on to the second question about the metabolic drugs. If you work in a perfect system, by all means, you would have these in your emergency department. You would know how to make them up, and there would be no difficulty making them up at all. You would have a massive team of people that would be able to come. Somebody would be preparing the time critical transfer. Somebody would be doing the metabolic drugs. We work in the real world where there's shortages of staff, the knowledge on how to find these things. In fact, I would argue most hospitals probably don't have them. And if they do, nobody knows where to get them. And the downside of sending somebody to go and look for these and make them up takes your team away from the ultimate goal, which is a time critical transfer. On another point, the retrieval team should not be coming to get these children. The local team should be transferring them. When you have a time critical transfer, be it a head injury, which needs neurosurgical intervention, or an incredibly high level of pneumonia, which needs filtration, the retrieval team coming out to retrieve that child and bring them back is a slow way of doing it. So the local team must bring them. If the local team are struggling to make up metabolic drugs, they are not going to be prioritizing getting this child to a center which can filter them, which is the ultimate goal. So I can answer the two questions the same way. I think it's a situation where you have many more jobs to do than you have resources, and just saying to do it has some negatives on some of the other things that you could do. So okay. I advocate early antibiotics and sepsis most definitely. And certainly if you have all the resources available, please start these metabolic drugs, but remember the downside to the interventions.
Okay, that's great. Another question combined again from Hannah and Johnny. Recognizing that ketamine, although it's one of the most cardiac stable drugs that we have, when you have a child who's maxed out on their catecholamine response already, it can cause some cardiac instability. Would using fentanyl be better than ketamine?
Yeah, I think a lot of this is sticking with what you know and what works well. And I think ketamine is highly regarded as one of the safest, from a cardiac point of view, induction agents to use. And it's what I use when I have a septic meningococcal with no blood pressure who we're pushing adrenaline and fluid into. I use it in significantly reduced doses. Fentanyl, I find to get a dose that will have a sedative effect, you have to actually use quite a big dose of fentanyl. The low doses, 1 to 2 mics per kilo, will provide quite good analgesia, but I don't find you get enough sedative from those, and you're having to use bigger doses to get that sedative effect. And I think ultimately those bigger doses will have more effect on blood pressure. Although you could argue that either way, I think the most important thing is you're using something that you are familiar with. Fentanyl is a good choice as well. But again, you're going to want to reduce the dose of it down as well. And if you're certainly from a neonatal practice and you're very used to using fentanyl, I would definitely not advocate you go to a drug that you're unfamiliar with. Because you look up the dose of ketamine, 2 milligrams per kilogram is what the book will tell you. You give this child 2 milligrams per kilogram of ketamine and they will arrest on you. So I think stick to what you know. There's more than one good option. You have to tailor it to the circumstances you have, the team you have, and the resources that you're familiar with.
Great, thank you.
Yeah, thanks, Chris. And Dr. Sullivan, thanks again for that talk. It's great you could join us for a few questions. There was a few came through in the chat. First one was from Carl, which basically is asking, can hyperammonaemia present for the first time in an older child? And if so, why might that be the case rather than presenting at a younger age?
Yeah. Okay. Yes, it can definitely present as an older child. We've had a couple in the Children's Hospital, one chap who presented at about 18 months of age, and it's with an intercurrent illness. He decompensated and he turned out to be a male OTC patient.
Okay.
So normally, if you're the more severely affected, i.e., if you have less enzyme activity, you're more likely to present in the neonatal period. But you can present at any age, and another time that women can present is with childbirth.
Okay. And there was another question about the level of ammonia that would sort of be true for hyperammonaemia. For example, if the level was 400, would you go ahead and arrange time critical transfer or repeat? Have you any thoughts on a sort of a level to work off?
So the important thing is the history. If I had a history where it's a neonate who was actually very well, and then about two days collapsed. And you collapsed 2 days of it, and they don't look septic. They don't look like it's a respiratory. And the mother was trying to an experienced mom who's to wake them up couldn't. And you're going, actually, this is very suspicious of a metabolic condition. If you get a high ammonia, I'd be considering, but ideally, you're gonna have to start repeating it and arranging. I would do both at the same time.
Yeah, and I suppose the history and the presentation and your findings on examination are key. I can't. I think. Sorry. Yes, Costas, go ahead.
Just to add to the previous question, having late onset metabolic conditions is a real blind spot, certainly in the region that I cover with newts. For us. So any child, regardless of age, including young adults with signs of encephalopathy, we must absolutely do an ammonia at entry level, at presentation to ED. Yeah. Otherwise, we risk missing a significant hyperammonemia. And there's a number of children that have had irreversible and very poor outcomes because the ammonia wasn't done early enough. So I cannot label this point enough. If a child comes in with an encephalopathy, ammonia needs to be very high up on your list of investigations, and it has to be soon, early, and ownership of it. Someone needs to chase it within the first 15 minutes so we can act on it faster.
Yeah, and I think that during the talks we were having a discussion here with Tudor about practice in ED for septic screens in neonates presenting, and it's not something actually that we probably routinely do and probably should be doing on a routine basis for those children who are presented as collapsed neonate.
I think the other group of patients you might see an elevated ammonia is the acute liver failure patients. And I've certainly seen that in the past. The child presents with coma, and it's not a metabolic problem; it's acute liver failure due to whatever cause. So I would agree with what Costas has said. I think any unconscious or reduced conscious patient, regardless of age, it's a useful investigation to send.
And I think in the interest of time, we probably need to move on to the next talk. I'd like to thank Dr. Sullivan again for her talk and for joining us today. It's been really valuable to have you here and have your input to these questions. I'm just going to hand over now again to Chris to introduce our next speaker.
Okay, thanks, Ben. So our next speaker is Dr. Mark Terris. He's a consultant paediatric anaesthetist and intensivist in Belfast, and he's going to be talking about bronchiolitis.
Good morning, everyone. My name is Mark Terris. I'm a consultant in paediatric intensive care and paediatric anaesthesia in the Children's Hospital here in Belfast. I'm also the clinical lead for paediatric transport with the NISTAR team. The plan today had been to have a look at an interactive case of an infant with problematic bronchiolitis, but sadly that has not proven to be possible. So I thought instead I would spend a bit of time just looking at bronchiolitis more generally and the workload that it brings to us all. So bronchiolitis, we all know and understand, first described in the BMJ in 1941 by a paediatrician and a pathologist, Hubble and Osborne, who described it as, for the first time, as a separate disease in its own right. Previously, it had been considered to be a bronchopneumonic process. It's the most common cause of hospitalization in infants in the first year of life. It's estimated there's about 450,000 GP episodes annually in the UK and about 30,000 admissions every bronch season, with about 2 to 6% of those admitted children requiring critical care. Healthcare costs for RSV alone are estimated to be somewhere between £50 and £57 million per year. And although a disease of low morbidity, it's not zero, and in the UK it's estimated to be about 80 deaths per season. Pathophysiology of bronchiolitis is fairly familiar to us all. It's most commonly seen in previously healthy children, but there is an increasing risk of severe disease in children with congenital heart disease, those with airway abnormalities, those born prematurely, or children with trisomy 21. Environmental smoke exposure, both antenatally and postnatally, or air pollution may also increase the risk of severe disease. What happens? Well, child is exposed to a respiratory virus, which leads to the initial upper respiratory tract symptoms, nasal discharge, fever, poor form, poor feeding. A failure of the immune system to clear the virus results in spread from the upper airways to the lower airways in approximately 1/3 of children. This can either be by direct spread, essentially inhaled snot, or by viral spread through the body. The resulting mucus and airway edema causes airway obstruction, and this is a mixture of complete obstruction leading to atelectasis and dynamic obstruction causing wheeze, hyperinflation and increased work of breathing. Resolution of the symptoms occurs over the following 10 to 14 days as the virus is brought under control. The causative viruses will be familiar to us all. The key feature seen is the seasonality of viruses, with the viruses peaking during the colder winter months. This slide shows data from England and Wales from 2010 to 2020, showing the seasonal peaks in virus presentation, with last respiratory virus season having a fairly hefty RSV peak. RSV is the most common causative agent identified in bronchiolitis, and infection is nearly ubiquitous by age 2. Other causes of bronchiolitis include adenovirus, influenza, parainfluenza, rhinovirus, metapneumovirus, and of course coronavirus. So briefly, I have to mention the elephant in the room, which is the COVID-19 pandemic and the SARS-CoV-2 that we're seeing. Children are minimally affected or appear minimally affected with the novel coronavirus disease, but those who are presenting appear to be broadly in one of two groups, either the PIMS, TS, post-inflammatory type presentation, or presenting with non-specific viral upper respiratory tract infection symptoms that are going to make it very hard to delineate between your standard bronch and your COVID-19 bronch. Importantly, 85% of pre-pandemic coronavirus bronchiolitis patients had an identified co-infecting virus, and 10 to 51% of children with SARS-CoV-2 also have other respiratory viruses identified. So isolating one virus doesn't rule out the presence of a second virus, and all appropriate precautions need to be taken. Identifying positive cases is vital to allow appropriate isolation and protection of others, including staff, but similarly important to be able to de-escalate PPE and free up isolation space to allow healthcare systems to flow. Capacity is limited and will quickly become overwhelmed if everybody needs to be treated in full PPE. The recent national guidance from the Royal College of Paediatrics and Child Health on the management of children with bronchiolitis and lower respiratory tract infections during COVID-19 is an attempt in part to alleviate the pressure on systems and try and prevent this from happening. Positive effects of the pandemic potentially. This is data from a South American group looking at 4 countries following their most recent winter season. The solid bars show the average daily temperature, so the dip kind of May, June, July, August, equating to their winter period when they would classically see their bronchiolitis peak. The blue line shows the figures from 2018 for lower respiratory tract infection admissions, the yellow line, the 2019 data, and then the pale grey line at the bottom, the 2020 data. which I think you can see shows a significant reduction, an 83% reduction in lower respiratory tract infection admissions to PICU during this last season, a 92% reduction in RSV and a 78% reduction in flu admissions. This suggests that the social measures that have been taken, so increasing hand washing, social distancing, more use of face masks, for example, is having a significant impact on our standard bronchiolitis and may help alleviate some of the pressures that we are otherwise facing. So treatment for bronchiolitis, well, I think this is excellent advice from Hobbs to Calvin and has been the mainstay of my treatment in ICU for many years. I think it's important to recognise that often what we do comes with problems, and that sometimes doing nothing is actually the best that we can manage. Main areas to focus on, I suppose, so hydration, important to assess for dehydration and manage where present. Ideally enterally if at all possible. If you are going to use IV fluids, you need to be careful to avoid hyponatraemia. 2003, a group from Evelina Intensive Care looked at their bronchiolitis patients and identified hyponatraemia in 33% of all their RSV positive bronchs requiring critical care admission. 11% of those had a sodium below 130 millimoles per litre. So it's common and can be significant and may require treatment. Hypoxemia. So what is hypoxic with bronchiolitis? Current NICE guidance recommends targeting saturations over 92%, whilst the World Health Authority and the American Academy of Pediatrics recommend targeting saturations of greater than 90%. Some have suggested that routine pulse oximetry has led to overtreatment and is partly responsible for the rising admission rates that we see and have seen with bronchiolitis year on year. This paper is an interesting review of several different papers that have attempted to answer the question of where the correct level of saturation targeting should be set. Included in this is the 2015 BIDS studies, the oxygen saturation targets in infants with bronchiolitis. And essentially this group targeted either 90% or 94% in patients. The control group had standard oxygen saturation monitors on, whereas the treatment group had oxygen saturation probes that were adjusted to only show correct saturations below 90%, and anything between 90 and 94% was adjusted to show a figure that was greater than 94%. Their primary outcome in the study was resolution of cough, which I consider to be a slightly strange outcome, if I'm honest, but was found to be not different between the groups. However, there were no adverse incidents noted between the two groups. Longer-term neurodevelopmental outcomes were not assessed on the assumption that short periods of saturations at or below 90, around 90% rather, were not going to have a significant impact. Bottom line, I think, for us, we need to target numbers that are expected by our local and national guidance. This is what we will be judged against. Certainly in Northern Ireland, the bronchiolitis guidance that we have in the Children's Hospital targets saturations of 92% and above. But I would recommend having a read of this paper, because I think it does raise some interesting questions about where the kind of over-medicalisation of care has impacts and may have negative impacts on children's care. Other interventions that have been tried are many and myriad, and none have been shown to offer benefit, and some may actually come with harm. So the use of nebulized medications, salbutamol, ipratropium, steroids, hypertonic saline, none have been shown to have a significant benefit to patients, and none are routinely recommended. Similarly, the use of caffeine and the use of caffeine for apnea has not been shown to have a significant impact and is not routinely recommended. Nasal suction, well, it may help with feeding, but care needs to be taken that it's not too deep. You don't want to cause trauma in the nose and worsen the situation, but if it's required just to clear the nares to allow the child to feed, then it may be worth doing. Antibiotics are not routinely indicated unless the patient's requiring critical care or escalation of care, where about 30% of children will have a co-infection and a bacterial superinfection. But where antibiotics are started, certainly our policy in intensive care is to de-escalate them as quickly as possible and to stop within 48 hours, ideally, depending on results from bronchoalveolar lavage. So who do you escalate, when do you escalate, and how do you escalate, I suppose, are important questions. When to escalate? Well, escalation is required for patients who are objectively failing standard supportive treatment. So patients who have been managed on the ward with oxygen therapy where indicated, but are not responding. 2015 NICE guidance suggests that signs of failure are essentially impending respiratory failure, and that escalation should be considered if showing signs of exhaustion, such as listlessness or decreased respiratory effort, recurrent apnea, or the inability to maintain target oxygen saturations despite appropriate oxygen supplementation and kind of maximal oxygen supplementation at ward level. Important to stress that work of breathing alone is not an indication for escalation. It's not an uncommon phone call for us to receive in intensive care to say that the child may tire. And whilst that is a child who bears close watch and may require further intervention, it's not an indication to escalate care on the basis that they may tire. How to escalate then? So I think that the standard pathway that we're all familiar with through high flow, consideration of CPAP, and then on to invasive ventilation. A lot of debate and discussion about high flow and its role for bronchiolitis. It's increasingly used in a variety of areas, but the evidence to support its routine use is currently lacking. It appears to have a role in patients who have failed standard treatment, but doesn't alter the course of patients if started early. It may have a role in supporting patients following extubation to prevent re-intubation, but other than that, its role is still not quite clear. CPAP, more aggressive therapy and generally not available at ward level, so would require escalation to critical care. Has been suggested that it has a place in bronchiolitis. The 2017 Tramontane study, which compared nasal CPAP to high flow bronchiolitis, the results of this did not show inferiority of high flow, but did suggest a higher relative risk of success with CPAP. However, as mentioned, CPAP may not be routinely available, and given access to critical care, this option may be limited locally depending where you work. Currently, the first ABC trial is underway to try and establish the non-inferiority of high flow compared to CPAP in critically ill children, both in terms of step-up and step-down care. And this trial is underway in the UK as a multi-centre trial. So children that fail, children who require invasive ventilation, well, my approach to things, as you've gathered already, is fairly simplistic, and I like to consider things in a fairly broad fashion. We're all familiar with the DOPES mnemonic that is used to identify issues, and I think it's a useful framework to hang our thoughts around ventilation issues that might arise in patients with bronchiolitis who have been intubated and ventilated. So displacement of tubes, correct positioning of the tube is important to avoid the tube being dislodged and falling out, or to prevent endobronchial placement. The tolerances and distances that you're talking about are 1 to 2 centimetres in some of our smaller patients, so it's not uncommon for the ET tube tip to lie too low. That, coupled with oral intubation and the difficulties of securing an oral tube in an exact position, result in potential problems. So always consider tube placement if the patient is not behaving as you would expect at any stage. So tubes will frequently slip in through the tape, having been previously x-rayed and been shown to be in a decent position. Obstruction or partial obstruction is a common cause of difficulties with ventilation. And pathophysiologically, you think about this as a disease of mucus production, which can obstruct not only the airways, but also the ET tube. And suctioning the ET tube can make a huge difference in your airway pressures and your ventilation, and is always worth considering. Pneumothorax is rare, but can happen, and when it happens, needs appropriate and urgent management. Equipment may malfunction, but often the equipment is functioning perfectly well. It's just functioning well for an adult patient, but not coping with your standard small bronch baby. Adult circuits and excess dead space can result in virtually no tidal volume being delivered to the patient. So always make sure that the patient is ventilating, that their chest is rising and falling. And I wouldn't rely too much on the numbers that the ventilator's generating. So targeting tidal volume is appropriate, but restricting tidal volume at the expense of chest movement is detrimental to the patient. Initially, after intubation, these patients may require recruitment to open up the lungs, followed by adequate PEEP to maintain lung volume. And the same goes following any episode of disconnection or suction where the patient may de-recruit. It's important to ensure that you have maximised and recruited the lung back where possible. You can see breath stacking in bronchiolitis as a result of the dynamic airway obstruction. So it's important to ensure that there's adequate expiratory time available to the patient to allow full exhalation. And this can be achieved best by reducing the rate and watching the IE ratio. If the ventilator you're using has it, looking at the flow time loop to check that the flow actually gets to 0 before the next breath is delivered is another useful way to assess whether you're at risk of breath stacking. Roughly, so suggested initial settings for a ventilator, well, a respiratory rate of around 30, an I time of 0.7, 0.8, something like that, and then enough peak pressure to see adequate chest movement, ideally limiting that to below 30 centimetres of water at peak. The targets, so I think we're all guilty on occasion of overachieving on our targets in these patients. So we have to remember that mechanical ventilation is not physiological normal ventilation. So we shouldn't be aiming for normal targets either. So target saturations, maintaining them greater than 92% and weaning your oxygen where able. And carbon dioxide levels, well, anything up to 10 kilopascals, assuming the pH is well compensated and above 7.25. But as I often bang on to the trainees in ICU, target figures, or accepting figures rather, with a pH of 7.4 and a CO2 of 5 suggests that you're working the lungs too hard, and that comes with the risk of longer term lung damage. What else do we want as a retrieval team when we arrive to collect this patient? So an appropriate ET tube in the correct position, as discussed already. Do be careful. Correctly has been a move towards using cuffed tubes, but we are still seeing errors with the wrong size of tube being used. So micro cuffs, I think, are the most commonly used tubes, and they do have suggested age ranges and weight ranges for the smaller patients. So don't size using any other equations that you're used to using. An NG or an OG tube to decompress the stomach is important. Children, as you know, tolerate gastric insufflation poorly, pushes up on the diaphragm, reduces your compliance, and will make your ventilation much more difficult. So putting in a tube and actually decompressing the stomach is important. IV access, so peripheral IV access is perfectly appropriate. Ideally 2 points of access to allow for a failure during transfer, and the ability to continue the journey without having to stop to achieve second access. Arterial access rather is not important for your standard bronch. So I think a bronchiolitic patient who's ventilating easily and is not requiring excessive pressure or excessive oxygen can be managed without an arterial line, and that removes the risk then of thrombosis, etc., that you can see with arterial lines, particularly in this kind of weight range of patients. Suitable sedation and paralysis. This will vary from where you work. Generally, morphine for the younger patients under a month alone, plus or minus midazolam for those older patients. Again, not uncommon to see patients maintained on volatile anaesthetics, so the use of sevoflurane, which is acceptable for standard anaesthetic practice, but less acceptable for the critically unwell patient, so bronchiolitic who's required intubation and ventilation. They'll tolerate it poorly, their blood pressure will likely drop, and that will just drive a vicious cycle of more fluid boluses to maintain it. So try and get rid of the volatile as quickly as possible and get them settled and established onto IV sedation. Interestingly, in the 1940s, it was standard to use brandy, whiskey or port to sedate infants with bronchiolitis, but we wouldn't recommend that anymore, but you can have a small whiskey yourself after a stressful bronchiolitis stabilization in theatre. Chest x-ray to confirm tube placement and to have a look at the lungs is useful, and most transport teams would want to see a chest x-ray before they move that patient to make sure that the plastic is all in the right place. What does the future hold for bronchiolitis? Where are the areas of research? Well, currently the BEST trial is ongoing. This is a multi-center RCT, which is comparing surfactant to placebo, essentially air down the ET tube, in children who are ventilated with bronchiolitis. And they're looking to see a significant effect on reduction in mechanical ventilation by 18 hours, which is their primary endpoint. This is currently in its third season, and recruitment is ongoing. So we'll see, be interested to see rather the results that come out of this, and whether it answers the question finally as to what role surfactant plays in children with bronchiolitis who end up ventilated. This is another interesting trial, something I hadn't heard about but came across in preparation for this talk. So nitric oxide that we will use in intensive care for oxygenation and improving VQ mismatch, but it also has an antiviral property, and there's been some suggestions that it may be of benefit to children with viral pneumonitic processes, including bronchiolitis. So this group in Israel, this is an early kind of multi-center RCT where they used intermittent high-dose nitric oxide inhaled administration 5 times a day for up to 5 days. High dose is not an understatement. They're using 160 parts per million in these patients, when classically we used 20, maybe 40 parts per million in intensive care. Very small numbers in each arm, but they did suggest a significant reduction in length of stay, improved oxygenation, and no safety issues identified in either arm. So importantly, the rates of methemoglobinemia were not too significant as to stop treatment. So watch the space. They are planning a larger trial to see. That's everything from me. I'd like to thank you for your time, and if anyone has any questions, we hopefully will be able to get to them. Many thanks.
Okay, thanks very much. Now we're joined by Dr. Terris, who you've just heard speaking, so thank you very much for that talk. And Dr. Richardson has also joined us. Both Mark and Julie are PICU consultants in Royal Belfast Hospital for Sick Children. So Mark, a few questions. I'd say thanks very much for your talk on bronchiolitis. There's a question through about PPE and criteria for de-escalating PPE, particularly starting a child on high flow, which has been classed as an aerosol generating procedure. Any sources or any guidance that you know of that could help in making decisions around that?
Thanks, Ben. I think the best source and the most current source is probably the RCPCH document that they recently released, which I think was an attempt to allow us to sensibly de-escalate PPE and allow us to use high flow during the current kind of pandemic.
I think we seem to be having a few issues just with Dr. Terris there. So yeah, I think he's alluding to the fact that there is an RCPCH guidance on de-escalation of PPE, which has been approved by Public Health England, and it is available on the RCPCH, that's the Royal College Paediatrics Child Health website. You're back with us, Mark?
Yeah, apologies.
Yeah.
Technical difficulties this end. Yeah, so the RCPCH document that I think you probably mentioned is probably the document I would refer people to. I think it's a sensible effort to allow us to de-escalate PPE, to continue to provide ward level support, and to avoid, I suppose, reaching capacity in the critical care network closest to you very quickly. Simply put, there are not enough beds for all the children if we end up having to take everyone. So, and likewise, most of your critical care units will quickly run into difficulties if they're having to operate in full PPE. So, I would refer people to RCPCH, I think, for that.
And I think there was another comment just about asking for a bit of elaboration on a phrase that you'd mentioned about just a child looking tired isn't necessarily a sort of warrant ICU admission, and would not be at this stage more reasonable to try and get critical care input and make a joint decision about management for a child who looks tired, but actually their numbers maybe aren't too bad yet?
Yeah, absolutely. So I think that's a subjective objective evaluation, I suppose, and it's not uncommon that we get a phone call, a series of numbers, a description of a patient's kind of course trajectory, a recent blood gas, and the numbers to us don't sound awful, but the message we're getting from the referring clinician is that this patient looks very tired and is not going to manage. I think the kind of the last 10, 20 years, the ever-increasing admission rate, the ever-increasing intervention rate, perhaps in bronchiolitis, we've all lost some of our ability to sit in our hands, do nothing and watch. We always want to intervene and be fixing things. And some things like bronchiolitis, time is the only thing that's really going to fix this. So we may need to sit back. Every critical care network, every retrieval team and unit are happy to be contacted and to be aware of patients in the area that may need escalation. But I think that doesn't always, a phone call doesn't always kind of immediately result in a need for a transfer, an intubation and ventilation. And that oftentimes, particularly with bronchiolitis, which is a very dynamic condition, you can have a patient looking dreadful 1 minute, 10 minutes later, once they've settled whatever was annoying them, their general condition can look so much better. So we do, I think, have to temper our enthusiasm to act with our need to just watch, wait and see sometimes.
Yeah. Any other comments or questions from any of the panel? I think there was just one more question coming through in the chat there about just any particular guidance on or principles to guide ventilation of bronchiolytics. Is there anything in particular you want to be bearing in mind when your ventilator settings, or any kind of key tips in that regard?
I suppose the things that were mentioned, so beware gas trapping. There is a degree of gas trapping goes on. Beware suction secretions. I mean, primarily why these kids get in trouble is because they're loaded with secretions. That doesn't necessarily get better once the tube goes in. And there's certainly a group that will improve with a bit of suction via your ET tube. Ventilating, depending what equipment you're using, making sure that the child is actually ventilating well. So I think we're all very good and appropriately protective in our lung ventilation strategies, but targeting tidal volumes on certain machines in a very small infant, the numbers are so kind of error prone that actually you may, yes, you're saving the lungs, but at the expense of not actually ventilating the patient. So the eternal dead space discussion, I'm afraid. So every intensivist will have a horror story of a child who's not been ventilated adequately just due to too much dead space in circuits. And I say that with my anaesthetic hat on as an adult trained anaesthetist. Most adults will not notice it. A 3 kilo bronchiolytic will definitely notice it if you have extra space in the circuit. So always make sure you're minimizing that. The pandemic in some ways has made that more difficult as well, because we've had to increase the number of filters, the number of steps, and the potential dead space I think that exists in circuits for these patients. So you do have to be careful with that.
Be mindful. Grant. Listen, thanks very much, and thanks again for the talk, Mark. I'm just going to hand over to Chris now to introduce the next talk.
Okay, thanks, Ben. So our next speaker is Dr. Julie Richardson. She's one of our consultant paediatric intensivists in Belfast, and she's going to be talking about the sick cardiac child.
I'm Julie Richardson. I'm a paediatric intensivist at Belfast Children's Hospital, and I have the pleasure of talking to you about the sick cardiac child today. I think for most of us, when we're told that there is a child down in ED who has cyanotic heart disease, we feel a bit like this. So absolute horror and terror comes into our heart, even though we may not show it unless you're actually a cardiologist. And even then, I think sometimes feel a bit nervous. So I'm going to run through a few cases, a common scenario, and a couple of more unusual cases at the moment, and hopefully just build your confidence a little. So baby A, 4-week-old, collapses, is apneic. The pH is 6.8, the CO2 is 8, the lactate's 5, the glucose is 2. So what are you thinking? Well, because I'm doing a cardiac talk, you're thinking this is likely to be a duct-dependent lesion, probably coarctation of the aorta. And in this case, you're absolutely right. And this is a picture just to remind you what that looks like. Typical presentations about 4 weeks of age when the duct closes and then the baby's reliant on the aorta, which is fixed. However, babies do not come like with a label. They do not come saying, I'm a cardiac baby. They come collapsed and sick, and there is a differential diagnosis. Many of you are really used to this situation, but it's really important, and it's really important that you act quickly. The differential is sepsis, 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 obviously cardiac disease. It could be metabolic, it could be surgical, such as a volvulus, or it could unfortunately sometimes be a non-accidental injury. Your history and your examination are really important in trying to break that down. The fact that this child had a low sugar might push you in the direction of it being metabolic, but also that happens in sepsis and in sick children. You might, on examination, find that the pulses are weak. Again, unfortunately, that is found in sepsis and in just very sick children. So it can be difficult, although the books make it very clear, it can be difficult clinical to work out what's going on. So in terms of management, you're going to do your ABCs. You're going to give some antibiotics. In this particular child, you're going to intubate them, and you're going to do that with care, which we'll talk about in a little moment. Prior to intubation, you're probably going to start some inotropes on this child, and because we're deeply concerned this child might have a coarctation, you're going to start some prostaglandin. You may start that before you've got echo. Not all hospitals have an echo facility immediately, and it's better to treat soon and stop later. You can always stop prostaglandin. So I'm now going to just talk to you a little bit about my general approach to the sick cardiac child that requires intubation. And I view it as a situation that is an impending disaster. The best approach, particularly with a cyanotic child with a complex heart, is to presume this child is likely to arrest on you. And the first question is always, do I really have to intubate them? And once that decision's made, you want the most senior person available with the most knowledge. However, you also want to be timely and not delay unnecessarily. So in terms of this, like I would with any sick child, but particularly with a cyanotic heart disease child, you need to be prepared and you need to get organised. So you're going to draw up fluids, you're going to prepare for an arrest, you're going to prepare your team for an arrest and delegate roles. You may well start an inotrope, and I usually do before I intubate a child with cyanotic heart disease in particular, so I'm thinking about a hypoplast. And I'm going to be fully prepared for a difficult intubation because of the cardiovascular status. In terms of the induction agents, I would usually use ketamine because it's cardiovascularly stable. However, in the very, very sick child, such as a hypoplast, I may not even use ketamine. I might use something like fentanyl, so enough to reduce the catecholamines and allow me to place a tube, but not to prevent an arrest. What you also have to remember, usually in a cardiac child, that the reason you're intubating them is because their cardiac output is poor, and therefore all your drugs will take longer to act. So you need to be patient and give them time to work and prepare for the worst. Magic adrenaline, something that I usually have in my pocket, or push-dose adrenaline. I would absolutely always have this with any sick child requiring intensive care, but particularly so with a child with cardiac disease. It's easy to make up. Adrenaline's found in every ED, and it's easy to give little tiny aliquots to keep you out of trouble. And hopefully if you prepare and you consider and you have your team all planned, then the seas will be calm and you will have a straightforward intubation. So moving on to another scenario. So we have a little baby come into ED who has double outlet right ventricle, TGA, pulmonary stenosis and a small RV. If you're not a cardiologist, your heart is racing and you're already worried because you're thinking, I don't even understand what that means, and it sounds awfully complicated and I can't understand which way round the blood's going. The family tells you that they have a BT shunt, which is 3.5 millimetres, and the kid's had recent diarrhoea and vomiting and has just recovered from that. On examination, the heart rate's 190. They look blue around the lips, and when the saturation monitoring's put on, it's 50%. When you listen in, you're not sure if you can hear a murmur or not. And as you will remember, shunts should have a really loud, continuous murmur, and they're not subtle in any way. So what we're worried about here is, has this child actually got a blocked shunt? These days, presentation of a blocked shunt is really uncommon because we don't use them as frequently as we used to. Lots of children get full repairs rather than a staged repair. So we're not quite as used to seeing a blocked shunt. The most common time that will happen is immediately post-op, so in the first couple of days when they're still in the intensive care. But the other time that this might happen is when they've become a bit dehydrated and got another illness. So it's something that you should think about in your differential when you've got an unwell child, and it's really important that you keep these children hydrated and don't restrict their fluids. So something like a stenotic pulmonary valve is the sort of lesion that may get a BT shunt these days. And again, just to remind you what a BT shunt does, it's just an artificial conduit from the left subclavian artery to the left PA. So what do you do if there's a blocked shunt? Well, this is absolutely an emergency. So you're going to give them some oxygen. You're going to start preparing to intubate with all the cautions that we thought about. You are going to get an echo as soon as possible. However, echoes are not terribly good at picking up clots in shunts. So even a negative echo might still not persuade you that you don't have a blocked shunt. You're going to give some volume, so you're going to give aliquots of 5 to 10 mils per kilo. You will give some phenylephrine of 10 to 30 mics per kilo. Phenylephrine, many of you will not be familiar with. It's a very potent vasoconstrictor and is very useful in this situation. You may start a little bit of inotrope, such as dopamine or adrenaline, but actually once you've got better access, what you probably need is noradrenaline. This is all to increase your systemic vascular resistance and try and persuade blood to go to the lungs. Once you are in the position of intubating this child, you're going to sedate and paralyse them. You're going to try and minimise the amount of PEEP. You're going to give them lots of oxygen as a potent pulmonary vasodilator. You're going to aim for alkalosis and also give them a little bit of magnesium to try and help and persuade any blood flow that is left to go to the lungs. At this point, you're very much hoping that you don't have an entirely blocked shunt, but a partially blocked shunt, because otherwise none of this will potentially work, depending on the anatomy. If you haven't done so already, you should absolutely be contacting cardiology and paediatric intensive care at this point. They may well suggest that you should give a heparin bolus. This is usually at a dose of 50 units per kilo and may be repeated. They may then suggest you start a heparin infusion in the order of 20 units per kilo per hour. Again, in the child that the shunt has been in situ for many weeks to months, this is unlikely to change the situation, but may prevent propagation of clot. If this is a little tiny baby in neonatal age who has still got a duct open or has potential for an open duct, you might actually be advised to start a little bit of prostaglandin, again to persuade some blood to go to the lungs. Ultimately, however, this child needs, if there's no improvement, or minimal improvement, this child needs to be in definitive care centre and needs either a catheter urgently or surgery. Very occasionally TPA has been used successfully. So it's really important that you identify the problem, you act quickly, stabilise the child and speak to the specialist and get this child to the right place at the right time, or else there'll be a real disaster. And since shunts are so uncommon these days, it's not something that you would necessarily think about straight away. When you've got a blocked shunt, it's an absolute emergency. You're going to use your ABC approach. You're going to intubate early with the caution and preparation that I spoke to you about earlier. You're going to increase the SVR using your fluid bolus, phenylephrine, and then an infusion of noradrenaline. You're going to decrease your PVR using sedation and paralysis. You're going to aim for alkalosis, and you're going to use high oxygen. At that point, you're also going to attempt to stop propagation of the clot, or unlikely to be able to remove the clot, but use a heparin bolus, heparin infusion. But ultimately, you need to be in a surgical centre because this child may well need surgery and a new shunt. So moving on, I am going to talk about yet another scenario which used to be very, very common, and I spent most of my SHO days running to cardiology to deal with this, but again it's something that's really uncommon these days. So baby C has tetralogy of Fallot. They've come into ED with poor feeding. They're having intermittent blue episodes, particularly bad when they cry or actually when they poo. Their SATs at the moment are 65% when you measure them. And when you listen in, there's some wheeze and auscultation, and you can't hear a murmur. So what we're talking about here, and just to remind you about those of you that can't quite remember tetralogy of Fallot. So you've got a stenotic pulmonary valve, you've got a VSD. Because of that, you've got a very thickened right ventricle, and you've got an overriding aorta. And the problem here is when there's a change in PVR and SVR, suddenly you have less flow to the lungs. So a bit like the situation we talked about before. So what we have here is a spelling child. And spelling always made me think of something magical and wonderful. Unfortunately, it can be life-threatening and not at all magical, otherwise known as a hypercyanotic episode. So the first thing to do is keep calm and get prepared. So the first thing you're going to do is soothe this child. So put the baby in the mum's arms, get it cuddled, get it calm, because if it's crying and cross, you're going to struggle to get blood to the lungs. The next thing you're going to do, if that hasn't worked, is to bring the knees up to the chest, lying the baby on their back, and that increases the SVR. Then you're going to give some oxygen if they'll put up with it, and then you're going to give some morphine. Now, if you don't have IV access, it's suggested you should give IM morphine, because obviously attaining IV access is going to distress the child initially, and IM is quicker. If your child's still got SATs in the 60s or less, then you need to move on to the next stage. So you're going to keep calm and carry on. So at this point, if you haven't already, you're going to call your cardiologist in intensive care. You're going to be thinking about getting access. If you haven't already, you're going to give a fluid bolus of 10 mils per kilo and repeat that. You may give a dose of oral propranolol, which again can be repeated 15 to 20 minutes later, or you may be suggested to give an IV dose. Again, phenylephrine can be very useful in this situation, and again the dose of 10 to 30 mics per kilo in little aliquots to see if you get a response. And your aim here is to try and improve saturations and break the cycle. At any of these points, the child might suddenly look much pinker, look much happier, and you don't need to then proceed with the next step. However, if all of this has failed to work, then you're in real trouble. So you've got a child who's having a very prolonged spell, remaining very blue, the infundibular spasm hasn't relaxed, and you're struggling to get blood to the lungs. At this point, you may consider intubation and ventilation. You want to increase SVR, so you're going to run some noradrenaline. And this child, honestly, at this point, may well need an emergency shunt. So at that point, you need, again, to be in a place which can perform cardiac surgery and as soon as possible. In the meantime, giving supportive care. And then the very last child and situation I'm going to talk very briefly about is the child who comes into ED at age 13. They've recently had an upper respiratory tract infection. They've had a high temperature. They generally just haven't recovered from that. They're lethargic and not themselves. They've also complained intermittently of mild abdominal pain. Their heart rate is 160 and they have a few scattered creps on auscultation. So as you will note, the heart rate is high. There's some scattered creps. Recent chest infection, you're probably thinking about a pneumonia or lower respiratory tract infection. But as I'm doing a cardiac talk, you know I'm probably not going down that line, and I wish patients could just tell you what's wrong with them sometimes. So this child actually turns out to have a myocarditis. And the clues were the persistent tachycardia. When you do a chest x-ray, it doesn't show the pneumonia that you were expecting, but it actually shows really quite a large heart. If you're clever and been thinking ahead and thinking potentially about a heart, you may have done a troponin, which will be high. The ECG, when you do it, may show some arrhythmias. It may show some ST elevation. It may show some right ventricular, left ventricular hypertrophy. And when you do an echo, you've got perhaps a cardiomyopathy, a slightly dilated heart. In terms of myocarditis, I'm not going to go into the details of treatment. It's generally supportive. Many of them will manage without needing paediatric intensive care, but the main point of bringing this up at this point is actually to consider it in your differential diagnosis. Most children who have myocarditis initially are treated as a pneumonia or an asthmatic in the first instance, and then it's only due to failure to get better or failure of treatment or deterioration that suddenly the heart is thought about. So it's uncommon. The most common virus that causes it is enterovirus. In our population, it's usually a virus, but it's also important to think about in a child who has had oncological therapy. Treatment is supportive, diuretics are important, immunoglobulins can be helpful, as can anticoagulation, and the very worst group of children may need paediatric intensive care support and potentially mechanical support for the heart or even transplant. But we're very lucky because many children get better in the next 2 to 3 weeks. However, it's very difficult to predict which ones will get better and which won't. In terms of everything I was going to say today, that is it. My main aim of this talk is to say, remember to think about cardiac, particularly in a child who isn't getting better, particularly this winter when you've got that host of bronchiolitis coming through the door. In amongst all of those, one of them will have an undiagnosed VSD and actually be in heart failure. So if you've got a child who's not very well, who is getting worse and not following quite the path you thought, just always think, especially when you're thinking, do they need paediatric intensive care? Just always think, have I got the right diagnosis? In the children with cyanotic heart disease, think about, well, do they have a shunt? Could it be blocked? In the Fallows child, know about spelling Fallows. And obviously the collapsed neonate, there's a big differential diagnosis, and cardiac is one of those. So be prepared, prepare for the worst, drop your drugs, think about what you need to do, prepare your team, discuss early with the tertiary centre, cardiology and paediatric intensive care, and get the patient to the right place. There's no point being in a centre that can't actually repair your shunt or do what you actually need. The medicine sometimes fails in what you actually need as a surgeon. Thank you very much.
Welcome back, everyone. Listen, I'd like to start by thanking Dr. Richardson for that talk. Certainly a scenario which, and I'm sure not the only one, whenever you hear there's sick cardiac kid coming in, your heart itself starts to race a little bit and starts to panic. And so it's good to have thought through a few scenarios and have those structured approaches to how you might manage that situation. We've had a few questions coming through in the chat, so we're going to go straight into those. The first is really with regards to inotropes. There's a question about what would your first choice of inotropes be in a child with congenital heart disease or complex heart disease, and what you're sort of thinking behind that choice. So any thoughts?
So the honest answer is that it would depend on what the actual diagnosis is, but in the situation you're in ED and you're working everything out, adrenaline's a reasonable choice for most things. If you're specifically looking to increase your SVR, as we were in both those situations where we had a blocked shunt or a trough, then you actually want a bit more of a push. So something like noradrenaline or phenylephrine used in the short term because it's short acting and really potent, and is gone. So if it's the wrong choice, then it's quickly disappeared. So I think people get really worked up and in a bit of a tiz about which inotrope or that they use. The honest truth, if you work in enough cardiac intensive cares, you find out that actually it doesn't really matter because everywhere uses a different concoction. And they go, you should never use this drug in one centre. You move to the next centre and they use it. So I think it matters less than you might actually think, but I'm sure there'll be different views out there. So adrenaline first choice when you're in an unknown situation, noradrenaline if you're looking for a pressor.
Yeah. Thanks. And I suppose if there's one thing people fear more than the collapsed cardiac kid coming in, it's the collapsed neonate where you don't know the cause and it might be a cardiac cause. We talked earlier about a case where it was inherited metabolic disorder. What sort of signs or symptoms might be that kind of give you clues that you're leaning more towards a underlying cardiac diagnosis as the cause of the collapse versus some of the other differentials which you talked about earlier?
Yeah, I mean, the first thing is with the collapsed neonate, you need to keep an open mind. And even when you've got some of the signs there, don't be led down one route. So treat everything till you know is my approach to it. So get your antibiotics on. Sepsis is by far the most common, but there's a differential diagnosis as we discussed in the talk. So in terms of cardiac patient, the things that might make you think of that is that you do have a child with reduced saturation, they're particularly tachycardic. Again, that can happen in sepsis or any unwell child, so it's not delineating. You may have a history of failure to thrive, which is actually going on a bit longer than the very acute history. And you may have some respiratory signs, breathlessness, and increased work of breathing, which you might not have seen with some of the others of a longer duration. And then on examination, you're listening, is there a murmur? The fact that there is no murmur does not mean this is not cardiac, and you've got to remember that. And you often get flow murmurs in septic children as well, so don't be misled by that. And then you're looking for pulses, absence of femoral pulses. The book says, this is brilliant that you've got your diagnosis of cardiac, coarctation. In real life, it's not as straightforward as that. The child with sepsis often has quite difficult to feel pulses because of low blood pressure. Your metabolic child who's profoundly unwell might be in the same situation. Other things that are useful are pre and post ductal saturations, and forelimb blood pressure can be useful because if you see a discrepancy, that makes a big deal. The other thing you might find on examination, listening in, you hear crackles, and particularly over winter, I do implore you that if you've got a bronchiolitic child that is just not getting better and you're thinking about ICU, just do remember to think about cardiac. There's always one every winter in every centre that is actually an undiagnosed VSD with significant heart failure. The other thing in terms of examination, you might have some dysmorphic features again, but that may push you in the direction of metabolic rather than cardiac. And you may have a big liver. Going with cardiac failure, but again, that could be a sign of metabolic. So although the books make it look really simple, when you've got a collapsed neonate in front of you, you've got to be really thoughtful, go through the history in detail, examine your child, I think carefully and considering all the differential diagnostics, and work through it slowly, and hopefully you'll come to the right conclusion. And if not, treat everything. You can always turn that back. There's no harm starting Prostin and starting antibiotics and thinking about metabolic things. There's more harm if you haven't considered them.
Yeah, that's great. Thank you. She says it would be lovely if it was just as clear cut as it is in the textbooks, but reality doesn't quite match that. No. And just one more question then. It was mentioned, we talked about the use of IM morphine. One of the questions from Justin was, could you use intranasal diamorph as an alternative to that, if that was the first thing that kind of came to hand in ED?
Yeah, absolutely. And often in ED, they'll actually be more used to using intranasal diamorphine, and that would work nicely, because then you're not going to upset, well, you shouldn't upset the child quite as much as with an IM. Yeah.
Great. And thanks, Julie. And I suppose it's most of you realise we're slightly behind. We are going to try and catch up a little bit. So we're due to start the afternoon session at 1:45. We're going to get rid of the official lunch break, but I guess hopefully you'll be able to continue eating and join us. In the next 5 minutes or so, we're going to kind of do an unofficial discussion just with Costas. I know he had his case, there was a few questions came through afterwards, so we're going to keep talking about that. If you need to go and get some lunch and get back, join us at 1:45. That's grand. But if you can't stay on for the next 5 minutes, you're more than welcome to join the chat with Costas. So maybe if we just, for anyone who's maybe joined later, because your talk was quite early, Costas, do you mind giving us a 1-minute summary, if that's possible, in a case that complex, of what the case was, and then we'll go into some of the questions.
Sure, yeah. So basically, it was a case of a 4-year-old girl with dyspnea and orthopnea, so she couldn't lie flat because the stats would drop. She had a diagnosis of a large anterior mediastinal mass. She had respiratory failure, and she was tiring to the extent where her GCS was dropping down to 10 and getting increasingly sleepy. So we were trying to decide what was best for her, and whether if it came to intubation, what could be done for that.
And I suppose there was some of the questions, one of the questions was, well, there was two. One to do with whether there's a role for trying to intubate in a prone position or carrying out, and the other was carrying out CPR in a prone position. Be keen to hear your thoughts on that.
Yeah, so the key take-home message is you do not take, if you can try and avoid intubation until absolutely necessary, then that's what needs to happen. But the reality is that the child might take the illness in their own hands, and you can't avoid intubation. So the problem with these masses, more than 2/3 of them are in the distal anterior mediastinum. So when you intubate them, you're likely to get an obstruction anyway. So you need to try and avoid paralysis. That's key, because that wreaks havoc with your thoracic pressures and allows the mass to collapse the airway even more. ECMO standby, if you are in the right place, might prove a lifesaver, but again, it might be difficult because you've got SVC obstruction. So, if the center can use femoral, then maybe that could work. But we know outcomes from these kids are quite poor on ECMO unless the tumor itself is highly responsive to chemo. Now, prone CPR is a question that's been asked. So if the child collapses post-intubation, turning them prone is a very good idea, because then you're using gravity in your favor to try and relieve pressure from the airways. It's almost like your Hail Mary approach. And if the child arrests, then doing CPR in the prone position is another Hail Mary. So there's no big RCTs available for prone CPR. There's a handful of papers on which are case reports, and some are sim-based and some are mannequin-based. So that doesn't really qualify for class 1 evidence. But there are case reports where if you do thoracic CPR in the same rate and the same sort of pressure, then you can't get ROSC. Obviously, it's a two-person technique. You can't bag this child whilst prone, so they need to be pre-intubated, and that is probably what would have precipitated their arrest. So it's rare Hail Mary stuff, but if it's the kitchen sink. So you've got nothing to do by trying it if it's come to that.
Okay, thanks. And there was another question from Rachel Parish through just about, so you're working in a district general hospital without a PICU, and would you recommend commencing an NIV to transfer the child to tertiary pediatric intensive care unit?
So specifically for the case we had on this course where the pH was uncompensated, so with a very high CO2, and the history is long-termish, over 3 months gradual onset, I think you would be criticized if you try to stick the child in the back of an ambulance on NIV, because this child is likely, despite all we do, despite steroids to decompress the tumor, despite sitting them up, is still likely to need an intubation. So you don't want a child arresting or needing a tube in the back of an ambulance. So you need to try and counteract that risk by doing almost a semi-elective intubation beforehand, with the understanding that things may well and are likely to go wrong. But it's better to have support in a hospital before you set off and stabilize them and do a prone transfer, rather than having no support in the back of an ambulance with a child this complex and this child arrests on the back on the motorway, which does happen, unfortunately. So absolutely use NIV to try and avoid intubation, and there's very solid evidence to suggest that it has a role to play in these sort of complex cases. But for retrieval purposes, I think you leave yourself open for criticism there. And
okay.
Just to maybe make a few comments on NIV, certainly from looking at some of the comments that people were making to your case, Costas, looking on Twitter, NIV people were sort of almost regarding as, this could temporize things. I think one of the concerns that I would have as somebody who, uses NIV in a critically ill child in a few minutes, a number of times over the years, it can also make things worse very quickly, particularly in a 4-year-old strapping a face mask on, and you've already got that critical airway. That could be almost the final push to get them to decompensate before you're ready with your ENT team in theatre. So it's a bit of a balance, really, isn't it? It might help and it might avoid the intubation for you, but on the other hand, it might very much result in an emergency intubation rather than a semi-elective intubation. I don't know what your thoughts are. Maybe you've had better experiences with NIV than I have.
I think it's on a case by case.
Yeah.
To be honest, I think that there's pros and cons in terms of physiology, and there's pros and cons in terms of child compliance. So you need to gauge how obtunded the patient is, and at GCS of 10, they will probably tolerate it. GCS of 8, they probably need a tube. And if they have a GCS of 14 and they're 4, they probably fight it because probably more scared than you are at this point in time. So it all depends on what you've got in front of you. Now, in terms of physiology, then we know we can support ventilation, but also don't forget you've got something pressing on your airways and essentially is causing an external valve effect. So you might actually cause air trapping more and more and more, because we can push air in, by this child can't exhale very well, which is why one of the reasons the CO2 might be high. So it can absolutely make things worse. So if you're reaching out for NIV, you need to be aware of these things and have the potential intubation plan in place beforehand, so that you're at least ready to react to it. But it really is down to trial and error, but try and do it with everyone in knowledge that things might get better fast or get worse fast, and everyone ready to react.
Thanks, Costas. It's nearly time for the afternoon session. One last question quickly, if that's okay. It came from Lorraine Redmond, and it was really about whether there's any specifics or support that you'd be keen to have from the nursing staff in these particular situations.
I mean, again, it's down to local leadership. I like flat hierarchy, so I'm in no way superior as to what the team does to any of my nursing colleagues, and I've certainly still been put in my place when I have a plan that's not what the nursing team thinks is in the best interest of the patient. So an experienced nurse who has seen this before will be extremely valuable in that setting, not least because they're the strongest advocate for the patient and can guide you away from trouble. But probably one of the key areas in which nurses, both junior and senior, can be used in this setting is that we forget that the people most impacted by this is not the healthcare workers, it's the families. And we all almost always forget to keep someone next to the family to keep them in the loop as to what's going on. And the complaints, like I said, are not going to come by whether you use the rigid bronchoscope to intubate this child or whether you prone them or not. They're going to come if you haven't kept the family in the loop, if you've kept them in the dark, if you kept them unaware, and if you've not been there to show empathy and compassion. So stereotypically, the empathy hat is better worn by our nursing colleagues, and for good reason. And so I would always have someone, doesn't have to be a nurse, but it's usually a nurse that volunteers to be with the family, to be that relay between us and the family, to so that we're all on the same page and we all know what's happening.
Perfect. Listen, thanks, Costas, again for your talk and for staying on and taking that extra bit of time to answer some of those questions, because I know they came through afterwards and there was some we thought were worth sharing and discussing. On that topic, if I can encourage you all to continue with the YouTube chat, posting your questions throughout the talk. It's quite difficult to get them in at the end if they're all posted at the end of the talk, so post them as they come to you throughout. And without further ado, I guess hand back to Chris to start the afternoon session.
Okay, thanks, Ben. So our next speaker is Dr. Stephen McVea. He's one of our latest consultant paediatric intensivists in Belfast, and he's going to talk about the child with reduced consciousness.
Hello, my name is Dr. Stephen McVea and I'm a consultant paediatric intensivist in Belfast, and I'm here today to talk about the child with a reduced level of consciousness. So my learning outcomes for this session, I hope by the end of this session you'll be able to recall the causes of a reduced level of consciousness in children and to understand the pathophysiology of a very important cause, that of raised intracranial pressure. Following this, I hope you will be able to discuss an approach to the child with a critically raised intracranial pressure. So we'll begin with a case. This case is of a 5-month-old term baby who is awaiting outpatient review for macrocephaly. Their head circumference has moved from the 50th to the 99th centile from birth till now. He has been admitted under the general paediatric take with what appeared to be a vomiting illness. Baseline bloods were sent and he was started onto some IV fluids. And as the night team, you have been called to see him as he's become increasingly drowsy throughout the shift. When you arrive, you do an ABC assessment and find that he has signs of upper airway obstruction, which are relieved with a jaw thrust. He has a non-rebreather mask on and is oxygenating well with SATs in the high 90s. He has got good air entry. His heart rate is lower than you would expect for a child of his age, in the mid-70s, and his blood pressure is higher than you would expect at 130/90, although he is warm and well perfused with normal heart sounds. You assess his level of consciousness and find that he only responds to pain. In particular, he opens his eyes to pain briefly, he moans to pain, and he gives some abnormal extensor movements to pain. His pupils are size 3 bilaterally and are reactive, but his anterior fontanelle feels very full, even bulging, and his sutures are spread. He has no temperature and no rash. So what could the cause of this child's reduced level of consciousness be? I want to draw your attention to this document the management of children and young people with an acute decrease in consciousness level from the RCPCH, which was revised most recently last year. Within this document, there is a poster with a nice flowchart for assessing children with reduced level of consciousness, which takes a stepwise approach. Firstly, you confirm the level of consciousness using GCS or AVPU, and then you perform a decreased level of consciousness specific ABC assessment. You make sure that the child is well oxygenated, is not shocked, does not have a low blood sugar, and then you decide whether or not the child needs their airway protected because their GCS is either below 9 or they have a CO2 which requires controlling in the setting of a raised intracranial pressure. This pathway gives a range of preliminary core investigations to send, which are listed on the slide, and advises that you start observations and consider a differential diagnosis. The following is the differential diagnosis included within that pathway, including such diagnoses as hypertensive encephalopathy, metabolic disease, prolonged seizures, sepsis, intracranial infection, raised ICP, intoxication, and shock. Each of those topics in the guideline gives you key features to look out for and initial management pathways. In our case, our child is inappropriately bradycardic and hypertensive with some features of abnormal posturing in keeping with raised intracranial pressure. Following through with the advice within those guidelines, you should give high flow oxygen, position the child in a head-up position with the head in the midline, consider osmotherapy, correct any hypoglycemia and shock, and arrange review with your local anaesthetic or paediatric intensive care team for consideration of intubation and ventilation. So following on with our case, our child had IV access in situ, so a blood gas was taken, the blood glucose was 7. Because of the signs of raised intracranial pressure, doses of osmotherapy was given as 3% saline, and PICU was contacted. So I hope we have now covered the potential causes of a reduced level of consciousness, and I now want to move on to the pathophysiology of the cause in our case, which is raised intracranial pressure. In humans, the CNS is contained within a fixed space within the skull, and there are a number of tissues contained within this space. Those tissues are the brain, the CSF, and blood, which can be divided between the arterial and the venous system. And in health, those tissues within that space exert a pressure, your intracranial pressure. When you introduce pathologies, which are listed on the slide, such as cerebral edema, blood clot, abscess, hydrocephalus, initially the CNS has the capacity to compensate by reducing the volume of CSF or venous blood, and the pressure does not rise immediately. However, as these compensatory mechanisms are overwhelmed, the pressure begins to rise, with a high pressure generically being taken as being above 20 centimetres of water. Other physiological parameters have effects on the intracranial pressure also through their effects on cerebral blood flow. The first two that I would like to talk about are the blood gas tensions of CO2 and O2. CO2 demonstrates a direct relationship with cerebral blood flow. As CO2 gas tension within the blood increases, cerebral blood flow increases. This is in a linear fashion until maximal cerebral vasodilatation is reached, in which case it flattens off. At low CO2 gas tensions, cerebral blood flow reduces because of cerebral vasoconstriction until maximal vasoconstriction is reached. Oxygen demonstrates an inverse relationship with cerebral blood flow. As increasing hypoxia develops, cerebral vasodilatation develops at low oxygen tensions, supplying increased blood to the brain in an effort to supply adequate oxygen to the brain tissue. Therefore, management of these gas tensions will be important when we come on to managing intracranial pressure. Another physiological parameter I would like to touch upon is that of blood pressure and its effect on cerebral blood flow. In health, cerebral blood flow is maintained across a wide range of blood pressures at a constant rate through autoregulation. This is achieved through vasodilatation or vasoconstriction of cerebral blood vessels. And only when maximal vasodilatation is reached at low blood pressures does cerebral blood flow start to fall, and only at maximal vasoconstriction at high blood pressures does cerebral blood flow start to rise. However, when the CNS is injured by pathology, this relationship can be disrupted and cerebral blood flow becomes directly proportional to the mean arterial pressure. And this can be conceptualized through the cerebral perfusion pressure, the pressure which is perfusing the brain, which is equal to the mean arterial pressure minus the intracranial pressure. Finally, whenever intracranial pressure rises, there is the possibility that an area of CNS or brain tissue will herniate through into another area of the CNS. This can be transtentorial, uncal herniation, or cerebellar herniation. The features of these are given on the slide and include things such as autonomic instability with hypertensive bradycardia, respiratory irregularity, temperature instability, neurological deficits such as cranial nerve palsies, respiratory arrest, and ultimately death. So now that we have reviewed the pathophysiology of raised intracranial pressure, I hope to take those fundamentals and apply them to the management of our child with a critically raised ICP. So if we return to our case, PICU are now in attendance, the airway is maintained with the jaw thrust, and the child is saturating well with a non-rebreather mask. A blood gas result has come back and shows a respiratory acidosis with a CO2 of 7.2 and a pH of 7.28. Otherwise, the gas isn't very remarkable. The sodium is at the lower end of normal, the glucose is normal. The child's hemodynamics are evolving, and the child is becoming increasingly hypertensive with a blood pressure of 139/88, and the heart rate has fallen into the 60s. Otherwise, his GCS remains at 6, his pupils remain reactive, and he is not febrile. We have already instituted our initial management with the use of oxygen to avoid hypoxia. We haven't been required to treat shock, and the blood glucose is normal, so we haven't been required to treat hypoglycemia. The child should be placed in a 30-degree head-up position with the head in the midline, and if anything is obstructing venous outflow from the head, this should be removed in order to allow for any compensation with venous blood reduction in the head as much as possible. The next step is to administer osmotherapy. The two options here are hypertonic saline, otherwise known as 3%, some brands are 2.7% saline, or 20% mannitol. Both of these medications work by creating an osmotic gradient between the blood and the brain tissue, pulling fluid out of the brain tissue and reducing the size of the brain within the CNS, aiming to reduce the pressure that it exerts. In terms of which is preferable, there is very little evidence to truly guide one choice over the other. I have included a forest plot from a meta-analysis comparing hypertonic saline with mannitol, which shows a trend towards improvement with hypertonic saline over mannitol, but it just fails to reach statistical significance with the confidence intervals, including 1. The take-home point here is that osmotherapy needs to be administered, and in the scenario of an emergency, you administer what you have to hand. In our child's case, the airway needs to be protected because the GCS is lower than 8 and the child is failing to control their CO2, which is increasing their intracranial pressure through increased cerebral blood flow. In addition to that, we want to scan this child's head as a matter of urgency, and in order to do that safely, airway protection should be undertaken. This will require intubation, the technique of which will require the most experienced intubator present to undertake, as you do not want to allow the CO2 to rise excessively during the intubation by having delays at the tube passage, and you want the tube to pass first time if possible. The technique should be through a modified RSI, so the child should be ventilated during the intubation to avoid excessive rises in CO2 and to avoid against periods of hypoxia. Drug choice should aim at avoiding periods of hypotension during the intubation. Classically, ketamine has been said to raise your intracranial pressure and therefore should be avoided in cases such as these. However, more recent studies show that the effect on the intracranial pressure is minimal, and the effect of other agents on dropping the blood pressure and the cerebral perfusion pressure could be catastrophic. Therefore, I would advocate for the use of ketamine with fentanyl as an induction agent and avoidance of classical agents such as thiopentone unless there is signs of active seizure and the child is very hemodynamically stable. You should prepare for a blood pressure drop in these scenarios so that you can act rapidly by having push dose pressors available and fluid boluses available. And you should also prepare for rises in the ICP with CO2 rises during the intubation by having further doses of osmotherapy present. Muscle relaxant choice, I would choose an RSI dose of rocuronium. Following intubation, the child should be ventilated to a normal CO2 of 4.5 to 5, which can be correlated with your end tidal CO2. A volume-targeted method such as PRVC is probably preferable for tighter control of CO2, and you should avoid hypoxia, titrating your FiO2 to a PaO2 of greater than 12. If you are going to undertake suction, you should pre-oxygenate the child adequately beforehand, sedate the child adequately with boluses of analgesia to avoid spikes in ICP, and monitor your end tidal during hand ventilation to ensure you're neither over or under ventilating the child. From a circulation perspective, initially 2 points of IV access is plenty. You want to arrange for urgent neuroimaging of this child, and delays in undertaking an arterial line or a central venous line may delay this child which may have a time-critical pathology which needs intervention. Any hypotensive spell should be treated aggressively with fluid resuscitation, and you should aim to maintain an adequate cerebral perfusion pressure. Different targets for cerebral perfusion pressures are advocated on this Paediatric Emergencies website for different age ranges. At this moment in time, we do not have an ICP monitor in situ, and therefore we are not able to guide our cerebral perfusion pressure based on an ICP. In those settings, you can assume an ICP of 20 and target a mean arterial pressure based on the table on the Paediatric Emergencies website based on age ranges. In order to titrate your mean arterial pressure, this can be done with the use of a diluted strength of noradrenaline, which can be run peripherally prior to a central line insertion. I would advocate that this infusion should be made up and attached, even if not required, because the delays in preparing it, if the blood pressure should fall, can be reasonable in duration. And you do not want the child to be subjected to excessive periods of hypotension. The child needs to go for urgent CNS imaging to rule out time-critical neurosurgical pathology, which requires intervention. Otherwise, from a CNS perspective, the child should be sedated and muscle relaxed to lower their cerebral metabolic demand, which will help reduce their intracranial pressure. Common combinations are of an opiate, such as morphine and fentanyl, with a benzodiazepine, such as midazolam, and muscle relaxation with rocuronium. If there's any sign of seizures, these should be treated aggressively with the APLS protocol. And different centres have different approaches to the use of prophylactic anti-epileptic drugs. I would advocate you discuss with your local neurosurgical or PICU team with regards to the use of prophylactic anti-epileptic drugs. Phenytoin and Keppra are common choices if they are to be used. Blood sugar should be monitored and hypoglycemia should be treated, and the child should be kept normothermic as pyrexia increases cerebral metabolic demand and will increase ICP. So active normothermia should be maintained. If the child develops signs of herniation, pupil dilatation, worsening hypertensive bradycardia, extensor posturing, then emergency management will involve hyperventilating the child by hand with 100% oxygen, delivering boluses of hypertonic saline or mannitol, and giving additional analgesia, sedation and muscle relaxation boluses. Additional aspects of this child's management to consider include: should CNS infection be covered? Local guidelines will guide you to appropriate choices of antibacterial and antiviral therapy. Fluid restriction, as this child is at high risk of developing SIADH, so fluid restrict to 80% with an appropriate isotonic fluid. Keeping the child nil by mouth and chasing up the results of your initial panel for the child with reduced levels of consciousness, including toxicology and metabolic screens. I've included the next pathway as an overview of ongoing management. So this pathway was taken from a publication last year in Paediatric Critical Care Medicine, which was looking specifically at the management of severe traumatic brain injury and gave an algorithmic approach to its management. This algorithm includes all of the tenets of management that we have spoke about so far: early CNS imaging, baseline care, positioning in the bed, midline positioning, maintaining gas tensions, and then how to manage herniation, raised ICP and reduced level of CPP. These aspects of management are the ongoing levels of care which are appropriate in traumatic brain injury but are applicable in other causes of raised ICP as well, and form the basis of ongoing management, usually within the ICU. This pathway terminates with other second-line therapies which are outlined in this image, but these are purely ICU level management and will not be involved in prior management before ICU, and I've included them more for information. So ultimately, what happened with our child? Our child was intubated and ventilated with a ketamine, fentanyl, rocuronium RSI, was ventilated to a normal level of CO2. They didn't drop their blood pressure, but they didn't achieve our target CPP, so were started onto peripheral noradrenaline at a low dose. They were sedated with morphine midazolam infusions and transferred to CT, where a large posterior fossa space-occupying lesion was found, which was causing hydrocephalus and impending cerebral herniation. Further doses of osmotherapy were delivered, and the child was transferred to neurotheatre for urgent EVD insertion to relieve the hydrocephalus and tumour debulking. So in conclusion, I hope at the end of this case you are now able to recall the causes of a reduced level of consciousness in children, to understand the pathophysiology of raised ICP, and to discuss an approach to the child with a critically raised ICP, bearing those pathophysiological principles in mind. I've also included some references for further reading. Thank you.
Well, welcome back, everyone. Hopefully you managed to get a quick bite to eat while we sort of having that discussion with Costas. you'll see that Dr. Stephen McVea has joined us. He's one of our new consultants in PICU and Children's Hospital. And thanks very much for the talk, Stephen. Very interesting.
Yes.
And there's been a few questions that have been raised just during it. So I suppose the first thing was to do with sedation. So if you're sedating these kids, what sort of key principles that you want to be thinking about to guide how much your choice of sedation?
So yes, so the children with the raised ICP, once you've intubated and ventilated, you do want to keep them quite well sedated. I favour a combination of an opiate and a benzodiazepine, and particularly probably favour the use of fentanyl as the opiate. The reasons behind that, you're wanting to manage their ICP, and these children are at risk of ICP spikes. And I suppose it's more in the ICU once we have something that we can monitor the ICP with. But if we have an ICP spike, one of the methods of bringing it down would be to increase your sedation, and you want to use something that will work quickly. You don't want to oversedate the patient too much. You want to have them relatively deep. But once you've achieved good sedation, then additional boluses other than managing ICP spikes aren't really indicated. You don't want to compromise your blood pressure with the use of excessive sedation. And in those scenarios, once you've achieved adequate sedation, then you'll use other methods for treating ICP, such as hypertonic saline or other osmotherapies. The reason I like fentanyl in the ICU is once you've got an ICP monitor in, if you're going to treat anything, it works quickly. And that also holds for scenarios where you might do something which might cause the ICP to spike. And the classic example in the ICU is a suction. So if the child is going to undergo a suction, you'll give them a bolus of something like fentanyl, which will work quickly and will cover against an ICP spike during the suction. Whereas other opiates such as morphine, you'll have to wait longer for the benefit before you can undertake your procedure. And often people don't wait long enough for it to have had its maximal effect, and therefore you risk an ICP spike with morphine versus fentanyl.
Yeah, grand. Thanks. And you mentioned osmotherapies there and briefly touched on it, I suppose, in the talk, but hypertonic versus saline versus mannitol, bit of debate about those. Just keen to hear your impression or your thoughts as to preferences.
So I suppose when you're reaching for them now. You need them now to give. So what you have available, if you have one over the other available to you, you will use what you have available. My personal preference would be for hypertonic saline, all other things being equal, if I had a choice between the two in that moment. A few reasons for that. First of all, I covered briefly in the talk, there is some evidence in the literature of a trend towards improved outcome with hypertonic versus mannitol. From a practical perspective at the bedside, hypertonic will act as a fluid bolus and will pull fluid into the circulation and will therefore help you maintain a blood pressure, which will be helpful for cerebral perfusion pressure. Whereas mannitol will work as an osmotic diuresis, and with its use you will lose volume from the circulation and you may therefore be chasing your tail with regards to your blood pressure. The other aspect with mannitol being an osmotic diuresis, these children are at risk of developing complications of raised ICP, for example, diabetes insipidus, and mannitol causing a diuresis will cloud our assessment of that down the line. So my preference would be for hypertonic over mannitol.
Yeah, great, thanks. And just one other thing I thought was interesting in talk. So we're talking about induction agents. And obviously, I suppose there's old evidence there to suggest the use of ketamine might increase your intracranial pressure. But your worry about other agents and in the hemodynamically unstable child, your argument would still be that ketamine would be your choice. Can I ask you just to elaborate a little bit more on that? Or?
Yeah, I suppose you draw evidence from other areas, and one of the main areas is in traumatic brain injury with raised ICP, and the evidence out there suggests that even a single episode of reduced mean arterial pressure of hypotension in that setting can have catastrophic effects upon the outcome in the case. And I think that in these scenarios, the evidence for the raise in ICP is quite weak. The evidence that we have for the detrimental effect of a drop in blood pressure is quite strong. Therefore, I think in the induction period, unless you've got an active seizure, you're strongly advocating for the use of ketamine to maintain hemodynamic stability during the intubation. Even in the setting of an active seizure, you can make a strong argument for the use of ketamine in terms of getting the intubation done and then using other agents to sort the seizure following the placement of the ET tube. So my preference would certainly be in favour of ketamine in those cases.
Good. Thanks, Stephen. Any other? Yeah, Costas, comment?
Add to the previous question on the 3% versus mannitol. So I think Steve hit the nail on the head, and the general preference from ICUs in the UK is for 3%, but the evidence contrasting the two has been quite weak until recently. I mean, there's one of the few RCTs comparing the few in children came out last month in pediatric critical care medicine, comparing ICP spike management with either side. So it was a RCT, small size RCT, about 28 patients, I think, and it unequivocally showed that 3% is superior to mannitol in controlling those ICP spikes. So we finally have some evidence in favor of 3%, which is easier to find and easier to use, I find, in children.
Perfect. Thanks, Costas. Grand. I think in the interest of time, we're going to move on to next talk. So I'll hand over to Chris to let him introduce that.
Okay, thanks, Ben. So our next speaker is Dr. Tom Waterfield. He's a newly appointed consultant in paediatric emergency medicine in Dublin, and he's going to be talking about recognition of the sick child.
Thank you very much for inviting me along to the Paediatric Emergencies Conference 2020. I'm Tom Waterfield, and I'm a paediatric emergency medicine consultant and clinical lecturer at Queen's University Belfast. And I'm going to talk to you today about recognition of the sick child. If you'd like to learn more about recognition of the sick child, or particularly the approach to young infants, particularly with a fever, then there are podcasts available on the Paediatric Emergency website, and there's some details of those there on the screen now. So the aim of my talk today is to really talk about children that present acutely to either general practice, pre-hospital settings, A&E, and it's aimed really at anyone that would have to work with an acutely unwell child all the way through from kind of pre-hospital all the way up to the paediatrician. Primarily what we see in the emergency department are previously well children with febrile illnesses, so that will be the bulk of this talk, although we will cover some other areas. And the aims today are to go through risk stratification, so by that I mean trying to determine who is high risk before you even see the child. A little bit about the history and what the kind of key points are to try and get from the history. A little bit about observation, so actually what we can get from observing a child from a distance. A little bit about vital signs, so observations, some key points for the examination, and some discussion of red flags, particularly focusing on kind of NICE guidance and sepsis guidance. And there's a picture there of a puzzle. The way I'm trying to think about this is very much like a jigsaw puzzle. There is unfortunately still no single piece, whether that be a piece of history, a clinical feature, or a blood biomarker that can tell us whether a child has a serious infection or a serious illness. We have to get all the different pieces and put them together to build a picture. And unfortunately in paediatrics, some of the pieces aren't even given to us. We have to go looking for them, we have to ask the right questions and examine for the right things to actually get them. So risk stratification. So the point of this really is, just like in the pictures there are some activities that you can see which you would know are risky. If someone told you were going to do bull running in Spain, you'd have some concerns even before they went that they might come to some harm. And it's a little bit like that in paediatrics. So it's important to note that most of our guidelines and our evidence and our practice is built around research of healthy children. On the whole, they exclude children with underlying health problems. So in terms of the risk stratification, you want to think, before you even see this child, do the guidelines that we know about apply directly to this group, and are they at higher risk of something going wrong? So kind of one of the most obvious examples there are newborns or neonates, so children under a month. So kind of as our background, the study from Australia, still a bit old now, but still I think holds true, the fever study, which looked at children in the emergency department. And they reported that about 14% had serious infections. Now that's a slight overestimation, and that kind of reflected in their own data. with quite a high proportion of pneumonias which were probably viral. And it probably explains why about 1 in 3 of their children with serious infections, by research definitions, got better without treatment. But if we take that as a kind of baseline population, 14% of children with fever and ED may have some sort of infection that's a little bit more serious. Let's look at children under a month. So we've taken quite a high estimate. If we take children under a month, probably some of the best data comes from the Spanish group and the step-by-step study, which was 2,000 children across Spain and Italy from kind of 2015, 2016. And they had a 26% likelihood of serious infection, 4 times the risk of invasive infection. So even against kind of pretty high estimates in older children, neonates are still far higher risk. So that's one of the first things. So children under a month are very high risk, particularly if they're presenting with a febrile illness. And that group of children, which have a very low threshold for discussing with paediatrics, so we'd expect kind of all children under a month to undergo a septic screen, and only really in exceptional circumstances would they not. Other things that you may see, so ex-premature infants, so graduates from the NICU, they may have underlying chronic lung disease, so they may have home oxygen, like in the picture there, which would make them more vulnerable even to common illnesses like kind of the common cold, rhinovirus, for example. They may have underlying poor health, and all of these will make them more susceptible to kind of common everyday illnesses. And then age, and I've expanded the age a little bit here. So under a month, the risk of serious infection is much higher. So that's actually a real risk, if you like. And between 1 and 3 months, that risk drops away pretty quickly. And by the time you get to 6 months, actually the risk of serious infection is pretty similar to that of a 2, 3, 4-year-old. But actually I've included all the way up to a year there. And the reason I've included a year is actually a bit like we talked about the puzzle pieces and trying to kind of, some of them aren't obvious for us. Children under a year actually can be quite difficult to assess if you're not comfortable and experienced with that age group. Their physiology is spectacular, they're incredibly fit, they're like little Olympic athletes, so they can cope incredibly well with quite nasty infections for quite long periods. They're not verbal yet, and actually the examinations can be challenging. So certainly under a month you need to be aware that the risk is very high of serious infection if they're febrile. That probably doesn't drop away until somewhere between 3 and 6 months, but certainly depending on your experience, most paediatricians would be happy to assess a child under 1 if you had any concerns at all about their appearance. So with that risk stratification in mind, that's just helping for you to kind of identify who's at high risk of something more nasty before you even start talking to the family. History, so today you'll probably hear lots of things that you must ask for in the history. Like the cardiologist colleagues will have things they want, the metabolic team will have things that they want. I try and keep this very simple. So we're focusing here on, is this child very sick? Again, if we say most children that we see have a febrile illness, fever is the main reason that people attend GP and A&E. So you need to clarify the points for the parents. We're all now practicing medics in some way or another, and it's not enough just to kind of repeat or copy down what the parents have said. We need to try and clarify and understand what those points are. In particular, ask around the duration of the illness. So most febrile illnesses last 3 to 5 days. If it's going on for more than 5 days, why is that? Is it a secondary infection? Have they got an underlying malignant process? Is this an inflammatory condition? Ask about what's happening in between the temperatures. So most self-limiting illnesses have a natural variation during the day. So they may look dreadful during the fever. They may be mottled, miserable, clingy, irritable. They could have many of the features which would be on many sepsis checklists. But actually the temperature when it wasn't there, the child was eating, drinking, playing with the dog, near enough back to normal. And it's that variation which we would normally see with most self-limiting illnesses. So ask about form, play, behaviour. What's that like when the temperature's not there? Think about intake, so you can ask about wet nappies, how much they're eating and drinking. Food intake isn't too worrying, certainly for 2 or 3 days, but fluids obviously more concerning, so we need to make sure that children are getting enough fluid in. And then I've just put a note there, but always beware of the child that's been lethargic, unwell all day without variation. I'm always very concerned about the parent that says, you know what, there was a lot of up and down for the first couple of days, but today all they've wanted to do is sleep on the sofa, even when they've not got a temperature. So for those of you that are nervous about examining children, this part of the scenario is really useful for you. So it can be difficult to examine children, especially young children. They can be a little bit nervous of us. We're now increasingly wearing PPE. The interactions are becoming more and more challenging. So use observation. If you notice, people that are used to working with children will often take a history, will stand back in the corner of the room, and actually most of my gaze is on the child while I'm taking the history, because I'm trying to get as much information as I can whilst they're comfortable and relaxed. And actually, when you're doing the observation, think about it in a structured way. So, you know, it can be a bit nerve-wracking seeing children, and just think A, B, C. So from an airway point of view, if they're talking or crying, or maybe they've got stridor, and maybe you can hear that at rest when they're sitting on their mum's knee, that's really important. And it's an important finding even without the need for a stethoscope. Breathing, so most children under 5, because that's where the challenge is for examining children, are happy in their shorts or pants. If they've got a temperature, they may be quite comfortable being stripped down, and the parents can do that for you if you're not in a hospital setting. And then you can look at their breathing. So what's their respiratory rate? You can time it. What's their work with breathing? Is there a prolonged expiratory phase? Are they taking a long time to breathe out, which may be indicative of wheeze? It's a lot easier to see that prolonged expiratory phase than it is to actually hear really tight wheeze if you're not used to it. And then cardiovascular. So it's hard to do a cardiovascular exam, but actually remember, most children over 1, the presence or absence of a murmur is of little value. It's useful in the child under 1 who may have an underlying cardiac problem exacerbated by a viral illness, but healthy children over 1, the presence of a murmur isn't often that helpful. What is helpful is their perfusion. So what's their colour like? Are they ashen? Are they pale? Are they mottled? And so some of that you can get just from looking. And then disability, so are they alert, active, are they only responding to the voice? And then an exposure, so if you strip them down, actually, do they have a rash? Are there any injuries? Is there anything else that you're worried about? So if you think now, actually, you could be someone who's quite uncomfortable seeing children, perhaps you work in a pre-hospital setting or you're newly qualified, and you already have an idea of who's at high risk, what are the key points in the history, and you can put together a reasonable assessment just from a couple of minutes of observation. And certainly enough that if you struggle on the examination, you'll be able to talk to your paediatric colleagues and get some advice. So observations, so we put those in, we really mean vital signs, so heart rate, respiratory rate, central capillary refill time from the head or the forehead, a body temperature and oxygen saturations. And there are normal ranges and they're widely available. People that work with children every day will get used to these. The important thing is that you know that they exist and where to find them. And there are lots of apps and they're also available on the internet, and most departments will have them up on their walls. So just to be aware that they exist. I'm going to talk a little bit about abnormal observations in a moment, but temperature. So we get a lot of problems with fever phobia. We get a lot of reattendances where parents are worried because their child's had another temperature. A fever really is just telling you that the child has typically an infective process. You can get fever with malignant processes and with inflammatory conditions, but in a previously well child, on the whole, it's going to be because they've got an infection. Most febrile illnesses last 3 to 5 days, and the temperature will fluctuate naturally with the symptoms matching that. A normal body temperature, traditionally people have struggled with that, we've asked that question, but with COVID people are getting more used to it, but 36.5 to 37.5 is the normal range. The temperature going up, or the height of the temperature, is actually pretty poor marker of severity, so that's one of the kind of myths that we get. So the temperature is 40, it must be a dangerous infection. In young children, certainly under 5, they're very labile with their temperatures. They can have a temperature of 40 with rhinovirus and a low-grade temperature with meningococcal. And that's not, just anecdotal, that's fact. So the meningococcal, the PIC study which we ran, 37 hospitals, 1,300 kids, 20 cases of meningococcal, 2 of those, or 10% of our meningococcal cases, had very low-grade temperatures, just 38. So it's not necessarily the severity of the illness indicates the height of the fever. The other one that we sometimes hear is that if the fever comes down with antipyretics, that's reassuring. And again, that isn't actually true. All that's telling you is that your antipyretics work. Almost any temperature will come down to some extent with antipyretics. We do, however, in A&E often give antipyretics to children who are febrile, but that's not because we need the temperature to come down. It's because it goes back to that variation. We want to assess that child without their temperature. So if you think about if you've ever had a temperature yourself, or if you've got kids, a high temperature, their heart will race, they will breathe fast, they may pant, They will be mottled, they can be miserable or lethargic. All of these symptoms can occur. And they're driven by the temperature. But actually, at that moment in time, they may be hitting several triggers on sepsis. And you've got to make that decision quickly. From my experience, I think this is a common cold and I think it will settle, or I need to go on and start to treat with antibiotics. So we bring the temperature down and reassess. So that's the key point. If you're in the community and you see a child and the temperature comes down, check the heart rate again, check the respiratory rate again, make it clear that you've seen an improvement, and check with the family. Often we'll see children in the emergency department and the parents are very stressed, very worried, and pretty certain their child's going to be admitted to hospital when they arrive. Only for 45 minutes later for them to actually say themselves, volunteer that their child's much, much better and they'd be happy to go home. And there has to be that kind of agreement that you've seen that improvement in the child. There's lots of ways of bringing the temperature down. So Calpol's on the picture there, so paracetamol, you can use ibuprofen. The reason this is there, it's just if you do combine paracetamol and ibuprofen, you will get a greater reduction in temperature, but it's very small, 0.1, 0.2 degrees, so it's not clinically significant, and then you lose your antipyretics for 4 hours. So we tend not to give them together, we tend to try and space them out. So I said I would come back to kind of abnormal observations. So a lot of us are taught, and I was trained early on, you don't let a child go home with abnormal observations. But that's probably a little bit rigid. I think the key point is that we shouldn't be ignoring abnormal observations, choosing to ignore them and send them home. And we need to be aware of what the normal ranges are, and we need to have a look. But how dangerous is it to actually send someone home with abnormal observations? This is a really nice paper that looks specifically at that. So a similar size centre to what we have in Belfast, and essentially looked at children with abnormal vital signs at the times of discharge. And they looked at adverse events. So this included readmission for reattendance for prolonged admission, needing resuscitation, needing intubation, or needed surgery. And what they found was there's two kind of points to take. So it is more risky if you send someone home with abnormal observations. They are more likely to reattend. But actually, it's 2.5 times more likely, but from a very low risk point. So as we go back, most children we see in the emergency department actually will be able to go home. Most febrile illnesses are self-limiting and benign. And even if we send children home with abnormal observations, the absolute risk remains very low. But the relative risk does go up. And so the kind of key point here is, I think we probably can move away from saying you can never let somebody home with abnormal observations, but we have to be clear why we're letting them go home and communicate that plan with the family. And kind of simple examples might be, you've diagnosed a child with a lower respiratory tract infection, you've commenced them on treatment and they're slightly tachypneic. Well, that's okay, you can explain it, you can monitor for the other vital signs, and you can allow the family home with a plan. Likewise, the child with a normal heart rate on arrival in the emergency department who's had salbutamol and is slightly tachycardic at discharge. We don't necessarily need to admit that child overnight just because they're tachycardic. As long as you can put the rest of the puzzle pieces to show that child isn't septic, you can communicate that risk with the family. And you can be fairly reassured that the absolute risk is pretty low. So finally, examinations. You kind of have to bite the bullet now. If you don't like working with children, or it's not something you do in your day job, you'll have to get and examine them. And the reason I've got that picture, that's a recent picture of me and my family we had done in a photo studio, and it looks wonderful. Looks like we've sat and posed and just got that. But the photographer was great, and they would have been an ideal paediatrician. So that picture came after getting them to jump off the bed, after play, and that picture's directly after they overran and jumped on us, and they managed to just capture the moment as they kind of turned around. But it's that opportunistic kind of nature that you have to have as a paediatrician. So remember, this child is not on their best form. They've not seen you before. They've got a temperature. You're wearing PPE. They're a bit scared. They're a bit nervous. You don't need to lift them off their mum. You don't need to get them stripped nipples to knees at 45 degrees like you had to for your medicine, finals. You have to be opportunistic and think where the value is. Go back to that ABC. The airway, you can listen. You don't need to put your hands on to do that. Breathing, make sure you've had a look first. What's their respiratory rate? What's their work with breathing? Have they got that prolonged expiratory phase? If you're listening in, what are you listening in for? Primarily wheeze in young children with a febrile illness. Is there any focal crackles that may help with a lower respiratory tract infection? The cardiovascular exam, it's really more around pulses and perfusion. by all means you'll listen for heart sounds, but again, in a child over 1, young children may have cardiac lesions, and that's different, but in older children, really, they may well have a murmur, and that's likely to be flow. From a kind of disability point of view, use the AVPU scale, so are they alert, responding to voice, pain or unresponsive, and then if you strip them at this age, you'll be able to look for rashes quite easily. So the physical exam is actually quite quick for the assessment of the sick child. It's more complicated for some of the more detailed specialties, but hopefully we examine those children when they're on good form in a controlled environment, and it'll be easier to perform the examination at that time. So finally, we've kind of kept away a little bit from guidelines until now. So there are lots of different guidelines. There's the NICE sepsis guideline, which has 3 different pathways based on age. There's the Sepsis 6, Surviving Sepsis campaign, which also has algorithms for pre-hospital and in-hospital, and also specialist and non-specialist. You also have the NICE feverish illness guideline, and then not to forget, you also have the NICE meningococcal septicemia guideline. And all these guidelines overlap and don't necessarily agree. So it is tricky. And I'd encourage you to have a look and consider your local guidelines and how you might follow those. My preference still probably the NICE feverish illness guideline. I think it has the best balance in terms of allowing for assessment of a child and some decision making around safe discharge, whilst also helping you spot sepsis. There's actually 16 red flags in the NICE feverish illness guideline, and I still haven't met anyone yet who can kind of rattle all 16 off. But I tried to condense them down and want to reassure you that they're not actually that scary. So a fever under 3 months, well, I think we've discussed that and you'd be happy. Looks unwell to you. So remember, if you're all now used to working with people or children, you're a healthcare professional, and if you think this child looks unwell, take that seriously. Lethargy, and I've mentioned that again because beware that lack of variation, that child that's lethargic all day. Shock or dehydration, I think we'd all be worried about. Severe respiratory distress and signs of meningitis or encephalitis. So they're not that complicated, the red flags, if you break them down into those 6. How reliable are the red flags? So if we go back to the same studies, the fever study we mentioned earlier looked at this. So the absence of a red flag kind of shouldn't be reassuring. Just because a child doesn't have red flags doesn't mean they won't have a serious infection, unfortunately. So you still have to look for some other features. But actually the presence of red flags puts the specificity up quite high. So, my interest is around diagnostic tests. That specificity would be similar to an abnormal white cell count or abnormal neutrophil count. So, if a child has a presence of a red flag, actually their likelihood to have a serious infection goes up quite significantly. So they shouldn't be ignored. Another paper looking at a similar thing kind of attached scores to red flags and then produced what's called a ROC curve, which is essentially a trade-off between sensitivity and specificity, and looked at different studies and combined them. I think the point here is that they're not perfect. A bit like that puzzle piece from earlier, there's no single red flag, unfortunately, that will tell you this child definitely has a serious infection. I think the only thing that probably comes out consistently across multiple data sets and multiple studies is lethargy. So and proper lethargy, not feeling tired and washed out, but actually this child is hard to wake up, and if they are awake, they fall back to sleep quickly. A little bit about clinician instinct. So another study here just looking at what clinicians thought, and certainly if you think this child has a serious infection, there's a very good chance that they do, and I would trust that instinct. Personally, kind of like evidence-based medicine, but I don't think evidence-based medicine and instinct are separate. Hopefully from what we've kind of pulled out in this is with the puzzle pieces, we aren't going to be replaced by Alexa. It takes some skill to take the history, examine the child and pull together all the features you need. And sometimes there's lots of these little puzzle pieces that just aren't adding up or giving you an uncomfortable feeling, and it's hard to necessarily pinpoint exactly why that is, and that may be that clinician instinct. So as long as you take a moment to think, why am I worried? If you're still worried, trust that and act on it. So kind of in summary, we've had a kind of brief overview today of how you might look for the sick child, and I've tried to really condense it down so that it would be applicable to kind of pre-hospital, general practice, A&E and even paediatricians. And the aim is to make it kind of easy to what's the really high value stuff that can help you spot sick kids. So we talked about risk identifying and being aware of those children that are more vulnerable, and then having a think about where you are, who you are, and whether you need help with those children. We've talked a bit about the history, so by all means complete a full paediatric history, but particularly we need to be clear about duration of temperatures, what's happening in between when the temperature's gone, and some information around intake and their fluid status. We've talked a bit about observation, which is really key and is not kind of necessarily always taught. So a lot of us will spend, while we're taking the history, watching that child. You can get a huge amount of information if you just put a structure to it, and can nearly perform the major part of your examination just from the doorway. We talked about vital signs, the importance of knowing the normal ranges, but also some pragmatic views about actually we can send children home with abnormal observations as long as we've thought about why they're abnormal and we've communicated a plan. We talked a little bit about the examination and how we can keep it brief, and focus on the areas that we need to, and a little bit of a brief discussion around red flags and how they might fit into our practice. So yeah, thank you very much for inviting me along, and I look forward to watching the rest of the talks over the course of the day.
Okay, I'm sure you'll agree that was a great talk from Tom Waterfield. Unfortunately, it's a good thing. He has started a new consultant post down in Dublin 2 days ago, but that means he hasn't been able to join us today. So what we're going to do actually is just go straight into Emmeline Heffernan's talk on DKA. We have noticed a few questions coming through with Tom, so we're going to actually address those in the question panel after Emmeline's talk as well. So we'll do both Emmeline's and Tom's questions at that stage. And whilst Tom's not here, we'll put them to the panel. So I'll just hand over to Chris then to introduce Emmeline.
Okay, so we'll head over to Dr. Emmeline Heffernan's talk. She's one of the paediatric endocrinologists in Belfast, and she's talking about DKA and in particular the new DKA guidelines.
My name is Emmeline Heffernan. I'm a consultant paediatrician with a special interest in diabetes and endocrinology, working in the Children's Hospital in Belfast, and I'm going to be talking to you today about DKA. So just to start, I'll be starting with a little bit of background and then go through the definition and just some details about the diagnosis. I'll talk about the different presentations, not all of which are classical, and then I'll go through the emergency management, and we use the BSPD guidelines, which were updated earlier this year. And I'll take you through a case and then discuss cerebral edema and answer some questions. So why is DKA so important? Well, it's the leading cause of death in children with type 1 diabetes, and it accounts for between 60 and 90% of mortality for children with diabetes. It happens quite commonly at diagnosis. The National Paediatric Diabetes Audit surveying England and Wales shows that almost a quarter of children present and in DKA at diagnosis of type 1 diabetes. That percentage is higher for younger children, and particularly the under 2s, where the signs aren't always as obvious. Anecdotally, I think there's more presentation in DKA recently with COVID, and that may be due to difficulties accessing assessment in primary care, or perhaps parents being unwilling to come to hospital as well. However, DKA also happens in children with known diabetes, and again, the National Diabetes Audit showed that 20% of children will be admitted with DKA at some point in a year. Locally here, our numbers aren't quite as high, but there are some children that will present repeatedly in DKA, and the risk is higher if they have poor control, so HbA1c over 80 millimoles per mole, or around 9% in the old terms. It's also more common in adolescents, so rebellious teenagers, and also in children from difficult social circumstances. So the risk, the main worry with DKA is obviously cerebral edema. And historically, it was thought that this didn't happen very often. Previous studies looked maybe 7 per 1,000 episodes had cerebral edema. However, recent more neurological imaging studies have shown it is a bit more common than that. And interestingly, the diabetes audit showed that mannitol or hypertonic saline was actually used in 12% of DKA admissions. So that is very high. And I think the reason for that is that as soon as we suspect cerebral edema, we should treat it. Now, because cerebral edema has a very high mortality of 24%, and a third of children are left with severe neurological deficit. So we all know the 3 cardinal features for the diagnosis of DKA, but it's important to note that glucose doesn't have to be that high. So blood glucose over 11. If you look after children with type 1 diabetes, particularly teenagers, you know that's not that uncommon. So a child with known diabetes with relatively normal sugars, if they're unwell and vomiting, they should really be testing ketones at home. And if they present, it's important to think of DKA, even if their sugars don't seem that bad. You also need acidosis, so venous or capillary pH below 7.3 and bicarb below 15. The previous BSPD guidelines said bicarb below 18, but now it's changed to 15, and that correlates with the ISPAD guidelines as well. And also capillary ketones over 3. In some centres, they check ketones in the urine, and it's really important to notice you need 2+ of ketones in the urine, and I'll come back to that in a minute. So if you've got those 3 features, you've got DKA, and it can be classified into mild, moderate, and severe based on the pH. So mild DKA, the pH 7.2 to 7.3, bicarb 10 to 15. Moderate, pH 7.1 to 7.2, bicarb is between 5 and 9, and a severe DKA is pH below 7.1 and bicarb below 5. So when to suspect DKA? So it doesn't always present in the classical manner of a child with weeks or months history of polyuria, polydipsia. Maybe they've started wetting the bed, they've lost weight, they're very tired, then they gradually develop abdominal pain and vomiting, deep sighing, Kussmaul's respirations, etc. Sometimes the child will be brought to hospital, query gastroenteritis, so the parents are worried the child is vomiting, but there's no diarrhea. Sometimes the parents will be worried the child's dehydrated because they're vomiting so much and they're really thirsty, but the clue would be that they're still passing a lot of urine. It can often present with an acute abdomen, so abdominal pain, severe, which can be severe, and vomiting can be DKA. And then sometimes the Kussmaul's respirations, those deep sighing Kussmaul's resps, the child is tachypneic, has distress, however their chest is clear, there's no cough, no fever. With any of these, you should think about DKA and ask about the osmotic symptoms, but not every child will have that history. About 86% do have the classical osmotic symptoms, but some children don't have them. So interestingly, we also have some things that mimic DKA. So a few years ago, we had a case of an infant who presented with abdominal pain and vomiting, and the gas showed a severe metabolic acidosis, and they checked the BM, which showed a blood glucose in the teens, the high teens, and the urine was checked, and there was ketones in the urine. So that child was thought to have DKA, commenced on insulin, but quickly went hypoglycemic despite the very low insulin dose. And then reviewing the investigations, when they came to PICU, it turned out the urine had only 1+ of ketones. So if you do check urine ketones, it's important to make sure that there is enough for the diagnosis. That should be 2+ or more. And that child just turned out to have a surgical abdomen. So management then, we use this British Society of Paediatric Endocrinology and Diabetes guidelines. They were updated earlier this year. The new update is really a focus on restoring circulation in children with shock. There's also guidelines with ISPAD, and we'll be updating guidelines next year for management of DKA as well. We've recently started using the care pathway on the BSPD website, which is really good. It's very, very handy. It looks quite wordy, but it's very practical, and it really walks you through everything. So if people ask me about questions about managing a severe DKA, or they're worried about DKA, I'll generally say just look at the guideline because it's really good. So if you go onto the website under guidelines and look for the care pathway, there is a place where it says the DKA calculator. And if you click on that, you can put your own patient's name, their date of birth, their weight, their pH, and if they're shocked or not, and what insulin rate you want to start. And if you put in all those details, it will complete all the calculations for you, and then you can print that out for your patient. So it's very good. The calculator is excellent. So a recent case that we had is a little 6-year-old boy. He had quite a short history of just 2 days of polyuria and polydipsia. And he presented to the emergency department because of abdominal pain. He just had 1 vomit, but he was very lethargic and he wasn't able to stand up. He'd previously been well. There was no known family history of diabetes or autoimmune conditions. So the triage nurse quickly suspected DKA and checked the capillary glucose, which was high, around 21, and the ketones were also very high, 4.7. So this child was brought round to resus, and the venous gas was checked, showing severe metabolic acidosis. So the pH was 6.8 and the bicarb was only 1.4. So their initial management then, if you look on the care pathway, it does also take you through the ABC approach. So his airway was patent. He had Kussmaul's resps. He was very tachypneic, resp was 36. SATs were 100% on them, 100% oxygen via rebreather. But he did have ketotic breath. I would love to be able to smell ketones, but I unfortunately can't. But some people can, and that's really useful if you can. He was also tachycardic, heart rate was 140, but blood pressure was normal, and he had poor central cap refill of 3 seconds and was very pale with cold peripheries. However, he was alert, he was able to answer questions, he said he felt fine, he was able to follow instructions and obey commands, pupils were equal, and he was moving his eyes normally. So just thinking about that, what would you do next? So the emergency management, if you haven't looked after a child with DKA before, it's really important to get senior help, or at least inform a senior doctor you have a child in with DKA. If there is a reduced GCS or they're repeatedly vomiting, think about protecting their airway. So do they need airway adjuncts or support? Maybe nasogastric tube, trying to prevent an aspiration pneumonia. In general, you want to avoid intubation because the CO2 may rise, and that can reduce the pH of the CSF and actually trigger cerebral edema. So intubation isn't necessarily the answer here. Give them 100% oxygen. Check the cardiovascular system. Cardiac monitor is really useful, and that will give you an early sign of low or high potassium. If there is no shock, you should give 10 mils per kilo bolus of normal saline over an hour. So that's basically your free bolus just for coming in DKA, and that gives you time then to work out the other calculations and figure out what to do next. However, in our case, if you're shocked, you should have 20 mils per kilo bolus of normal saline over 15 minutes, or plasma-like can also be given. Then the child should be reassessed, and if necessary, a further 10 mil per kilo bolus can be repeated twice, up to a total of 40 mils per kilo saline. But if there's ongoing shock or hypotension, then at that stage you may need to consider inotropes and discuss with PICU. It's worth noting sometimes the GCS can be really reduced and the child can seem quite unwell. If that is the case, it's usually related to the pH. However, do think, are there signs of cerebral edema there? Do I need urgent anaesthetic review? And I will come to cerebral edema in more detail later on. The other thing it's really important to do is try and get an accurate weight as soon as you can, because you really need an accurate weight for working out all the fluids. So going back to our case, and looking at on the side, you can see this is the care pathway. Again, it walks you through everything. Because he was shocked, he got a 20 per kilo bolus of normal saline over 15 minutes. And on reassessment, he was much better. His colour improved, heart rate was down, and cap refill was normal. So next, we're moving on. He didn't need a repeat bolus. Next, we move on to calculate the other fluids. So first of all, the deficit or dehydration, that is based on the child's pH. On a mild DKA, the deficit is 5%, a moderate, it's 7%, and a severe DKA, like in our case, is 10%. And then you use that percentage times their weight times 10 to get the volume of the deficit in mils, and that's replaced over 48 hours. If the child is not shocked and they've given the 10 per kilo bolus just for turning up in DKA, you do take that away from your deficit, but you don't subtract the resus fluids. The maintenance fluids are now calculated in the standard way. So previously there was a special formula for children in DKA, but we just used the standard method. So a child under 10 kilos gets 100 mils per kilo per day. Weight 10 to 20, it's 50 mils per kilo per day, and any weight above 20 is 20 mils per kilo per day. But it's important to note, if you're dealing with a very overweight child, you should have a maximum weight of 80 for a teenager, and look at the growth chart just to check the 97th centile for that child's age, and don't overdo it with the fluids. The care pathway also has guide weights for different ages as well to refer to. So your hourly rate really is your deficit minus the initial free bolus, if you got it, plus your maintenance for 48 hours, and divide all that by 48 hours. But I would recommend using the care pathway and the fluid calculator on that, and that keeps you right. The initial fluid is normal saline with 20 millimoles of KCl per 500 ml bag. The only reason you wouldn't give KCl would be if it was high or the child seemed to be in renal failure, in which case you'd wait till the potassium falls to the normal range or till they pass urine. The reason that it's important to give potassium from the beginning is once you correct the acidosis and once you start insulin, the potassium is going to be driven into the cells, and you can really run into problems with severe hypokalemia if you're not replacing that potassium from the get-go. So going back to our case, you can see there on the pathway, it's all worked out beautifully for you. So the deficit is calculated 10%, 10% times the weight times 10, and divide that over 48 hours, and that's your deficit replacement. Your maintenance calculated in the standard way, and then that gives you the total volume per hour. And that is just worked out really nicely for you on the pathway. So next you're thinking about insulin. There's no rush with the insulin. You can wait for 1 to 2 hours after fluids are started before you give the insulin. A lot of places will have pre-filled syringes, 50 units of Act Rapid and 50 mils of saline, or you can make that up. The starting dose can be either 0.05 or 0.1 units per kilo per hour. Some places will tend to start at the lower end, but if you have severe DKA, it's fine to start at the higher end. It's really important if the child is on a pump, that should be disconnected because the pump is not working. However, if they're a known diabetic, you continue their background insulin, their basal insulin, or a new diabetic, you could give basal insulin at that point as well. It's worth noticing that if your ketones are very slow to clear, for example, after 6 to 8 hours, if your ketones are still very high, you can increase the insulin. So if you started on 0.05, you can increase to 0.1 units per kilo per hour. However, the capillary ketones at the bedside, they're not accurate over 5, so a 6 is the same as an 8. So don't worry too much if it's if you're thinking, oh, it's gone from 6 up to 8. It's really not changed. These children require very close monitoring, really. Often their HDU level, particularly if there's like a severe DKA with pH below 7.1 or if they're under 2. In those situations, they need really half-hourly CNS OBS and one-to-one nursing. However, all children really need hourly CNS OBS, hourly capillary glucose, capillary ketones. Gas, electrolytes and glucose should be done after 2 hours and then 4 hourly at least, but more frequently if needed. It's very important. The doctor will obviously be seeing this child at diagnosis, but then at least 4 hourly. It's important that they're reviewed just to look at their observation chart, what's their GCS, look at their results, including their corrected sodium, and I'll come to that in a moment. Look at the ECG trace, is there a sign of low or high potassium, and looking at the fluid balance. So they do need very close observation. Going back to our case, you can see what happened through the pathway there, and I'll go into this in some detail in a table in a moment. The important things to note are once the glucose falls below 14, you should add dextrose to your maintenance and deficit fluids. If the glucose falls again below 6, you can increase the percentage dextrose in the fluids, and up to 10% can be given peripherally. So this is just showing the progress of our case. So he came in early in the morning, was in shock with a high heart rate. Bloods confirmed DKA. He got a 20 ml per kilo bolus over 15 minutes. And then at the next set of OBS, his heart rate had improved. He still had very high glucose and ketones, as you would expect. And at that point, he started the maintenance fluids, which was normal saline and 20 millimoles of potassium in a 500 ml bag. A couple of hours later, he got a repeat gas. The glucose is the same, really. The ketones are still high. It's still early days. His pH is still a severe acidosis. At 2 hours, he started on the insulin. It was started at the lower rate of 0.05 units per kilo per hour. 6.5 hours in, at the next gas, you can see the glucose had fallen down to 12.4. So at this stage, 5% dextrose was added. So normal saline, 5% dex, and 20 was the maintenance and deficit fluids. The ketones there stayed around 5. So this was 6 hours in. So the insulin rate was put up to 0.1 units per kilo per hour because there was ongoing severe DKA. And then a few hours later, you can see that everything started to gradually improve, and the pH gradually improved, and the ketones by 6:30 in the evening had fallen below 1. So that's a sign that you're winning. And we just expect a gradual correction, really, and it's often that the pH can be quite stubborn to improve for the first few hours. So by 10:30 that night, the glucose had actually fallen down to 6, the ketones were below 1, and the pH was gradually improving. Because the glucose was falling, the fluids were changed to normal saline and 10% dextrose, again with 20 millimoles of potassium in a 500 ml bag. And by midnight, really you had seen the pH corrected over 7.3, the bicarb was over 15, the glucose was 10, and the ketones were below 1. So that's your DKA resolved. So there would be an option there to reduce the insulin to 0.05 units per kilo per hour and continue everything overnight until they're eating the next morning, or you could just start background insulin, and that's probably what I would recommend. The less time the child is on IV insulin, the less risk of severe hypokalemia. So you can give their basal insulin if they're not going to eat, so Levemir or Lantus or Tresiba could be started, and then 1 hour after that you can stop the insulin infusion, and usually it stop the fluids at the same time. So just some tips if your acidosis isn't correcting, like in this case, are the ketones clearing? Do you need more insulin? Review the fluid status. Is the child in shock? Do they need more fluids? Did you make a mistake calculating the fluids? Is there sepsis? Very rarely this would co-occur with DKA, but think about it if the child has a fever. High white cell count is common in DKA and doesn't necessarily mean sepsis. Another thing we commonly see with the previous protocol was high chlorides, but this will correct spontaneously. Some places will change to plasmolite, but you do need to add potassium then. Rarely salicylate or recreational drugs are causing an ongoing acidosis. It's useful to look at the anion gap, which is usually between 20 and 30 in DKA, but if it was higher, consider sepsis. What's their perfusion, what's their lactate? So cerebral edema is very, very important, and that will be our main fear in a child with DKA. It typically will occur in the first 12 hours of treatment, but sometimes it can happen before treatment starts, and very rarely it can happen 24 to 48 hours after treatment starts. So the early signs are very non-specific. Maybe the child's got a sore head, they're irritable. It's very important a doctor sees that child urgently to assess them. If there's any neurological changes, then you have to suspect a cerebral edema. So in studies have shown that, like, a lot of the times it's reduced to GCS in 40%. Cranial nerve palsies would be diagnostic of it really. 35% of children with cerebral edema have those. Abnormal posturing, response to pain, so decorticate or decerebrate posturing, again, would be cerebral edema unless proven otherwise really. And Cushing's triad can also occur in about 40%. So the heart rate falling, the blood pressure rising, and abnormal respirations. Certainly if there's respiratory pauses or arrests, that's a very late sign, and those children do very poorly. So if you have any of these physical signs, you should treat it as cerebral edema. So how to do that? While you are reviewing the child, just check a blood glucose in case it's a low glucose causing a reduced GCS. Elevate the head of the bed, get senior help, restrict the fluids to half of what they're currently on, but it's important their blood pressure is maintained for cerebral perfusion. And then give whichever is easiest to hand, either mannitol or hypertonic saline. It doesn't matter which. The dose is handily enough the same for both of them, so 2.5 to 5 mils per kilo over 10 to 15 minutes, and that's 20% mannitol, or hypertonic saline 2.7 or 3%, just whatever you have. Once that's done, then it's important to discuss with PICU how is the child doing. Hopefully they've responded and improved. Neuroimaging can be useful when they're stable, but is not a priority in the acute situation. You're really doing it not to confirm cerebral edema, but to look and see has there been a bleed, an infarct, or an embolism, or something like that. For your differentials, document everything carefully, including the times. Mannitol can be given again half an hour later, or if you give mannitol the first time, you can give hypertonic saline the second time. And this is also covered in the care pathway, and it goes through exactly what to do and how to document it, and it covers everything. So it's excellent, the care pathway. So hopefully that hasn't happened and the DKA has now resolved. Like I said, the pH is better, 7.3 or above, bicarb over 15, ketones less than 1, and glucose below 14. That child should then be started on subcut insulin. Usually we'll stop the IV insulin half an hour after rapid-acting insulin, or 1 hour after a pump or long-acting insulin. And typically we'll stop the IV fluids at that point because the child is able to eat and drink. And it's very important that they're educated on DKA prevention and what to do in a sick day. So the sick day rules that we use here are standard. If the child's unwell, if they're known diabetic that's unwell, they should never stop their insulin. Even if they're eating less, just reduce the insulin, but never stop it. Parents are advised to test their sugar frequently, every 2 to 3 hours. And if they have glucose over 14 twice in a row, they should check ketones, or 1 high glucose and they're sick, vomiting, then check the ketones. Most of our parents are checking capillary ketones, so anything over 0.6 is positive, or urine 1+ or more for the purposes of what to do at home. So the first sick day dose is 10% of their total daily dose of insulin. Generally, children with poor control will have that drummed into them at clinic. What's their 10% dose? If 2 hours later they still have ketones positive, you repeat a rescue dose with 20% of rapid-acting insulin. And then if they're still positive 2 hours later, you're going to give them another stat dose of 20% of their rapid-acting insulin. If they needed 3 sick day doses, they should really go to hospital. But if any stage, if their parents are worried the child's very sleepy, they're continually vomiting, they need to go to hospital to be assessed. Often the parents will phone the ward for advice as well. For children on a pump, because there's no basal insulin, they can get into DKA relatively quickly. So they're asked to test ketones if their sugar is over 14. And if it's positive, you have to assume the pump isn't working. So you will give a correction by a pen. Also change the whole infusion set of the pump and troubleshoot the pump, which is a little self-test by pressing a few buttons. They get an injection of rapid-acting insulin. If the ketones are just 0.6 to 1.5, then it's 10% of their total daily dose. But if they're over 1.5, it's 20%. And those children can also increase their basal insulin by 150% or to 200% to try and clear the ketones quicker. So finally, just to summarise then, the take-home messages, do think of DKA in the unwell child. The presentation is not always classical. There are a lot of things that DKA can mimic, and occasionally something else can look like DKA that isn't. DKA can kill, so always think of cerebral edema if there is a deterioration. If you're asked to review a sick child with DKA, the nurses said the child complains of a headache, they dropped their GCS, there's any concern like that, they have to be seen immediately. It's really important to double check all your fluid calculations because they're complicated, but if you use the fluid calculator and the DKA care pathway on the BSP ED website, that will keep you right. Don't stop the IV insulin until subcutaneous insulin has been given. Ask for help at any stage. And it's very important there's education on DKA prevention for all children, particularly those with poor glycemic control. And hopefully raising awareness of type 1 diabetes symptoms and the 4 Ts in the general public will mean less children come to hospital in DKA in the first place. So thanks very much for listening, and I'm happy to take any questions.
Welcome back. You'll see we've been joined by Dr. Emmeline Heffernan. As Chris said, she's one of our paediatric endocrinologists in the Royal Belfast Hospital for Sick Children. Thanks for the talk, Emmeline. Really enjoyed it.
Thank you.
And it's something I suppose DKA a lot of us will encounter here involved. General paediatrics will encounter on a fairly regular basis. So, but nonetheless, always good to recap and to look. And things have changed recently with the guidelines. Mm-hmm. Just before we come to your questions, we did say we'd field some questions from Tom Waterfield's talk on the recognition of the sick child. There was a few questions came through, mostly to do with CRP, and one in particular was, can we use the CRP to help us differentiate between serious infection and those requiring admission to antibiotics? And is there a cutoff that you have in mind? I know Tom's not here. He's actually written a paper on that exact topic, which can be found in Archives, Disease in Childhood, Education and Practice. It's one of the interpretation articles. It's called How to Use CRP. And it's written by Tom Waterfield and Emma Dyer, D-Y-E-R. So rather than trying to steal his thunder, he's actually addressed that himself. I'll refer you to that paper. So it's worth a read and very useful. So coming on to Emmeline's questions then, so the question about phosphate in DKAs, obviously we tend to find that it falls, and there's that dilemma of whether or not you replace it or not. I'm keen to get your thoughts just on that particular topic.
Yeah, that tends to come up more in the very sick child who's in PICU with a low phosphate secondary to the DKA. In general, the guidelines say not to treat it unless it's very low, so less than like 0.3. And they're symptomatic. So mostly they won't have symptoms of low phosphate because it's an acute rather than a chronic issue. But in some cases, like if acute low phosphate might cause a metabolic encephalopathy or something like that, but that would be very difficult to differentiate from cerebral edema actually. So it's advised not to treat it unless you're convinced there's symptoms secondary to the low phosphate, because if you replace the phosphate, they may drop their calcium next. But if you were going to give it, you can give it with potassium phosphate together rather than potassium chloride, which will help avoid a hyperchloremic acidosis as part of your treatment.
Good. Thanks, Emmeline. And I suppose the most contentious issue at the minute in the management of DKA are the new BSPED guidelines, which come out in the last year or so. And I suppose the change is that we find we're given a lot more fluid using the guidelines. So just keen to, if you wouldn't mind giving us a bit of information as to why that came about, and then we have a chat with the other panel members, just because I know there's been a little bit of disagreement about whether people agree it's the right thing to do in terms of adopting and changing our practice in accordance with those. So.
Yeah, you're right. So these were interim guidelines. So they were an update from the previous, I think it was 2018 guidelines, because the experience was around the UK that sometimes the previous guidelines were taking a very, very long time to correct the DKA. So severe DKA could go into 2 or 3 days of treatment. And the children were having high sodiums and high chlorides. Now the high chloride is not an issue, and you wouldn't worry too much if the acidosis is ongoing because of the high chloride. But in some cases, the high sodium was problematic. So there was at the kind of an interim guideline then brought together by the BSPD guidelines to give more fluid to try and avoid this hypernatremia and to get the correction a little bit quicker. So the difference here is that there is more fluid. Everybody gets a 10 per kilo bolus, and there's more resus fluid. Plus your maintenance fluids are significantly higher than they were before. And that's especially relevant maybe in the older children that are a bigger weight. So there is a big change in the amount of fluid. Having looked at the guidelines over like the last 10 or 12 years, this does kind of come and go in cycles as to the maximum dehydration. It used to be 7% and now it's 10% and things like that. So these things just do come and go in cycles. So far, we've been using this in our centre since February, and we've had no issues with this guideline and being higher risk of cerebral edema or anything, despite their more fluid been given. However, it is still early days, and there are going to be updated guidelines again next year with NICE, and then the BSPD will review these guidelines again. So here we haven't had any issues with these new guidelines, and we're finding they do correct the DKA much quicker than the old ones without the high sodiums.
Yeah, and I think there's been some concern just raised about the, I suppose, the volume of fluid. I know Vicky Curry has mentioned that in the chat as well. Peter, when we were talking before and coming live, you'd sort of expressed some concerns about the volume of fluid. So
yeah, so I don't use these guidelines at all, and I did use the previous BSPED guidelines because I thought they were safe and they were good. From a paediatric intensive care perspective, we're worried about the sickest children that we get, which tend to be children with risk of cerebral edema. And I have huge concerns that these new interim guidelines, they've come out basically pending NICE guidelines, which are only coming out, well, they were supposed to, I think, initially come out this year. They're coming out next year. So we're using interim guidelines for a very short space of time that give a considerably greater volume of fluid to patients who are particularly at risk. So from an intensive care point of view, I'm really not happy to use these guidelines. And I know that as a UK PICU community, that those concerns have been raised and shared internationally in a number of leading journals recently. So I have huge concerns, and I'm certainly not happy to go with that. I would much rather have a child who's got a high sodium that I can manage and takes a little bit of time to manage versus somebody who's got cerebral edema because we've followed new guidelines. I also have issues that these guidelines have been based on papers and studies that have looked at relatively well DKAs who weren't that sick, weren't that acidemic, and had normal GCSs. So I think if we use that as a way to manage patients who are sicker than that, I think we'll get a false economy there, and I have huge concerns. So I personally wouldn't be happy to go with that just now.
Yeah, I think it's very difficult because there just isn't a lot of evidence out there as to managing, there's not really the randomized controlled trials in severe DK and cerebral edema, so it's very difficult to know. But it is useful. The National Paediatric Diabetes Audit was interesting, looking at the last audit of the use of mannitol and hypertonic saline for cerebral edema. It was used in 12% of admissions with DK, which I was surprised by. So I think it would be really useful to look at that audit data going forward with the new guidelines and see, is there more treatment for cerebral edema needed with the increased amount of fluid? So I think there are good ways that we can audit what's happening with the new guidelines and see, and time will tell.
Yeah, but at the same time, 10 to 12% is pretty significant. And if we already know that, and if we already know that's our baseline number, and then we change to something that increases that risk, to me, that's madness. Actually, we've already got a risk of 10 to 12%. That's way too high. We should definitely not be changing our guideline to something that has the potential to increase that, and then we'll subsequently re-audit it and may have to backtrack. Actually, that figure's already significant.
Costas, I think you were going to chip in.
I agree with Pete, and to people listening in, I think the take-home message is that the single biggest killer on any audit and any research in relation to DKAs in children is that biggest cause of mortality is cerebral edema. Top loading them with fluid is the wrong thing to do. It takes a lot for an entire region to divert from national guidance, but Wales have stuck to their own guns and have their old BSPED guidance still in place because they think the current one is harmful. Certainly in the Northwest and North Wales region, which I cover with newts, we still use the old one, and that's what we advocate for. And if people want to educate themselves more, there's a letter from the Evelina group in the archives from 2 months ago, and then responded by Robert Tasker, who's the leading editor of Pediatric Critical Care Medicine, highlighting the exact same issue. So don't follow the guidelines blindly, use your own brain, educate yourselves about it, and make your own decisions. But too much fluid, as a general, is probably detrimental to your patient.
Yeah, I think, yes, you have to only give the boluses if there's true shock there, absolutely, and just be cautious, yeah.
I think it gives a little bit of leeway. I felt the old guidelines really clamped your hands down and you couldn't give a fluid bolus, or it was very difficult to. And I think that there was kids who suffered from hypovolemia because people were so terrified of this link between rapid fluid correction and cerebral edema. So I think it gives you a little bit of leeway. I do agree with you. I have some concerns, particularly with that 20 ml per kilo bolus that you just give blindly at the start. And I think I would probably have somewhere a halfway house. I think there has to be a little clinical decision for these cases.
I think the other nice thing that the guidelines maybe untie your hands with is the use of having to stick with normal saline. It's nice to be able to give plasmolytes as an option, and certainly if it wasn't indeed, the DKA guideline before was very restrictive in sticking to normal saline. So I think having that option is maybe one of the good things with the new guideline.
And I think we could probably debate this for hours, but yeah, no. Listen, thanks again, Emmeline, for your talk. Really interesting and very clear presentation of how to approach DKA. I'm going to hand back Chris now to introduce our next speaker.
Okay, thanks, Ben. So our next speaker is Dr. Paul Moriarty, and he's one of our infectious disease consultants in Belfast, and he's going to talk about pediatric infectious disease pearls, tips. You're doing avoiding the common mistakes, but also tips from an expert as well.
So my name is Paul Moriarty. I'm a paediatric infectious diseases consultant in the Children's Hospital. And Chris has asked me to give a talk about pediatric infectious diseases pearls and avoiding the common mistakes, which was a nice title. And then he gave me a slightly longer brief. He said he was keen to hear about antimicrobial prescribing, who we should treat for hospital-acquired infections, do children between 1 and 3 months really need amoxicillin to cover for listeria, can we stop using Pen V for group A strep tonsillitis, and maybe we should just move to Tazocin for everybody like the adults have. As an aside, I'm not going to mention SARS-CoV-2, coronavirus or COVID. There's plenty about that out there already. So briefly to answer Chris's questions, who we should treat for hospital-acquired infections. Well, the definition of a hospital-acquired infection is an infection that arises in a patient more than 48 hours after they are admitted to hospital or within 48 hours of discharge. And then healthcare associated infections, which is probably a more applicable term to paediatrics, are infections that develop in association with healthcare or as a direct result of healthcare interventions. In paediatrics, who we should treat for hospital-acquired infections probably depends on the individual circumstances. So a child readmitted with a febrile upper respiratory tract infection soon after discharge for some other reason clearly doesn't have a hospital-acquired infection in the classical definition, whereas a line infection developing in a Broviac line on a patient on home TPN certainly has an infection which is likely to involve more atypical organisms and require broader cover than what we would usually give as empiric treatment for sepsis. The next question, do children over 1 month but under 3 months really need amoxicillin to cover listeria infection? And the answer to that question is probably not, and there's plenty of data to bear that out. It is, however, recommended in our NICE guidelines, and amoxicillin does serve a useful purpose in that urinary tract infection is the commonest invasive bacterial infection in this age group, and enterococci are not constitutively sensitive to cephalosporins. So amoxicillin serves the purpose of covering enterococcal UTI, although that's not the reason for its placement as empiric treatment in this group. Can we stop treating tonsillitis with penicillin V? In most cases, yes. In most cases, it's a viral illness. And the aim of treatment with penicillin V is mainly to avoid complications such as rheumatic fever and other post-streptococcal complications. Penicillin V to treat sore throat gives you a time benefit of 12 to 18 hours in total in terms of resolution of symptoms, and the number needed to treat to benefit one patient is somewhere between 6 and 20. The number needed to harm is about 15. So not a great benefit from antibiotics. The fever pain criteria, you will know, they're validated in children down to 3 years of age, and they're useful for making a decision about whether or not to use antibiotics. And many people ask about the penicillin V courses, which are long, multiple daily dosing, and not a very pleasant antibiotic to take. And the bottom line is amoxicillin is probably as effective, but slightly broader spectrum. And should we use tazocin just like the adults? Well, the answer to that is no. The range of our antibiotic sensitivities in the bacteria that we see are covered by third generation cephalosporins, and we've seen that in Northern Ireland E. coli resistance to tazocin since use of tazocin as first-line empiric treatment for sepsis was introduced has doubled. So I'm going to talk about fever in the return traveller. We are frequently asked questions about this, and I suppose I'll try to go through a couple of cases to illustrate the important points. The most important question is probably, where were you and what were you doing there? Whether you were visiting friends or relatives, VFR travellers are more often children, so more applicable to us. How long were you away and when did you get back? Which countries were visited and where did you stay, or what type of accommodation did you stay in? Whether there were travel vaccines prior to travel or malaria prophylaxis taken when going to malaria endemic areas. Whether a person used mosquito nets, what other activities they got up to while they were there. So whether that's holiday or visiting family. And then what medical history the child has. So, and that speaks to the bottom line, which is that common things are common. So this may not be anything to do with a tropical or unusual infection, but a complication of an already established medical problem. So to go through a case, and just as an aside, in case people recognise features of these cases, none of the cases are exact case reports of people that we've seen, usually an amalgamation of 2 or 3 cases in order to illustrate different points. So the first case is a 12-year-old visiting Northern Ireland from Uganda who presented to the emergency department with high fevers several times daily, occurring with rigors. She complained of a sore throat, a headache. She had slight thrombocytopenia and lymphopenia. CRP was up. LFTs and UNE were normal. And the doctors and ED were concerned about possibility of malaria, so they sent thick and thin blood films to the laboratory and a malaria rapid diagnostic test. And the rapid diagnostic test was positive, and the thick and thin films showed what looked like to the lab technician malaria parasites within the red blood cells. So the only other history, she's a healthy young girl, but she was treated for malaria 3 months ago. So appropriately, the team opened the UK malaria guidelines from 2016, which gives really good, clear, evidence-based and rational advice for managing malaria in a UK setting. Very important to know what the features of complicated malaria are. Clearly, evidence of cerebral malaria such as obtundation or seizures, acidosis, hypoglycemia, severe anemia, and from the lab, a parasitemia of greater than 2% indicates severe or complicated malaria. So, what investigations should you do? You should always do a blood culture in the returned traveller, along with your usual investigations for sepsis, blood count, inflammatory markers, U&E, liver function test. Beware of rapid diagnostic tests. There are a number out there, but many will stay persistently positive after treatment for falciparum malaria for up to 3 months. So in this child's case, this malaria rapid diagnostic test may represent a false positive. You need to send blood films by 3 to the laboratory, and you haven't excluded malaria until you have 3 negative blood films. A thick film examines the percentage of parasitemia within the blood, and a thin film, where the cells are more clearly visible, allows species identification. Both depend on the experience of the lab, and again, we don't see a huge amount of malaria. We have an excellent bacteriology laboratory attached to our hospital, but we don't see a huge amount of malaria, and so we should bear that caveat in mind. And of course, you should take any other investigations that the history or examination suggests. Briefly from the UK guidelines, the recommended treatment now are artemisinin and combination therapy drugs, and Riomet is the one that we most often use. It's usually available from our pharmacy. If not immediately available, it can be moved from another part of the city, as we've had to do on 1 or 2 occasions. And the treatment of choice for complicated malaria is IV artesunate, and these artemisinin-based drugs outperform the traditional treatment, the chloroquine-based treatments, in terms of treatment efficacy. Anybody with malaria who's presenting with suspected malaria and fever should be covered with broad-spectrum antibiotics such as ceftriaxone, plus or minus doxycycline to cover for tick-borne fevers or rickettsial illnesses. And remember the FEAST trial. So we like fluid boluses, and they probably are appropriate in our setting in most cases, but the FEAST trial showed very clearly that large fluid boluses were associated with an increased mortality in children with sepsis in a malaria endemic region. So she was given Riomet, and she was given IV ceftriaxone. And her fevers persisted and then settled after a couple of days. And the blood films showed Plasmodium ovale, so not falciparum malaria, but the much less pathogenic Plasmodium ovale. And then a culture result came back from a throat swab that somebody had undertaken because of her history of sore throat. And that showed gram-positive cocci in chains, which you all know is group A strep. So the point here is common things are common. She was treated for malaria. She probably has a persistent or continuous parasitemia related to long-standing Plasmodium ovale infection, and all along the cause of her fever and her illness was group A strep. So briefly, malaria accounts for about 20% of travellers presenting with fever returning from Africa. We see somewhere between 1,300 and 1,800 cases in the UK annually, and children account for about 10% of those cases, usually children who are visiting friends and relatives. 10 to 15 people die from malaria every year, and Plasmodium ovale often is carried asymptomatically in endemic areas. It rarely causes severe disease, and crucially it causes, when people are unwell with ovale parasitemia, they tend to have a tertian fever, in other words a fever that goes up and down every 48 to 72 hours. And ovale and vivax malaria have a dormant stage which requires what they call radical cure or treatment with primaquine after treatment for the illness itself. And remember always to check G6PD assay prior to giving primaquine because it can cause hemolysis in patients with G6PD deficiency. Some important resources, if you're stuck in an emergency department with a febrile sick patient, the UK imported fever service is an invaluable resource. And then there's the CDC and the ECDC databases and the ProMed databases for looking for where there are current outbreaks of particular infectious diseases such as viral hemorrhagic fevers, etc. So, where were you and what were you doing there? Most adults who travel for work or holiday. Half of visiting friends and relatives travellers are children. How long were you away and when did you return? Well, TB risk increases with travel to an endemic area for over 1 month, and usually people with tuberculosis won't present within a week of returning home, although children do develop primary TB at a much higher rate than adults, and so will present earlier. Incubation periods are important. So if you've returned from a dengue endemic area and it is more than 7 days since your arrival, you're unlikely to be suffering from dengue fever. Obviously, what countries did you visit? Is there an outbreak of viral hemorrhagic fever or other? Again, the ProMed website is excellent for that. Where did you stay? Whether there were travel vaccinations or malaria prophylaxis taken. So visiting friends and relatives, travellers tend not to either take malaria prophylaxis or take travel vaccines because they're going home, and so it's not normalised usually to take those precautions. Whether there's use of mosquito nets, what did you do when you were there, and that history should be age appropriate. We see older teenagers now, and may see and you may see older adults in other settings, and a history including sexual history from adults is important in returning travellers. What medical history do they have? We've mentioned, and what sick contents. But remember that common things are common, and they're as likely as not to be the cause of a fever in a return traveller. Okay, so the next case was a little girl that we treated this summer gone by, who presented to the emergency department with acute redness and swelling of the right side of her face, extending to the upper part of the pinna of the ear, which was also swollen. She had had a febrile flu-like illness just preceding this, which had now settled. She was fine, happy, playing, and the lesion itself was painless. There was no history of an injury or bite, and she was fully immunised. And there was no, you can't see it in the picture there, but there was no evidence really of periorbital involvement with the redness. So what treatment should we give in this situation? Treatment for cellulitis in children. Cellulitis is almost invariably caused by methicillin-sensitive Staph aureus. We have a very low prevalence of community-acquired MRSA infection in children in Northern Ireland. But you should ask about risk factors if you want to treat for cellulitis. So travel to a country where, travel or treatment, medical treatment in a country where MRSA is common. So the southern United States in particular, parts of Eastern Europe, etc. A family history of MRSA colonisation or a personal history of MRSA colonisation are important, and obviously complex medical history places you at increased risk of MRSA infection. So our little girl didn't have any of those things. So I'm going to plug our new version of the microguide now. So the Royal Hospitals or Belfast Trust microguide has just got a new version of the paediatric microguide or antibiotic guidelines, and we've added several different chapters, several new chapters to that. So I'd encourage everybody to download and use it. It's simple and easy to use. And when you look this up, you see that the treatment for cellulitis in children is flucloxacillin, not flucloxacillin and penicillin V, as I was taught in university, and not coamoxiclav. And so that's what she was given, and no change occurred. She was still happy, well, with a lesion on her face. And so when she represented, it was felt that this might be a facial cellulitis with possible involvement of the eye, and NICE guidelines and microguide say in that situation that you can use coamoxiclav to add anaerobic and gram-negative cover. And things slowly improved towards the end of the coamoxiclav. Not sure whether it's made a difference or not. She remained well. And then a week later she represented with a facial palsy. And now the diagnosis should be clear if it wasn't clear from the original picture. But if you re-examine that picture, there is the impression of a central clearing to that rash just in front of her hairline. And if you imagine a bullseye lesion, you might imagine under her hairline the other half of that circle. So the history was re-examined, and it turns out our patient was on holidays in the west of Ireland a month earlier with her cousins. They'd been glamping and had a great time. They'd spent a lot of time outside running around. There was no history of a facial injury. There was no history of a tick bite, and there was no history of mosquito bites or any other, or flea bites or anything else. But one of her cousins had had a tick bite without any immediate apparent consequences. And so what should we do next? Should we test her for Lyme disease? Should we test her for any other illnesses? Or should we just get on and treat her? Lyme disease is caused by the spirochete Borrelia burgdorferi and is a tick-borne illness. Not all ticks carry Lyme disease, even in endemic areas. If you do have a tick bite, the symptoms of Lyme disease in the early part are usually fever, flu-like illness, and the classical bullseye lesion. Sometimes you'll see more than one. Important to remember that children, the ticks tend to reside on the end of long grass, and so for an adult the bullseye lesions will often occur below the hips, whereas in children above the hips and often around the face and hairline. The next phase of the illness involves the central nervous system and can often cause facial palsy. It can cause heart block, and some people can present with neuroborreliosis characterized by meningism, sometimes polyradiculopathy, and sometimes encephalopathy. And then the late stages of Lyme disease involve further CNS effects and encephalopathy, or Lyme arthritis, or acrodermatitis atropicans, which can be seen in the top and is not commonly seen. How do you diagnose Lyme disease? Well, if you've got a clinical suspicion, a typical lesion, and travel to somewhere where Lyme disease is common or endemic, then you should treat the patient for Lyme disease without a test. And that is NICE guideline driven. If you do want to do a test, there's a two-step algorithm. You can send a sample to our lab, and we will do an ELISA here, which will screen for Lyme disease. And if the screening test is positive, then this is followed by immunoblotting at the National Reference Laboratory. You can sample other sites such as CSF or joint aspirate if necessary. In children, neuro-Lyme complicates about 10% of Lyme cases, and so it's something to think about. But beware in children that the classical bullseye rash might be concealed by hair, and also that antibodies persist for some time. So those living in endemic areas such as the New Forest in the south of England, or in parts of Central Europe or Scandinavia may well have antibodies from previous infection. Treatment is amoxicillin, 30 milligrams per kilogram 3 times a day for 3 weeks. Alternates are azithromycin or ceftriaxone for CNS Lyme. But Lyme disease affecting the cranial nerves, particularly facial nerve palsy, can be treated with oral amoxicillin. And that's what our patient was given. And at last clinic check, things had improved considerably and her facial palsy had almost resolved. Just to be aware of a few controversies surrounding Lyme disease. So chronic Lyme disease is a phenomenon that our chronic Lyme disease, as we've seen, is well described, and post-Lyme fatigue and post-Lyme pain syndromes are well described too. But outside of that, there's a broad industry surrounding the idea of chronic Lyme disease, which includes laboratories specifically set up to test for Lyme disease and other co-infection. They involve prolonged and often expensive treatments, sometimes people in this country being recommended to go to the eastern United States for additional treatments. And the important thing is that even in those with persistent symptoms, and we should counsel our patients when we've diagnosed them with Lyme disease that symptoms and fatigue may persist, there is no evidence for more prolonged courses than the 4 weeks ceftriaxone recommended for CNS Lyme, and no evidence for repeated courses of ceftriaxone either. Okay, so the last thing I want to talk about is vaccine adverse events. Again, these are questions that we get asked all the time, and it's a common reason for referral to our clinic. So I'm going to take to a history. An 8-week-old boy brought in by ambulance from the GP surgery. He had his first set of immunisations today. And about 40 minutes after his immunisations, his parents were still near the GP surgery. They came back in because he'd become very floppy, pale, unresponsive, blue around the lips, and the GP rightly assumed that he was having some sort of vaccine reaction and called an ambulance. In the emergency department 15 minutes later, there was a good deal of distress on Mum's part. She has no English and was unable to give a clear history, but from the ambulance staff, we've been told that he had become very suddenly floppy and pale soon after his vaccinations. He still was floppy, still pale, and he had an audible stridor. So what treatment should we give in this situation? Well, he was in an emergency department. He'd had a sudden collapse, having been given a drug, and so he was given IM adrenaline, as well as an antihistamine and some steroids. He recovered relatively quickly, within a few minutes, but was admitted to the short stay unit for observation. It was noted at that stage that his stridor was ongoing, even though he had recovered well and was quite alert and happy. And once we had time to review the electronic care record and to have discuss things with Mum through a translator, it emerged that he'd had fairly significant laryngomalacia, and actually stridor was a fairly frequent occurrence for this little boy post-feeds or when he was distressed. So he was referred to our clinic, and the questions were, should he have further vaccinations? Was this an anaphylactic reaction to his first set of vaccinations? And which ones should he or shouldn't he have? So we're often asked the question, should we separate vaccines, for example? So first of all, how common is anaphylaxis after primary immunisation? So in total, the incidence UK and in Canada and in the USA, it looks like the incidence is about 1 per million vaccine doses given. So not at all common is the answer. So what was this if it wasn't anaphylaxis? So this was a common vaccine reaction that is, in my experience, under-recognized. So hypotonic, hyporesponsive episodes occur classically after the first set of vaccinations, and they seem to be associated with the pertussis component of that vaccination. And they're characterized by what we saw in our young patient: sudden episode of floppiness occurring between 1 and 48 hours, or between half an hour afterwards and 48 hours after the vaccine, but often within 3 to 4 hours of receiving the vaccine. They go floppy, they go really, really pale and unresponsive, but they continue to breathe, albeit sometimes with quite shallow breathing. There's sometimes peripheral cyanosis or cyanosis around the lips, and they tend to resolve spontaneously. They are not seizures, they are not associated with any long-term adverse effects. And as I said, they're attributable to the acellular pertussis component of the vaccine. Will it happen again? So there's a really good study from Paediatrics from 2017, which is a meta-analysis of vaccine studies and provides really practical information for paediatricians trying to answer that question for parents. So the reference is there on the slide. It's from Paediatrics in 2017. The recurrence rate of HHE is less than 1%. And the recurrence rate for anaphylaxis in patients checked with skin prick testing first and then vaccinated was 0 from 130 patients in 3 studies. So what happened next? While we were convinced of the diagnosis, we immunised him in hospital for his primary immunisations, and he had surgery for his significant laryngomalacia, and last time I saw him he was well and fully immunised. Another little girl, just to illustrate a common vaccine reaction, 3-year-old girl who with her preschool immunisations the day before, grumpy and febrile later that day with a low-grade fever. And the next day she presented to the emergency department with significant swelling of the upper part of her right leg from hip to knee, which was the side she received her diphtheria, pertussis and acellular, or diphtheria, tetanus and acellular pertussis booster. It was tender and she wasn't really willing to move that leg much. So what should we do here? In my experience with this type of thing, people are comfortable with the idea that this is likely to be a vaccine reaction, but not comfortable with the idea of not treating it for cellulitis. So we've been through cellulitis treatment already. How common is cellulitis after vaccination? I wasn't really able to find any good data, but there was a case report of a similar episode published which reviewed data over the previous 30 years, published in the early 2000s, and was not able to find any cases of cellulitis related to primary immunisation. I guess the other way to think of it is, even with dirty needles, how common do we see cellulitis after a needle stick injury to a child in a park or otherwise? And the answer to that is also very, very uncommonly. So using a sterile needle, it's not likely that a child has developed cellulitis within 24 hours of a vaccine. How common are large local reactions or extensive limb swelling? Local reactions occur in up to 1/3 of those children who have the preschool booster. In other words, their 4th dose of diphtheria, tetanus and acellular pertussis. And about 1% have more extensive limb swelling with some limitation of movement and pain. So it's a common reaction after that 4th vaccine. Less common, but not uncommon after the 3 primary immunisations at 2, 3 and 4 months. So will it recur? If you have a 5th dose, yes, it's likely to recur. So it will recur in 50 or 60% of those patients who had extensive limb swelling the first time. But this is the fourth and final dose of this particular preparation of diphtheria, tetanus and pertussis vaccine. We give a lower antigen content in the teenage vaccines that we use. In those infants who do have redness and swelling, there is, again, a high recurrence rate up to 50%. And even those who have very significant redness and swelling of over 5 centimetres, they have a recurrence rate of around 10%. So you can counsel the parents that this is harmless, it is not an infection, and it may well recur, but it will be harmless the next time also. And some helpful resources. So the Green Book, published by the PHE on the recommendations of the Joint Committee on Vaccination and Immunisation, is a fantastic resource. There's also the Vaccine Handbook app, which is US style, or which is based on the US vaccination program, but also provides lots and lots of good information around vaccine adverse events. And if you see someone who's had a vaccine complication, we're very happy to see them at our clinic. And my last slide is just a plug for antimicrobial stewardship. I've avoided it so far for the most part, but just to say that we would really encourage a collaborative approach between infection specialists and subspecialists such as emergency physicians. Over the past 5 years, we have shown that we can increase our use of narrow spectrum antibiotics in the emergency department to above the WHO recommendation of 60%. And I don't believe we have seen an increase in infection complications related to that. And that's me finished. Thanks for listening. And I'll take any questions that you have.
Okay, well, welcome back. Delighted to have Dr. Paul Moriarty with us now on the panel. Paul, thanks very much for that talk. Very useful, and good to go through those topics again. We have a few questions coming in. Just firstly around Lyme disease, it seemed to generate a few questions. So I guess the first one was, how soon after exposure do the symptoms tend to develop? And then as a kind of a secondary question to that, so if patients are presenting with unilateral or bilateral facial palsy, should we be routinely testing them for Lyme disease?
So thanks, Ben. The symptoms tend to, so the bullseye lesion or target lesion, or erythema migrans as it's known, tends to develop 1 to 3 weeks or up to a month after the tick bites. So and with children, like in that case, you can often come into a situation where no given history of a tick bite is available, but instead a child is arriving at the right time of year, having been in an area where there might conceivably be or are known to be ticks. So so the time scale, and often the bullseye lesion is preceded by a fairly mild flu-like illness, and again, sometimes even that escapes the notice of mum or dad before they've presented to the department. And so I always ask for a Lyme disease test if I'm asked about someone with facial palsy. I suppose the qualifier, or to make the predictive value of the test a little bit, a positive predictive value of the test a bit higher, certainly if it's summer or late summer, certainly if they've been anywhere where Lyme disease is known to be endemic or even common, certainly if they've had a tick bite, I certainly would consider it strongly in any child who develops with a facial palsy.
Thanks, Paul. And there was also a question then about whether there's a role for steroids in facial palsy or Lyme disease. I know it's maybe something that ENT would recommend for Bell's palsy type presentation. Is that anything specific for Lyme disease?
It's not specifically recommended in the treatment for Lyme disease. I guess steroids might be given because the differential diagnosis includes both Bell's palsy and Lyme disease in any given situation. but it's not specifically recommended for the treatment of Lyme disease.
Good. And then coming to the case of the HHE, there was a question there about, obviously they treated for anaphylaxis, the uncertainty probable of the initial diagnosis. Why did that kid seemingly respond to the treatment? Was that benefits of the treatment, or do you think that was just coincidental, and he got better, or he or she got better?
I think he got better. I think these episodes usually resolve within about an hour. So I think I deliberately put the timing the way it was, but I think it was around time for the baby to get better anyway, and so he did. But he arrived in the emergency department having collapsed with a stridor, looking very pale, having been recently given a vaccine. So the treatment was the right treatment as far as I'm concerned. The ED physicians can tell me if I'm wrong, but I would say that was the right thing to do. And often with vaccine adverse events, it is digging around in the history and taking detail and having the advantage of sort of a retrospective view that eventually gives you the diagnosis. I would say my experience of vaccine adverse events and doing specific adverse events clinics is that most children who present having had an adverse event, where there is a pre-existing willingness in general to have the child vaccinated, they will end up being vaccinated at some point.
Yeah. And Stephen Tudor, from an ED perspective, I assume that kid comes, you treat as anaphylaxis until proven otherwise, with retrospect.
If you come in with signs of a reaction, stridor, difficulty breathing, hypovolemic, then you're going to treat what is common and look for, as Paul said, you're going to then hunt through the history. So yeah, if you've got something that presents that looks like they're having a reaction, then you'll go down that line. The adrenaline, as Paul says, maybe didn't help with the situation, but it didn't do any harm in the situation either.
Yeah.
Agreed.
I agree with Tudor.
Grant. And I suppose time probably one more question. Just I thought it was interesting you were talking about the point of care tests and some variation in those, Paul, in terms of just being cautious with interpretation of results. You maybe mind sharing just a little bit more about the various ways in which they might work and how that might affect then positive results.
So this is for malaria rapid diagnosis?
Yes, malaria, sorry, yes, yeah, back to malaria.
So I am definitely not an expert on malaria rapid diagnostic tests, but and I suppose some of the information is simply dogmatic. There are a number of rapid diagnostic tests out there for malaria, some more specific than others. Generally, the less expensive ones have a lower specificity and will remain positive for a longer time after malaria treatment. So if you've got a positive rapid diagnostic test, some can remain positive for up to 3 months afterwards. And then some are vulnerable to false positivity and sepsis as well because of the type of assays they are. So some look at things like LDH, for example, and therefore are vulnerable to false positives. So they're not perfect tests. The gold standard for diagnosis of malaria are thick and thin blood films.
Perfect. Listen, thanks very much for your time, Paul, and for that talk again. We're probably going to have to, I think it's last break of the day before restarting at 4:10. Is that correct, Chris?
That's right, Ben. So we're going to again play a few of our advertisers' videos during the coffee break. So again, please take a little bit of time to look at the videos. Like I say, the reason we've done this for free today is because of them. And we'll be back at 4:10. Thanks.
Get ready. He's got good technique though, I have to say. Okay.
Uh-oh. It's good. Good.
With reusable scopes, setting up a bronchoscopy can involve a lot of waiting. Waiting for the respiratory therapist to call you back. Waiting for a time slot. Waiting till a bronchoscope is available. The Ambu A-Scope 4 Broncho is ready when you are. You simply grab the scope and monitor and are ready to go. With reusable scopes, contaminants can hide in the bends and channels even after high-level disinfection, bringing risks to your patients. With Ambu A-Scope 4 Broncho, you get a brand new, sterile bronchoscope straight from the pack every time. With the Ambu A-Scope 4 Broncho, you get more than just a bronchoscope. It's a fully integrated solution with 3 scopes, a tailor-made sampling solution, and a high-definition monitor to help you deliver the very best in patient care. Ambu A-Scope 4 Broncho. Guaranteed sterility, ready when you are.
Okay, welcome back everyone. Thanks for sticking with us throughout the day. I know it's a long day. We were actually planning to have finished 2 hours sooner, but we had really enthusiastic speakers and lots of great content, so it was really difficult to leave anything out. So we're moving on to our afternoon session with the final 3 talks of the day. So our first speaker is Dr. Brian McCrossan, and he's one of our consultant paediatric cardiologists in Belfast, and he's talking about paediatric arrhythmias.
Good afternoon, everyone. Welcome to your session on paediatric cardiac arrhythmias. My name is Brian McCrossan. I'm one of the paediatric cardiologists here in Belfast. Just an overview of paediatric arrhythmias. They can either be too fast or too slow. Within tachyarrhythmias, the easiest way to classify them is into narrow complex or broad complex, which for the most part corresponds to supraventricular tachycardia compared with a ventricular tachyarrhythmia. But we'll talk through some of the subtleties of that as well. When they're too slow, is there sinus node dysfunction, something again in the atria versus something at the AV node or below? This is really just for your reference. So types of supraventricular tachycardia, what we mean are any arrhythmia which is fast and originating at or above the AV node. And they can be automatic or they can be re-entry. When we say automatic, what we mean is that they are under the control of adrenaline and therefore they warm up and cool down, whereas re-entry tachycardias tend to turn on and turn off. So re-entry tachycardias can be within the atria, like atrial fibrillation or atrial flutter, or they can involve the AV node. And when we think of SVT, really what we usually mean is AVRT, atrioventricular re-entry tachycardia, which goes along with Wills-Parkinson-White syndrome, or atrioventricular nodal re-entry tachycardia. And that's more common in the second decade of life. AVRT would be by far and away the most common type of SVT in children under the age of 10. The least common of these is permanent junctional reciprocating tachycardia. I only put that in for reference. You're unlikely to come across it. And in the automatic tachycardias, sinus tachycardia is by far and away the most common, but it's also important to understand and to appreciate ectopic atrial tachycardia. So just to get straight down to some clinical cases, you're in the emergency department and a 5-month-old baby presents with a 48-hour history of pallor, shortness of breath, and poor feeding. And like everything in infants, it's all to do with the feeding, as being as being an important sign and symptom of things. So looking at the ECG, you can see that it's fast. It's going about 230 beats per minute. It's regular. For the whole, on the whole, it looks narrow complex. In V1, you get the impression of some intraventricular conduction delay, but on the whole, it looks narrow complex. And looking closely at it, it's difficult to see definite P waves as well. So you would think to yourself, well, it's over 220 beats per minute. That's a good rule of thumb that tachycardia over 220 beats per minute is much less likely to be sinus tachycardia. And the patient's symptomatic and it's narrow complex. This is likely to be atrioventricular re-entry tachycardia. And we'll come to the treatment of that a bit later. Whereas a 7-year-old boy comes along, he's been feeling dizzy, which he had one episode of that, and he still thought he would go to the emergency department. But you do his ECG, and you see this, and what you can see is that it's in sinus rhythm. There's a P wave before each QRS complex, P, 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 P. The rates, 1, 2, 3, 4, 5, maybe somewhere in the high 60s beats per minute, so a little bit on the low side, but it's okay. But what you do notice is that you have a short PR interval and sloping of the QRS complex. So this is barn door WPW. But has this caused his presyncope? Well, I think at the age of 7 or 8, you probably could give a reasonable history of palpitations if this was causing the presyncope, i.e. the presyncope in the setting of WPW should be caused by SVT. WPW by itself is not going to cause many symptoms. So it's not that this patient needs any immediate treatment. or brought in to hospital necessarily, and I'm sure an outpatient Holter monitor and referral to paediatric cardiology would be enough with some safety net advice. Whereas in this instance, we have a much more abnormal looking ECG, and the history itself, you know, an 8-week-old baby goes along to their GP for their vaccines check. For their vaccines. And when the GP checks has a listen to the heart, he feels that it's irregular and it's very fast. And indeed, he is right about that. So you can see that at its fastest, there's about 1 box between the 2 RR intervals. And you know, so you're talking about a rate of close to 300 at times, but it is irregular even when it's fast. You know, it's not just as fast here, and it slows down to considerable extent here, maybe 130, 140 beats per minute. But as I said, it's irregular, it's narrow complex though, and you can see some P waves going on here as well. So it is a tricky one to figure out exactly what's happening here. So what would help you make the diagnosis? Well, you know, you're on the narrow complex tachycardia end of things. Is it sinus tachycardia? Is it atrial fibrillation? Very uncommon. Atrial flutter, possibility. Is it atrioventricular reentry tachycardia? A bit less likely considering that it is irregular. So what could it be, and what would help you make the diagnosis? Well, you could give a dose of adenosine. You were sort of itching to do that anyway, probably. But adenosine in this case here is not going to be therapeutic, but it might be diagnostic. By blocking the AV node, you've uncovered the atrial activity. And what we can see here are 2 P waves for every QRS complex. So what we have is an ectopic atrial tachycardia, and you've induced 2-to-1 AV block by giving the adenosine. So the difference between this and atrial flutter would be atrial flutter would be more likely not to give you a gap here. It would be constant atrial activity, much more sawtooth. So this patient will go back into an ectopic atrial tachycardia after a few seconds, having given the adenosine, because the adenosine will not treat the ectopic atrial tachycardia. It will just block the AV node. Next case, you have a newborn baby who pitches up to the emergency department who's very sick. They're edematous, they're poorly perfused, and there's not much history to be had from the parents here. There was no antenatal care. And what you can see here is, again, irregularity in the heart rate, but at times it's very fast, 300 beats per minute, and it's narrow complex. So we're on the narrow complex part of the tachycardia algorithm, but you can see here constant sawtooth atrial activity. So this is atrial flutter with a variable AV block. The reason why these patients are often very sick at time of presentation, so it's an uncommon, but it's more common than you think in newborns, because this is the one time when it's likely to present. And actually the treatment at the newborn period is likely to be curative, but they can be very sick because this, you know, especially in the newborn period, this is likely to be going on for hours, if not days on end, antenatally. And because the placenta does all the work, or most of the work for the heart and the lungs, they cope with that okay. But then when they come out, they're not able to cope. And indeed, they may already have been the heart and cardiac function may already be, you know, relatively poor during fetal life. But the treatment for this is a DC cardioversion. Synchronized DC cardioversion is basically curative for this, and you would put them on. I like to put them on digoxin afterwards. This is just for your reference again, but I found this very useful in terms of differentiating the different types of SVT. So what is the treatment? So you've recognized the rhythm, you've looked at the patient, and the first question is, what is the rhythm? So you've no problems with that now. Second question, well, what antiarrhythmic do I give? That's not the second question. The second question is, how urgent is the treatment? Is there evidence of shock? Less than that, is there evidence of congestive heart failure? Has the patient got a few symptoms, or are they actually very well looking? How long have they been in SVT? The symptoms and the patient's condition will be determined by the duration of the SVT, how fast the heart rate is, and especially if there's any underlying congenital heart disease, or if they've got cardiac dysfunction as well. So the initial treatment is covered very well by the APLS guidelines, and so I've provided those there. So whether they're in shock, whether they've got congestive heart failure, whether there are no other symptoms and they're well looking, all of those eventualities are covered by the APLS guideline. Of note, in terms of vagal manoeuvres, in an infant, I would certainly try an ice pack to the face. It's worthwhile, actually, if you can go and see that being done by somebody who knows how to do it. Because if you just set the ice pack on the face, it'll do nothing. You actually really need to smother the patient, but obviously you can't be too enthusiastic about that. Otherwise, you might, A and B come before C, and you might cause more harm than you intended to. But actually, it's something once you've seen it being done, it's not difficult to do, and it can be as effective as adenosine. Other vagal manoeuvres, which I'm sure you're well aware of, would be popping your ears by covering over your nose and trying to blow out your ears. Doing a handstand is a less well-known one. Drinking something very cold or an ice lolly, or blowing through a brown paper bag, something, or through a straw, something like that. But you come to hospital for some medicine usually, and in most cases you're able to get IV, and if not, IO access pretty quickly, and you're going to give adenosine. Now, you try to get IV access as close to the heart as possible, and you put a 3-way tap on, and you give adenosine 100 micrograms per kilogram per dose, with attached up to a 3-way tap with a bolus of normal saline, and you follow the adenosine with the normal saline immediately, and should be on ECG monitoring all the way through that, and the ability to print out the ECG as well. That's really, really important. So if that doesn't work, give it a minute, and then give a higher dose of adenosine, 200 mics per kilogram, and if that doesn't work, up to 300 mics per kilogram. If that doesn't work, you should pause at this stage and just make sure, A, that you're giving it properly and that you've got a decent line in. But if you're happy that you are doing those things, then is it really SVT? Especially if there's some aberrancy, indeed, is this ventricular tachycardia that you're treating? Or maybe you need, the heart's quite refractory to it, and you need some baseline medication in there, such as beta blocker, digoxin, amiodarone. But at this stage, you should pause and think to yourself, well, I should contact pediatric cardiology for further advice. Whereas if you're on the shock side of the algorithm, then if you have IV access, or it's very, very quick to get that, or get IO access, yes, you can give adenosine, but you may be moving quite quickly down to a DC cardioversion, which obviously, very importantly, has to be synchronized. So the aim of treatment in SVT is to get back into normal sinus rhythm and to stay in normal sinus rhythm. If you can manage that, the patient will get better. And a little bugbear of mine is constant questions about what dose of adenosine should I give next. If adenosine has even very briefly reverted somebody from SVT back into sinus rhythm, but then they go back into SVT, you don't then increase the dose of adenosine. You can if you want, but it won't make any difference. It's a misconception to think that a higher dose of adenosine keeps you out of SVT longer than an otherwise effective dose of it, but lower dose of adenosine. Adenosine is not an antiarrhythmic in that sense. It blocks the AV node to try and reset the heart and get you and to block the pathway and to get you back into sinus rhythm. What do you do if the baby is shocked? Sorry, it is not shocked, but in congestive heart failure. And this is a relatively common one that you're likely in your career to come across. We say a baby because for the same reason we talked about atrial flutter presenting when they're sick. The first time that a baby presents with SVT is likely to be when they are at their sickest, because it won't have been recognized. Babies don't tell you that they've got palpitations, and they may well have been in it for hours and hours on end over periods of days or even weeks. And when they arrive, they may have an enlarged liver, be pale, and be short of breath and pretty oedematous. But that doesn't mean that they need a DC shock. But the adenosine by itself may not be enough to get them out of it, or it may get them out of it and then they go straight back in again. In that instance, I mean, an esmolol infusion is certainly a possibility. Being a beta blocker, and if you haven't seen the echocardiogram, you may be not completely sure about the cardiac contractility, and also esmolol does tend to make the blood pressure a little bit saggy. In its favour, it's very quick acting and therefore very safe. Once you turn it off, it's out of the system within a few minutes. Digoxin is not negatively inotropic and also doesn't tend to affect your blood pressure. But people have are not so used to using it, and the dose does need to be adjusted if there are other comorbidities such as renal dysfunction. And especially if you've already used amiodarone or you were thinking about amiodarone, you need to be careful using those two together. But I would sometimes think about an IV loading dose of digoxin for that reason, and then going back to the adenosine. Ultimately, it's never very wrong to use amiodarone as an IV loading dose. It doesn't necessarily commit you to months and months of amiodarone. And being the domestos of all antiarrhythmics, it's probably the most effective. But if you were sort of winning, getting stuck in with a loading dose of IV amiodarone without running that past anybody won't necessarily go down that well. And as I've indicated before, once you've given one of these antiarrhythmic treatments, the longer acting ones, you're more likely to be successful in cardioverting with adenosine. Doing 2 or 3 of these things can take several hours by the time you send ECGs backwards and forwards to cardiologists, and the patient might be starting to get a bit saggy and really need to get out of the SVT sooner rather than later. And certainly if amiodarone hasn't worked, then I would consider a DC cardioversion. Most times you have enough time and leisure to involve an anaesthetist and go to theatres, and indeed even the induction of anaesthesia usually gets patients out of refractory SVT, but you might need to do a synchronized DC cardioversion. In this instance, 0.5 joules per kilogram often works, but the guideline says 1 joule per kilogram. So keeping out of SVT, as I said, adenosine just gets you out of it. It doesn't keep you out of it. In most cases, a beta blocker is good first-line treatment. So in a baby, propranolol, in an older infant, after a few months, and certainly in a child, more likely to be atenolol. But if you need IV treatment in the short term, the beta blocker to use is IV esmolol. You can use metoprolol, but esmolol is so short-acting and comes pre-prepared. Or you could use digoxin or even amiodarone, but I would be doing that in consultation with a cardiologist. So moving on then to broad complex tachycardias. The ones that would spring to mind obviously would be ventricular fibrillation and ventricular tachycardia. These are very rare, certainly in early childhood. Ventricular tachycardia can be a bit more common in teenage years. But what's more likely actually is the patient has SVT with aberrancy. That's either they have Wolff-Parkinson-White and they have antidromic conduction, i.e. the Wolff-Parkinson-White pathway is being conducted down that and then back up through the AV node, or it's going so fast that the AV node has struggles to keep up and broadens out a little bit with the SVT. Or somebody who's known to have right bundle branch block and gets SVT will also have a broad complex tachy, or even sinus tachycardia in patients with right bundle branch block can be quite difficult to distinguish as well. So the history is very important here. As I said, ventricular tachycardia and fibrillation are very rare. So if you have a history of past cardiac surgery, that's obviously very important, both in the setting of having right bundle branch block, so therefore it may not be that big of an issue, but you are more at risk, especially patients who, for example, had repair of tetralogy fallow or truncus arteriosus. Those type of conditions are more at risk of ventricular tachycardia. Is there a history of Wolff-Parkinson-White syndrome? What medications are available in the house? And is there a family history of sudden death, cardiomyopathy, channelopathy, those type of things? So just keep it clinical again. You can see we have here a 13-year-old girl who's presented to the emergency department with palpitations. She feels very well. The palpitations last maybe 45 minutes at a time when they come, and she's not really she certainly hasn't been syncopal, very occasionally pre-syncopal, and this has been going on for several months. So what you can see is that you can see a broad complex tachycardia. the rate is approximately 150 beats per minute, and you don't see any P waves. It's monomorphic, and you can see it's got a left bundle branch block. So it's got a right bundle branch block pattern. So this is ventricular tachycardia coming from the left ventricle. It's probably left vesicular ventricular tachycardia, which on the whole tends to be quite a stable type of tachycardia. But in this case, it's not that you're going to send the girl home and tell her not to worry about it. But you don't necessarily need to get cracking with DC cardioversion. That would be crazy, and somebody sitting staring at you. But you're going to admit them, put them on a monitor, talk to paediatric cardiology. And if you're in a district general hospital and it's difficult to get hold of us, this is well within the realms of an adult cardiologist. In fact, they're more used to treating ventricular tachycardia than any paediatric cardiologist, with the exception of an electrophysiologist. Stop. But the likely treatment for this will be a beta blocker, and sometimes in the future an electrophysiology study. So in this instance here, this could be the same history, but the heart rate's a little bit faster, 160 beats per minute in this case, monomorphic. But in this instance, there is left bundle branch block. So this is right ventricular outflow tract tachycardia, and this tends to be a fairly benign type of ventricular tachycardia as well. Again, this is taken in the context of an otherwise well girl or boy who doesn't have congenital heart disease, and there's no strong family history of note. So you have to factor all those things in as well in terms of your initial assessment. These patients are all going to end up getting an echocardiogram, Holters, and I would again treat this with a beta blocker. You could treat this with a calcium channel antagonist as well. Whereas this ECG is obviously very different. And where you have here is very disorganized, very fast, broad, complex tachycardia, and this is ventricular fibrillation. And obviously this patient is not going to be walking off the street and telling you that they feel a little bit dizzy and have palpitations. This will be a cardiac arrest rhythm, and you'll just follow the APLS guideline. But ultimately, these patients are going to require shock. This is obviously an AED, but they need DC cardioversion. Just a couple of other ECGs to add a bit of interest. You can see here that there is broad complex, relatively tachycardia, but 150 beats per minute again. But there are two distinct QRS morphologies, 1, 2, 1, 2, 1, 2. So it's alternating. This is called bidirectional ventricular tachycardia. Now, it's not that you'd be blasé about this anyway, but this is specifically associated with CPVT, catecholaminergic paroxysmal ventricular tachycardia, and it is one of the leading causes of sudden cardiac death in young people, mostly in the second decade of life, but it can be even a little bit earlier than that, but mostly in the second decade of life, and one of the leading causes of sudden cardiac death with exercise. So this is if you saw this, you'd certainly be admitting the patient and talking to us, and you'd be very worried about the patient as well. And this will need immediate treatment. If the patient's sitting staring at you, you don't need to do an immediate DC cardioversion, obviously. So, sort of looking through the APLS guidelines, if somebody has a broad complex tachycardia, which you're not sure what it is permissible to try adenosine. Patients with ventricular tachycardia may well be looking at you not particularly symptomatic. So if they are, don't panic. But do contact us. You can send an email or text the ECG to a friendly paediatric cardiologist. You could try magnesium sulfate. That can make you a bit hypotensive, but it's generally a very safe antiarrhythmic for ventricular arrhythmias. If on the advice of the paediatric cardiologist they think this is a fairly benign type of ventricular tachycardia, then you could try a beta blocker. But if the patient is symptomatic and you're worried about them at all, and there isn't a very clear history of long QT syndrome, then loading with amiodarone may well be the appropriate thing to do. If you can't get them out of it and they're starting to get sick, then a synchronized DC cardioversion, which will likely require the help of a general anaesthesia may also be appropriate. Obviously, if it's unstable ventricular tachycardia or the ventricular fibrillation, then you strictly follow the APLS guideline on that, which is here for your benefit, and I won't go through that right now. So, too slow. So we've covered all the tachyarrhythmias at a gallop. On the slow side, tend to be a bit more relaxed about that, although it causes a lot of questions for a paediatric cardiologist. But slow heart rates, are less likely to make you symptomatic, and much less likely to be associated with sudden cardiac death. The majority are just sinus bradycardia, which is usually physiological. If you look at that table that I gave at the start, many patients fall below the recommended heart rate for their age, and therefore by definition they have sinus bradycardia. But that doesn't mean that they've got something wrong with them. So they may just be a very fit, healthy young person. Changes in vagal tone can induce sinus bradycardia as well. Now, I suppose you want to be sure to yourself that they don't have increased intracranial pressure, but there should be other signs of pathological things causing increased vagal tone. Does the patient have access to medications that they shouldn't have, such as digoxin, beta blockers would be more common, obviously, and antidepressants. And then is it actually sinus, i.e. is it coming from the sinus node, or is it coming from an ectopic atrial pacemaker? So if you look at lead 1 and lead 2, it may well be, lead AVF, it may well be downgoing and therefore coming lower down in the atria in the coronary sinus, and that would be the most common ectopic atrial pacemaker. But that's really basically physiological as well. Or is there sinoatrial node disease? So are there big pauses? Is there sick sinus syndrome? So tachycardia followed by bradycardia inappropriately. And those things do require ongoing monitoring and occasionally a pacemaker. I just put in sinoatrial node exit block, really for completeness. You won't see it. I've never seen it. For all of those things on the bradycardia side, which are coming from the atria, a really important thing is how many symptoms are there, how pervasive are the symptoms, and is there chronotropic competence? Then it could be coming from the AV node, and that is a more important source of pathology for causing bradycardia. If there's AV block, it can be first, second, third degree, which we all know about. First degree AV block is basically physiological, and they should have a normal heart rate. Second degree AV block has two types: Mobitz type 1, which is wanky back, that's drop beats, whereas the Mobitz type 2 is where there is a fixed relationship, like 2-to-1 AV block, 3-to-1 AV block, and so Mobitz type 2 along with complete heart block or third degree AV block are totally different from the others. This is high grade AV block, which is definitely pathological and is much more likely to require a pacemaker in the long term. What also adds into the mix in terms of how seriously you view these things, how much investigation they're going to get on the threshold for pacemaker insertion, is whether there's a history of congenital heart disease or previous cardiac surgery. So here we have a 3-year-old boy attends the emergency department having fractured his humerus. The nurse notes that his observations are relatively slow, especially considering that he should be in a fair amount of pain, but he denies any other symptoms. So what you can see here is the QRS complex is pretty regular. It's about 70 odd beats per minute. And there are P waves, but the PR interval, well, there's P here, P here, P here, P here, P here. When you measure out the P interval, it's constant, but the PR interval isn't. And there's obviously more than one P wave for every QRS complex, but it's not always the same number of P waves. So really, when the best way of doing this is to get a sheet of paper and mark on the P waves and then slide it across to make sure that works. And then doing your PR, doing the same thing for the PR interval. That's how I work out what type of heart block it is. And what you'll see here is that really there is no association between the P waves and the QRS complex. This is complete heart block. So what would we do now? Well, This does not by itself necessarily need any treatment if he's not having any symptoms. So we'll look at the European guidelines for paediatric permanent cardiac pacemaker in a minute. But you have a narrow QRS complex. You don't have any wide ectopic QRS beats, and the heart rate is in the 70s. So on the face of it, this wouldn't require a pacemaker, but would need a workup as to why this has happened. Was this congenital? Has he had evidence of myocarditis? Is there a family history of this? Has he got a structurally normal heart? What's the function of his heart like as well? So it's not that obviously this patient is not going to get followed up, but they don't necessarily need any immediate treatment. The only blind would be, how did he fracture his humerus? Was he syncopal and then he fell, or was he playing football or fell out of a tree after having swung on it? You know, so the history is important here. Whereas this ECG here, you can see again there's complete heart block. So P, 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 and the PR interval changes, and you know, there's no association between it and the QRS complex. The QRS complex is nice and narrow again. There don't seem to be any other QRS morphologies, but the rate here is a lot lower. The rate here, about 7 and a bit boxes between the RR interval, and so the rate here is in the low 40s. And this in a child would score you a pacemaker. Here we can see P dropped, P QRS, P QRS, P dropped, P QRS, P QRS, P dropped. But if you look at the PR interval here compared to here, it's shorter here than it is here. So this is quite clearly wanky back, which is Mobitz, second degree AV block, Mobitz type 1. And this is a relatively benign thing. In fact, most of us would have this during sleep. Having said that, again, you're going to investigate this to make sure there aren't higher grades of AV block going on at the same time. Completely different from Mobitz type 2, where you have here 1 P wave QRS, P, P, QRS. So two Ps per QRS, but it's much slower as well. And the QRS complex is pretty wide. This is pretty nasty stuff, actually. And in this case here, not only is this child going to get a pacemaker, but actually this child, in this instance here, requires you know, emergency temporary pacing, I would say, because the heart rate here is about 30 or so. Whereas in this instance here, you have P, P, QRS, P, P, QRS, P, P, QRS. So there's a 2-to-1 AV block, but the heart rate here is about you know, high 60s, 70, something like that. And this patient is much less likely to be symptomatic, but it's still high grade AV block. So you know, they may well end up with a pacemaker at some point down the line, but we'll just need further investigation and monitoring. So moving away from AV node disease to sinus node disease. So this is the Holter monitor of an 8-year-old girl who has severe learning difficulties, but she had a syncopal episode in the paddling pool. And so this occasioned quite a lot of Holter monitoring. And now she wasn't symptomatic when she had this, but there's a 4.8 second pause followed by a 3.5 second pause. And this girl ended up getting a pacemaker. And the reason for that was because of this symptom of syncope in the paddling pool. And she had other reasons for having brief episodes of loss of consciousness. But if I could rationalize that a pause like this could have happened in the paddling pool, then she could have died from drowning. So it's not that sinus node dysfunction by itself is very, very unlikely to kill you because of cardiac standstill. But if you're doing something that you then would become syncopal and injure yourself as a reason for that, then that might be a reason to put a pacemaker in, and that would be effective at stopping those pauses. So these indications for a pacemaker, and this is in congenital AV block. This is just for your own reference. There aren't really any definite guidelines for pacemaker insertion in sinus node dysfunction in children. For some things, for example, in reflex anoxic seizures, where you will also get a sinus pause, I mean, people would be just as likely to let you have a pause for at least 10 seconds before considering putting a pacemaker in. But the frequency and the nature of the symptoms do play a part in whether or not you put a pacemaker in. Some parts of the guidelines would suggest that if you have a pause for over 3 seconds and it's sinus node dysfunction, that you're, and there is general evidence of sinus node dysfunction, that you may warrant a pacemaker. This is just for your benefit to see somebody who's got long QT syndrome. You can see that there is a long QT interval here, and also this upsloping is very typical of long QT type 1. And just to measure the QTC, it's usually using Bizet's formula. Don't just read the computer-generated printout, actually measure the QTC. So just to summarize, it's important that you take time to look at the ECG, recognize the rhythm, but equally important to look at the patient's condition. How quickly do you need to act? And that's as important as what you need to do, i.e. what specific therapy. In SVT, adenosine is usually therapeutic, but it can be beneficial in terms of uncovering the rhythm even when it's not therapeutic. Nearly all types of SVT will benefit from beta blocker. In terms of broad complex tachycardias, much rarer. They're much more likely to make you sick, but they're not always, so you don't necessarily have to panic, and that's why I say you should always look at the patient. Contact pediatric cardiology. You may try intravenous magnesium sulfate. If the patient's very well, you could try beta blocker, but if the patient is symptomatic or is decompensating in any way, then amiodarone is more likely to be beneficial, and in fact you may even need to do a DC cardioversion. Bradycardia is much less likely to be fatal, much less likely to cause symptoms, to actually cause the symptoms. Patients may be symptomatic and be bradycardic, but those are two different things. If it's AV node dysfunction, though, that is important if they are symptomatic and have evidence of certainly of high-grade AV node dysfunction. Sinus node dysfunction is relatively uncommon, but certainly does happen in young people and is very rarely fatal. But it can result in the insertion of a permanent pacemaker. Thank you very much. Happy to take any questions. Hello, everyone.
Hello, welcome back, everyone. Glad to be joined by Dr. Brian McCrossan, who you've just heard from. So listen, firstly, let's start by thanking you, Brian, for that talk. Few scary looking ECGs first to think about.
Yeah, absolutely.
And good to have gone through those before we next see one at 2 in the morning and have to try and process what's going on. So we're looking through some of the questions that are just coming in. So there's a question, you talked about SVT and the use of adenosine, and you had mentioned about if you've got a dose and you revert out of your SVT but quickly relapse back into it, about not increasing the dose because you've had an effect from it. And I suppose then the question would be, why not increase it, but also then how many times can you keep giving the adenosine before you need to think about moving on?
Yeah, sure. I mean, there isn't because adenosine acts so quickly inside of your system so quickly, you can use it on multiple occasions, but there is, but if you think that as long as the ECG breaks and you can see the gap and you get into sinus rhythm for a couple of beats, that is all the adenosine is ever going to do for you. It's then up to the heart to keep itself in sinus rhythm. And if you go back into SVT, it's because the heart is itching to go into SVT. It's usually because there's lots of ectopy. And that's actually what precipitates each run of SVT is some ectopy. So you can give adenosine if you want to, but it's not likely to actually keep you out of SVT. You'd be very lucky for that to do that. What you need is, and what the aim of all of this is to keep this kid in sinus rhythm, get you back to bed if you're on call like me, or get you not having to stare at the ECG monitor for the next 2 hours. And there's always a bit of anxiety with SVT that's going to go in, out, and the next time it goes into, it's going to stay in it. So you want to do your best to keep the kid out of it, and that's where the backup medicines of either the beta blocker and esmolol infusion, if the child's pretty sick, or if they are just a child for the first time and they're very well. I mean, sometimes this could be an 8-year-old, a 10-year-old first presentation of SVT. And they get out and they're eating and drinking, looking at you, and you can give them an oral beta blocker. So the beta blocker or the digoxin or the amiodarone or a flecainide, if you want to use that, they are the thing that will keep you out of SVT and also make it if you can't get the child out of SVT with the adenosine at all, will make it more likely for the adenosine to work as well. So as long as you've had some response with the adenosine at a particular dose, I don't mind you giving it once or twice more, but it's not likely to work for any longer than a few beats.
Yeah.
You then need to get the beta blocker in, or whatever medicine you're going to use, which will then decrease the threshold by which you will then stay in sinus rhythm and keep out of SVT.
Okay.
The point about just to reiterate the dose, I mean, it's a bit semantic on my part to say, oh, don't keep on increasing the dose. I don't mind if you do, but I don't want you ringing me about it, basically, because people say, oh, I was just wondering, we should now go up to 300 because the 200 worked, but it went back into SVT. Because that's a question you quite frequently get, and it's a slight irritation. It doesn't really matter. But it's not really understanding what the adenosine is doing, because 200 and 300 both act for the same length of time. So if the 200 works or the 100 works, it gets you back into sinus rhythm, but then you flip back into it quickly. The 200 is very unlikely to make any difference to that, because they'll both be out of your system within a few seconds.
Yeah.
So that clarifies anything about the use of adenosine.
Yeah, no, I think it does. And I suppose the other question that we'd come up with the panel were wondering about was the use in pre-excitation and the use of digoxin. You talked about it a lot in the under ones.
Yes.
Would you still be as keen to use it in those older children or over 1 year old, or
yeah?
What are your thoughts on that?
Yeah, I mean, depending which centre you work in, and whichever is your feeding centre for paediatric cardiologists, different cardiology groups have a preference for certain type of beta blockers, and digoxin isn't necessarily everybody's number one choice, so it isn't. But in infants, it's very safe, even if they are pre-excited. The concern about digoxin, full stop, is that you block the AV node. And if you are capable of conducting very fast down the pathway, if you had atrial fibrillation with your SVT, so you've got two things going on, and you've got atrial fibrillation and you have Will Parkinson White, that you would turn atrial fibrillation, which is make you sick, but it's not going to kill you, into ventricular fibrillation, which will kill you.
Yeah.
Now, as you get older into adolescence and into adults, people with WPW seem to be at slightly higher risk of having atrial fibrillation, but I personally have never seen it, and it's not something I worry about, especially in infants. So I'm very happy to give them digoxin. But the older you get, the more likely that the child will be sitting up looking at you, because they have other symptoms that will alert the parent that there's something wrong with them. So they tend to present a little bit sooner with their SVT anyway, a bit less sick. And so they are eating and drinking, and they're looking at you, and you have time to give them adenosine and then also to give them an oral beta blocker. So you don't usually have to get wired in with an IV esmolol infusion in an older, certainly not in an older child. You can usually give them a good dose of atenolol or propranolol, and then try your adenosine. And if that doesn't work, then maybe you would give them amiodarone even. So you would, but yeah, I mean, in the older child, I wouldn't usually use digoxin as a first off, but in an infant, yeah, I'd be very happy to do that. But equally happy to use a beta blocker as well, unless I have a worry that the child's function might be reduced, especially therefore their blood pressure is a little bit saggy. I'd be a bit worried about using a beta blocker as a first off.
Okay, thanks. That makes sense, Brian. And just I'm going to come to Tudor. I think there's been a couple more comments coming through on questions coming through on the chat, including something about the kids having a good time in the background. So
hold on 1 sec. I'll try and put a stop to that.
No, it's fine. It's good. Tudor, will you keep an eye on the questions?
Just on the question about the point about them not necessarily having good cardiac function, there was a question as to whether you would always do an echo on a child who you're thinking of starting a beta blocker to rule out any cardiac dysfunction.
Yeah, so they will all get an echo at some point. That is mostly, and the reason for that depends a bit upon the clinical status of the kid. But anybody with SVT is going to get an echocardiogram at some point. Generally, it is to make sure that they don't have congenital heart disease. The specific one that's associated with SVT would be Epstein's anomaly, but that's very rare. You're right. The sicker somebody is at the start, the more likely it is that it's the function you're looking for, and making sure maybe an effusion is very unlikely, but looking at the function. But that can take a while to organise, and really, the quicker you get the child out of SVT, the more well they will be. And I wouldn't be waiting around. That's why the esmolol is very useful in that circumstance, because if you overcook the beta blockade with that, then it's out of, and the blood pressure becomes saggy, or the child's perfusion becomes worse with that, you can stop it and it'll be out of the system quickly. We generally don't give IV propranolol anymore. I haven't given that for years and years, because once it's in, it's difficult to reverse. And so when we used to find patients, pretty hypotensive with that. So, you don't have to wait for an echo. And certainly if you're in an emergency department and the child's in SVT and is a little bit symptomatic from that, if you're worried, then you could talk to a pediatric cardiologist, but I think it's unlikely that they will say, yes, hold fire, and we will give, we'll wait for an hour or two until we can get in and do an echo.
Thanks.
Okay, that's great. Thank you.
Yeah, thanks, Brian. I think time-wise, we're going to have to move on to the next talk, but thanks again for your chat and for joining us today. And I'll hand back to Chris now to introduce our next speaker, who has also joined us.
Yep. Okay. Thanks, Ben. So our next speaker is Dr. Grace McCall, who is one of our renal consultants in Belfast, and she's going to be talking about paediatric acute kidney injury.
Hi there, my name is Grace McCall and I'm one of the consultant paediatric nephrologists working here in Royal Belfast Hospital for Sick Children, and I'm going to talk to you today about paediatric acute kidney injury. So just an overview of the talk, I'm talking to you about the background of AKI, its definition, pathophysiology, using a case to talk through principles of history, investigations, management, AKI outcomes and follow-up, and why is it important. So firstly, what is AKI? So it's the reversible loss of normal renal function, and it's recognised by a reduction in urine output and an increase in serum creatinine. And that results in a reduction in your glomerular filtration rate and will affect regulation of fluid, acid-base balance and electrolyte balance. The reversible element of that is arguable, and I'll highlight why that is later in that aspect of this talk. Chronic sequelae is under-recognised from the point of view of AKI. It was traditionally very much thought to be entirely reversible. However, emerging evidence challenges this and supports a strong link between AKI and chronic kidney disease. So looking at the incidence and mortality associated with AKI, so the largest study was in North America, and that looked and found that there was a markedly higher mortality rate associated with AKI, and that's really the largest study that there is in place. More locally, there was a study in Royal Manchester Children's Hospital in their PICU, looked at the time between the relationship between AKI and AKI biomarkers, and that identified that 49% of their children had an episode of AKI, which is fairly significant. And more recently, there was a study carried out through the British Association of Paediatric Nephrology, and that was over 6 centres looking at serum creatinine values. So they had over 57,000 creatinine values, and they found that there was a 10.8% incidence of AKI. However, only 27% of these episodes were recognised, and there was failings in very basic things such as daily weight urinalysis, things that are simple and that we could very much improve on. And this again is just to highlight an observational study from America, comparing. They looked at and compared the different definitions of AKI, and they very clearly identified it was associated with a greater mortality and length of stay, both in ICU and outside of the ICU setting. So where did this all come from the AKI perspective? So there's a sort of a seminal report, so the NC Pod report of 2009. There was a marker for change with regard to acute kidney injury. It was done in the UK, and up to 100,000 deaths each year in hospital were associated with AKI. Up to 30% of those could have been prevented with right care and treatment. These findings from the report showed systematic failings in adult AKI and recognised that changes in practice needed to be made to improve our patient care. This led to an NHS patient safety alert, as you can see in the centre. And that led on to Think Kidneys, which I'm sure some of you are aware of, that was produced in 2015. And that was a national NHS campaign to improve the care of people at risk of AKI, including paediatrics. And this is just that document and the BIPN flow diagram for AKI. That was developed by representatives for the paediatric renal units, and the output was a consensus document highlighting children at risk of developing AKI, advice regarding investigation, management and tertiary service referral criteria. So thinking again about the definition of it, so there has been variable attempts to do this over the years. Primarily rifle was very much adult driven, so risk, injury, failure, loss and end stage disease. And this was carried out in 2004 by the Acute Dialysis Quality Initiative Development Group. That led on to paediatric rifle, so P rifle, and that looked more at changes in glomerular filtration rate rather than just serum creatinine alone. And then more recently in 2012, KDIGO took that forward and they amended the definition with regard to changes in serum creatinine and both your urine output, looking at those children who didn't have previous blood results with specific upper limit reference ranges. And again, that's just to highlight the different ways in which it's been classified, and KDIGO tends to be the one that's more recently used in literature, which is the one that I have circled. And again, that's just a slide to show the definition as per KDIGO, stages 1, 2 and 3, 3 being the most severe, 1 being less so, and that table of agreed age-related intervals. So that child that comes into hospital who's never been in before gives you an idea of what their creatinine should be. And that's also in the Think Kidneys, so if you're looking for a reference point, it is there. So the limitations of this, so diagnosis of AKI in children is caused by for variable reasons, and it's not distinguished in the classification. Diagnosis is traditionally relied upon from a creatinine and a urine output perspective, but serum creatinine is affected by a number of different factors such as sex, muscle mass, age, metabolic state, and generally it's a poor biomarker. So a big point that I want you to remember is that creatinine levels only rise once you've lost 25 to 50% of your renal function. So there are other biomarkers out there which are beyond the scope of this talk today, but are certainly a research point for future. Looking at it onwards, the measurement of urine output, very difficult in children. People do struggle with that, so it's a problem. But despite these limitations, estimation of serum creatinine and urine output are the most practical way in which we can define AKI at this current time. Pathophysiology then, so this is just a table to try and talk that through with you. So you get a primary insult that causes acute tubular damage, and it's accompanied by a loss of the ability to reabsorb filtered solute. This resulting vasoconstriction in an attempt to improve the GFR can perpetuate further renal damage such as obstruction and inflammatory processes. And this is a table really to look at the etiology of AKI. And it can be classified, and I've tried to classify it into three different sections. So functional, leading to reduced blood flow, intrinsic or obstructive. And this is important for a number of reasons, and important to highlight that AKI secondary to hypovolemic dehydration is the most common cause worldwide. So just try and work through that table and see where it is you think that your child fits in and go from there. So talking through a case then, so this is a 4-year-old girl. She had a 3-day history of vomiting and diarrhea. She had a history of temperatures at home, limited oral intake, parents unable to quantify, as is so regularly the case when we see these children, and a decreased urine output. Again, couldn't quite put their finger on when she had last passed urine. Looking at her past medical history, so she had a history of congenital cardiomyopathy. She had a cardiac transplant in July 2016. As a young child, she had recurrent urinary tract infections, and this culminated in an E. coli sepsis, aged 2 years of age, and at that time she had a documented AKI. This led on to her to develop CKD stage 3, probably partly from a transplant perspective, but also because of insults to the kidney, and she also had hypertension. Looking at her medication history, she was on tacrolimus, alpha-calcidol, cotrimoxazole, atenolol, sodium bicarb, Cytron and Abidec. And just to particularly focus your minds in there on the tacrolimus with regard to her medication history. So history is really important from the point of view of AKI, and it's important that you do take the time to do that. So think about the fluid intake. Has there been a reduction? What about their urine? Again, is there a query about obstruction? And is it concentrated? Is there blood in it? Temperature, you're thinking about insensible losses. So if you've got GI losses plus temperature, you must think that actually that renders them at higher risk of dehydration. your normal history points as you always would, but really focused in on that medication history. So nephrotoxics, have they had Nurofen for their temperature rather than just paracetamol alone? And always think outside the box from a systematic point of view. Is there something else more unusual going on here? So do think about rashes and joint pain and recent tonsillitis and that side of things. It's important to consider that children who are dependent on others for fluid intake can also be at increased risk of AKI. Non-ambulatory children and those with a low muscle mass will have a lower baseline creatinine, and that may mask their creatinine rise if not compared with baseline levels. So don't just look at the warning scores on your lab system, look at the trend. There are several high-risk scenarios for AKI along with specific underlying medical conditions that render children at risk of AKI, and they're in this table, and again they're within the Think Kidneys document. A thorough drug history, as I've already said, is really, really important, and consideration of potential nephrotoxic medications must be undertaken. And this table highlights common agents that may need to be stopped, may need to be dose reduced or monitored very carefully. It's not an exhaustive list, but one that I find can be helpful just in your general daily practice. In the setting of AKI, your nephrotoxic medications should be stopped if you can, and if you cannot, undergo dose reduction in line with their estimated glomerular filtration rate. And this needs to be reevaluated as their renal function changes. So if your EGFR gets worse, you may need to readjust those doses. Again, if it gets better, you may be able to relax it slightly. So back to our case. So this little girl, she was tachycardic. Her rests were fine, her stats were fine, but she was also hypotensive with a blood pressure of 88/56. Normally sits with a blood pressure of 120 to 130. Of note, her weight was down 1 kilo from her recent clinic appointment, and that is important. If you can get a previous weight, that's very useful. She was lethargic but rousable. She did appear to be dry on clinical documentation, so dry mucous membranes, not edematous but cool peripherally, and had a cap refill of in and around 3 seconds. Thermal pulses were present. She had good air entry. Her tummy was nice and soft. No other rashes, meningism or anything of concern. And her initial gas there, as you can see it, she had a metabolic acidosis, and of note her BM was 2.2. So how do we assess these children with AKI? Attend to their life-threatening features first. So think about your ABCDE approach, so oxygenation, fluid status and electrolyte derangement. Evaluation of fluid status is essential to clinically determine if they are hypovolemic, euvolemic or hypervolemic. Make an attempt at that. It is difficult and I fully appreciate that, but do make an attempt. It makes it easier for people coming behind you to see if your changes have been effective. Your blood pressure should be performed manually on an upper limb. You may need to consider doing a Doppler blood pressure if you've got a smaller child or a baby for a more accurate reading. A height measurement when working out your blood pressure centiles is needed. However, I appreciate that if a child is very sick, this may not always be possible. So clinical features consistent with fluid state. Okay, so I've tried to split this up again into 3 sections and make it easy for people to go through and try and make that assessment. And this is all things that you will already know, but it's just to try and quantify that for you in a succinct way. So looking at your child with a dry mucous membrane, sunken eyes, prolonged cap refill, our child very much fits into that picture of being hypovolemic. In that situation, you want to think about giving a fluid bolus of 10 to 20 mils per kilo, either of 0.9% saline or plasmite, depending on your local fluid guidelines. For those children that don't quite fit into either hypovolemia or hypervolemia, you may feel they are euvolemic, but they can still undergo a fluid challenge, which can be between 10 to 20 mils per kilo, but maybe given over a slower space of time, such as 60 minutes, to see how they respond to that. Does it improve their observations or does it improve their urine output? And then there are the children that are hypervolemic, so thinking about those that are tachycardic, hypertensive, raised JVPs, difficult in children but can be present, gallop rhythm, edema or a palpable liver. Have to be more judicious with your fluid in that situation. You can certainly give an IV furosemide challenge to see if it is effective, but these children are the ones that do run into difficulty quicker, so do consider referral to ICU or consideration for renal replacement therapy at an earlier stage. So for our young lady, she had 40 mils per kilo of sodium chloride. Her systolic blood pressure remained low despite that, at less than 100. She had a 10% dextrose bolus in light of her BM. And we decided from a fluid perspective that she was dehydrated. So therefore she had a 10% deficit. She was catheterised and placed in a strict fluid balance. At the time when she came into the emergency department, she was felt to be very drowsy and she was commenced on tazocin and acyclovir. And I raise that from an acyclovir perspective because that is a drug that is very, very much documented to have issues with exacerbating AKI. So be careful if you think that a child has encephalitis and you need to treat them, that's fine, but make sure you renal dose adjust it and make sure you review that on a regular basis. And we can see for her initial results there that her creatinine was up at 171 with her baseline being 80, so a marked increase in her creatinine. Her potassium was okay, her chloride was low, her bicarb was low, her coag was slightly off, and importantly, just to mention, her TAC level, so it was 4.8. It wasn't high, that's acceptable from a cardiac transplant and a renal transplant perspective, but always think about it in these children. That gave her an EGFR of 21 mils per minute, and if you put that in perspective, you're thinking about dialysis when you have an EGFR of 15 and below, so a marked decrease. AKI investigations, so clinical history and biochemical investigations along with renal ultrasound are helpful in determining the cause of AKI. And this table is just a way, I know it's a busy slide, but it demonstrates initial investigations that should be performed in all these patients. And further investigations are then warranted dependent on the suspected diagnosis. If you're concerned, discuss it with your local paediatric nephrologist. Just to highlight a few things, urinalysis is a really easy, quick test and done poorly. Please do it. Please send off urine for a protein creatinine ratio. First thing in the morning is the most reliable and it gives us a good idea of losses from the kidney from a protein perspective, and that's very helpful in looking at trends. The other thing to look at, a lot of people ask, is how do you work out their EGFR? So that's normally their height, it's multiplied by a K factor. So here we use 40, other places do use a different K factor, so just go in line with your local policy and you divide that then by your creatinine and that will give you your EGFR. Looking at renal ultrasound, it's an important modality and should be performed in certain circumstances. So within 6 hours, if you think there is a concern regarding a pyelonephrosis, pyelonephitis, or a renal vein thrombosis. And within 24 hours, if you cannot identify a cause for AKI or you think there is an obstruction. Really, if there's an obstruction, I would like it sooner than 24 hours, but that's the current guidelines as per KDIGO. If you ultrasound during an AKI episode, you will find the kidneys are large and bright. A renal biopsy can be considered in those children who have nephrotic or nephritic presentations and if they're rapidly, their renal function is rapidly deteriorating and we do not know why. So this is just a nice diagram to sort of show you that until recently, progress in characterising events that follow an AKI insult have been hampered by a lack of a consensus definition of progression and its associated events. And following recognising this, a working group again, the Acute Dialysis Quality Initiative, sought to clarify these concepts, and they identified a clinical course of AKI and conceptualised it in events that followed an acute insult to the kidney. And there's 3 phases. So the first one is the development phase, and that represents the immediate effects of the initial insult which may be subclinical. The extension phase then ensues, and that is in a point where both injury from the kidney and repair mechanisms are competing against each other. And then you have the resolution phase that represents the net outcome of both damage and repair. And the duration of each of these phases may vary considerably from child to child, dependent on the nature of the kidney insult and the repair processes. So I'm just going to try and talk you through these. So thinking about optimising kidney perfusion, minimising iatrogenic insults, control your acid-base balance and electrolyte abnormalities, and optimise urinary drainage. And I'll just talk through each of these separately. So these interventions should target removal of kidney insults and optimise conditions that then facilitate your adaptive repair processes. So optimising fluid and kidney perfusion. So fluid resuscitation we've already talked about. Fluid-wise, we would prefer that they have ongoing fluids or feeds given orally or NG, and if that's not possible, then IV fluids are fine, but do switch them over as soon as you feel that is appropriate. Strict fluid balance and daily weights are essential. I can't emphasise that enough. It's very helpful, particularly if you're in liaison with a nephrologist, they will want that. Initial fluid review should be carried out within 6 hours of admission and assess that regularly thereafter. Fluid regimes, adjust them on clinical response and subsequent electrolyte results. Maintain your blood pressure. So for this little girl, we held her atenolol. That was in liaison with cardiology. Be wary of stopping those kind of drugs unless you've spoken directly to their cardiologist, particularly in a cardiac transplant patient. Echo can be useful, and it was with her, and she still managed to have good function despite being hypotensive and dry. Just of note with regard to blood pressure, there is no evidence to support renal dose dopamine. That was an older practice, but that is not the case anymore. And fluid management then, so again, looking at your stage 1 AKIs, they really can have maintenance fluids plus deficit if you think that's necessary. Stage 2 and 3 do tend to run into more issues and are slightly more complicated. Once you feel that you have filled them up and adequately resuscitated them, and if you're still struggling from a urine out perspective, it is wise to replace insensible losses, so 400 mils per metre squared per day, plus mil for mil of what they are peeing out, and that should keep them safe and should stop them becoming fluid overloaded. Fluid deficit can also be given in stage 2 and 3, but carefully, and needs to be reviewed regularly. And then when you come to the renal recovery stage, you do find that these children become polyuric. So looking at those, if you find that there's 4 mils per kilo per hour of a urine output, you should be replacing that volume that's above that, either with IV fluids or oral fluids, and that's trying to prevent them from having a secondary injury from an AKI perspective. Minimising your iatrogenic insults. We've already talked about this from a drug history perspective. Renal dose adjust your medications as per GFR. Stop nephrotoxic potential where able. She was commenced in tazocin acyclovir. Was it necessary? She did not end up having encephalitis. She was drowsy, more likely so because she was hypotensive and hypovolemic. So always do think about it. TAC levels, so just so that you know, TAC levels do tend to go up with diarrhea, so they do need closely monitored, and you may need a dose reduction in your tacrolimus level, but that can be led also by the transplant centres. Cotrimoxazole for her, just to flag that up as well, it is associated with tubulointerstitial nephritis, so she may have had something more unusual, so again, have a think about it. And atenolol, think about your antihypertensives. The big antihypertensives that we do worry about are ACE inhibitors and ARB, as they should definitely be stopped if they are having GI losses. Because they have a very high risk of causing AKI and should be restarted once they are better. And all of those children should have sick day rules with regard to those therapies if they're on them. Controlling acid base and electrolyte abnormalities, so address hyperkalemia. Okay, I'm not going to go through that. That's as per APLS, and we would stick with that. Severe acidosis compromises adaptive repair, so correct it where able. Giving sodium bicarbonate is fine, but you must ensure that your calcium is normal. And a quick way of doing this, if you have a gas in the ED department, if your ionized calcium is greater than 1, that's good. But do not give bicarbonate if it is. You must replace your calcium first before giving bicarbonate. You may require electrolyte supplementation, particularly during the polyuric phase. So they may need sodium, potassium, and magnesium and phosphate. So do keep an eye on those elements. Optimising urine drainage. So this is important if you suspect a congenital abnormality of the kidney or urinary tract. So that's what CACUT stands for. So those young babies that come in, it's a baby boy who is a missed posterior urethral valves. Catheterise them if you deem it is appropriate. If obstruction is suspected, get an urgent renal ultrasound. The guidance is 24 hours. If you can get it before that, that's great. And then you can try and remove and treat that obstruction and use your urologists. They will be able to help you with that. Delay in this compromises, again, adaptive repair. Those children that come in with a high potassium and a low sodium, think about them from an obstructive perspective, they may well have pseudo-hypoaldosteronism, and once you relieve that obstruction, that should resolve. When do we want to know about them from a nephrology perspective? So as I've already mentioned, CKD and previous renal transplant, they are at risk, so we do want to know about them. AKI associated with multisystem disease, if they're hyperkalemic unresponsive to medical management, if they're anuric or alloanuric and their plasma sodium is less than 125, pulmonary edema or hypertension unresponsive to diuretics, if their urea is greater than 40, so uremic children become unwell, they do not want to take fluids, they will not take solids for you, and they will progressively become more lethargic. If they have a glomerulonephritis with a nephrotic range urine protein creatinine ratio, so anything over 200 from a urine protein creatinine ratio is nephrotic range, we would want to know about that. And stage 3 AKI, definitely. Stage 2, very happy to also have a discussion about those children. And then moving on to renal replacement therapy. So this is an entirely different talk in itself, but really I'm just going to talk briefly through the indications for this. So again, hyperkalemia, volume overload, metabolic acidosis that is refractory to medical management, symptomatic uremia, if they are anuric and you're struggling with regard to nutrition and volume or toxin removal, so it can be very helpful. Renal replacement options, so if you're in the PICU setting, CVVH is the one I think that most people would opt for. It's a gentle form of renal replacement therapy. PD can be used in the acute setting and we would use it very regularly, but it does take time to optimise it to good levels and does require no leakage of the catheter. So it is an option, but it can be difficult to establish. Hemodialysis and HDF, they are forms of renal replacement therapy, difficult, and would not use those in children who are very unwell and unstable from a clinical perspective, as they cause large fluid shifts and electrolyte shifts. So CVVH would be a better option for them. So progress for our child, so her creatinine peaked at 220. She did not require inotropic support. She did not need filtered and she did not need ventilated, and that was because of careful fluid management from the outset. She completed 5 days of tazocin. Her acyclovir was stopped on day 2. All of her cultures were negative, including her virology. So again, thinking back to that acyclovir, was it needed? Her blood film at the time, she had low neutrophils. It was all reactive and felt very much to be related to her concurrent illness. She was discharged from PICU on day 4. She did have a phase of polyuria, which was ongoing, and GI losses, but they settled by day 6. And she now has a minimum fluid target of 1,400 mils a day. And that is a strict care plan for her and very strict parameters for parents about when they must seek medical attention. And she was discharged on day 10. Subsequently, unfortunately, her CKD has become worse due to this hit, and she's now sitting with a CKD stage 3B and 4, really just highlighting again how important it is to manage these children well. And unfortunately, she is on a number of supplements now, including EPO, because of her CKD, and she's got progressive bone disease. AKI outcome. So why is this important? Why am I talking to you about this today? So this was a good study done in Israel. So it was looking at Israeli adolescents who were examined before compulsory military service, and their data were linked to the end-stage renal disease registry within Israel. And anybody that was coming through that had a kidney disease in childhood, either Acute, pyelonephritis, glomerular disease, were all looked at, and they all had normal renal function and no hypertension in their adolescent years. However, in their adult years, there was a significant increase in end-stage renal disease that really suggests that kidney injury or structural abnormality in children has got long-term consequences. And these are just some other studies. Again, this was an American study that really identified that chronic sequelae of AKI is under-recognised. A third of 176 children who were looked after in this centre in both the PICU setting and the ward setting had reduced kidney function or remained on dialysis at the time of discharge. And on a 3 to 5 year follow-up of the cohort, 58% had long-term effects, including hyperfiltration, reduced kidney function, hypertension and proteinuria. And this second study is just, again, it was 126 children treated in an intensive care, and 10% of them had CKD within 1 to 3 years following an AKI. So again, compelling evidence that we do need to take this seriously moving forwards. From a follow-up perspective, stage 2 and 3 AKI should be followed up at 6 weeks, 3, 6 and 12 months. At that clinic review, I would expect a manual blood pressure, their bloods to be checked and their urine to be dipped and their urine sent off for a protein-creatinine ratio. So basics, nothing complex, but it will identify those children who are running into trouble. All children who have required dialysis, including those who have CVVH, or who have persisting proteinuria or renal dysfunction at 3 months of follow-up, should be referred to a tertiary nephrologist or SPIN paediatric nephrology. So in summary, AKI is associated with increased mortality and long-term CKD, and I hope I have convinced you of that today. Early recognition is paramount. Creatinine only rises in 25 to 50% of renal function, so taking that good history and looking at your drug history and getting the families to seek medical attention early is important. There is a role for biomarkers, and future studies will evaluate those further. Volume resuscitation and fluid management is key. And a very important cornerstone of your management. Identifying potential nephrotoxic agents and ensuring renal dose adjustments are made where appropriate. And all patients with AKI stage 2 or 3 require long-term follow-up to mitigate progression to CKD. I'd just like to acknowledge my department here, and I'm very happy to take any questions that you have. Thank you.
Thanks very much, Chris, for that talk and for joining us for the questions. A few have come through there. I suppose one referring to adjusting doses of medication in AKI, which I assume you touched on briefly, and I assume we do need to do. Have you any good sources or references? Obviously, some people maybe not working or living within the UK, so anywhere they can turn for advice.
Sure, yeah. I mean, I think one of the good ways to do it is to try and work out any GFR if you can, which is helpful then to apply back to your formularies. Your BNFC is good. Certainly there's always a renal dose adjusted section on the bottom of that, and you can get that as an app. So that's a handy thing to use. There is also what's called the GUIDES formulary, and there's a renal handbook of medications as well, which most renal units should have. Certainly all those in the UK will have, and can be found in intensive care. So again, they can be something that you can refer back to, and you can get it on online versions as well. So it's just something to bear in mind if you are stuck in the middle of the night and you're not sure what to do with dosing. There are things there you can use.
Yeah, grand. And I think another sort of, I suppose, contentious topic really about regards or relates to the link between AKI and development the chronic kidney disease. And I know there's questions just come through in the chat there about any particular risk factors for children with AKI who are less likely to fully recover. So just wondering what your thoughts on that particular topic are.
Yeah, so I think there's lots of different studies that look at this, and I think there was a big one that I haven't really talked about because it's neonatal, but there was an Awaken. It was called the Awaken trial, and it was done in America, and it was over 2,000 infants, and 30% of those children in the unit had AKI, and it was associated with an increased risk of mortality and length of stay, but also from a longer term perspective for those young babies. And essentially it's trying to get the idea in your head that you're born with approximately 1 million nephrons, and every time you have an insult to the kidney, you lose a certain number of them. You do not regrow them. So every time you have a hit to the kidneys, you are leaving yourself then more at risk for CKD in the future. So you may have a child who, has that very severe meningococcal sepsis who's an AKI 3 who doesn't recover. Or you may have that child who just has continual insults, such as the child that was in that talk, who I very much suspect, further on down the line will need a renal transplant. She's young, she's young at this stage, and I've no doubt that she will get into trouble again in the future. So it's all about trying to prevent that, but also keeping a really close eye on them and looking out for those telltale signs that their renal function is deteriorating and trying to intervene where you can.
Okay, thank you. And I think another question that just came through about post-contrast nephropathy. Is this still a risk with modern IV contrast, or more of a historical thing now? Is this something you see?
Yeah, no, I mean, it certainly is. It's still there. I think now what we can try and do is look exactly, do you really need that scan, or is there another way of imaging that child in any other way you can avoid that? But there are times when you can't, and certainly there are children that we would look after within the renal team, and we have to give them that contrast. And what we will do in that situation is that we will sort of hyperhydrate them beforehand, either with oral or IV fluids, and then give them the contrast, and then give them additional fluids after that to try and flush it out of the system. And it's all you can do if you are very stuck in a situation. But yeah, it's something that we try and avoid, but if we can't, then we try and get around it by giving them additional fluids and support.
Grand. Perfect, thank you. Any other comments or questions from the rest of the panel before we move on? No, grand. In that case, then thanks again, Chris, for your talk and for joining us for the questions. And we'll hand over Chris to introduce final speaker of the day.
Okay, thanks, Ben. So our last speaker of the day is Dr. Stephen Mullen. He's one of our paediatric A&E consultants in Belfast, and he's going to be talking about paediatric burns.
Hello, my name is Stephen Mullen and I work in the Kids Hospital in Belfast, and today we're going to chat a little bit about paediatric burns. So the overarching theme for this is essentially to do the basic things well, as I think that's really important for these type of injuries. We're going to discuss the fundamental principles of assessing burns injuries, and then talk a little bit about minor injuries, focus on the evidence behind burns first aid, before progressing on to major burns, and at the end we'll discuss briefly the considerations you need to have for non-accidental injury in these children. So it's really important that we know how we assess a burn, as this has implications for how we manage the injury in the department, in order to give parents information in terms of about the time it might heal, and also for who else we might need to be involved in looking after these children. So we need to be aware of what patients we're likely to see. So this is an epidemiological study published in 2014 by Kemp and colleagues, which shows what we would usually expect in the A&E department, that the majority of burns have a low TBSA, or total body surface area, less than 1%, and they're more common in the under 3s, and this is part of their developmental process where they're exploring their environments. By far and away the most common injuries we see are scalds and contact burns, and this is what our talk will focus on. Radiation burns, chemical injuries, and flames are thankfully less common, and most of the first aid is essentially the same, apart from chemical burns. At this time of year, we'll have just encountered Halloween and bonfires festivities, when we usually see an increase in presentations as a result of fireworks or other burn injuries. So it's important that we're up to date and know how to manage these wounds. So the first thing we'll talk about is the depth of the burn, and this is a key part of your assessment. So this is a table that I've taken from the International Best Practice Guidelines, which are an excellent free online resource, giving a really good synopsis for the management of pretty much all burns in paediatrics and adults. Contrary to our American cousins, instead of using a 1st to 3rd degree burns classification, we define it more anatomically. And if we start at both ends of the spectrum, I think it's the easiest way. So you think of your superficial burn, which essentially looks like a sunburn. So the skin will be red, there should be no or minimal blistering. It will be painful and it will blanch really easily. And this means that only the superficial layer of the skin or the epidermis has been affected. At the other end of the scale, we've got a full thickness burns. So this has gone through your epidermis, your dermis, and into your subcutaneous tissue. So these burns will be white, they'll be charred. Because you've damaged the nerve fibers, they most likely will not be in any huge discomfort, and it's certainly not painful to touch. Whenever you put some pressure on it, it doesn't blanch, it remains white. And in between these areas, we've got our partial thickness burns, which are subclassified into superficial and deep, both of which are applicable to the other two classifications. With your superficial being a little bit red, usually incredibly painful, may have extensive blistering, with your deep partial thickness starting to get that white appearance. So this shows a good picture diagram of what you might expect. So this is not a minor injury, but you can see the white that's associated with the full thickness burns associated there. You can see your deep partial thickness burns and then the little bit of erythema around it, more in keeping with your superficial partial thickness burns. So now we've looked at the depth of the wound. The next thing to consider is the size. And this has huge implications in terms of making onward referral, if you need to get IV access to start fluid rehydration, and also when you're discussing with your local burns or plastics team. There are multiple different ways in which we can measure this. So you can use the principle that 1% of the child's hand, or the hand of the child equates to 1% of the child's TBSA. Or you can use the London Bowder chart. So both of them are absolutely fine. The one I tend to use more now is a Mersey Burn app. So this is a free online resource that you can get from any of the app stores, and it works incredibly well. It's really simple. You put in the weight and the age of the child, you shade in the area of partial thickness or deep full thickness burns, and that'll give you your percentage. So just like all other burns, when you're managing the size, you ignore the superficial erythema. This will also give you some advice on fluid resuscitation. This app has been validated, and certainly in my practice it seems to correlate better with the NTBSA that's generated by our plastic surgeons. So having talked about the assessment of these burn injuries, we're going to talk a little bit about the management, and for this we're going to focus specifically on superficial and partial thickness burns. An area I think that we could certainly improve on is our use of analgesic. We often see kids come into the department with acutely swollen limbs as a result of trauma, and we're very quick to get decent pain relief in early because we realise how sore these are and how much distress these children are in. Anecdotally, I feel we're probably not as good with our burn injuries. And if we're able to get decent analgesia, the one that I usually recommend is intranasal diamorphine, you can be able to de-escalate the situation and get your other treatment modalities in. So think about what analgesia you're going to give these kids and how you're going to administer it. In keeping with the theme of do the basics well, it's really important that when they come to A&E departments that we're able to do the basic burns first aid, that if it hasn't been done at home that we should complete it in our department. Now this is a parental information leaflet that I was part of designing when I was working in Cardiff that coincided with a campaign called the Safety Campaign to educate parents. The two aspects of this that's important to cover are the cooling mechanism, in which is just cool water from a tap for 20 minutes duration. And the thing to remember is that this is beneficial for 3 hours after injury. So if they come into your A&E department at 2 hours and 45 minutes, you should still be putting their arm under the tap for the 20-minute time period. The other aspect to cover is the covering of these wounds, and we recommend either cling film or in some countries is known as sarin wrap, and this works incredibly well. This should occur after the burn has been cooled appropriately. This stops the burn fibers or the nerve fibers being stimulated by the air, therefore decreasing the pain felt by the patient. They're also transparent, so you don't need to remove dressings and put them on whenever you've got a senior or subspecialty that wants to look at it. And it also protects the wound from bacterial infiltration. So something really simple but works incredibly well. Now just go into a little bit more detail about burns first aid. When you go back to basic physiology, we're talking about the Jacksonian model of injury. So whenever the injury occurred, there's a part of that tissue that no matter what any of us does, it's dead, it's necrotic. But it's the area that surrounds it, this area of stasis, which we can potentially save. So by doing decent first aid and by adhering to the other principles of burn management, you can potentially reduce the TBSA and the depth of these burns. Most of the information that came out of this was from animal models, particularly pork, but recently we've got started to get some decent paediatric information coming through. So this study, which came out of Australia at the start of this year, looked retrospectively at 2,500 kids who attended a burns unit with an injury. And what they were looking at, their primary outcome was skin grafting. So this is some of the results from the paper. So the key results are displayed in this forest plot. Anything to the right of the forest plot favours intervention. The odds ratio for skin grafting is reduced by 0.59 with the use of burns first aid, particularly cool running water. The same results are applicable for full thickness depth, hospital admission and operation room intervention. So these are really impressive results impacting how we should educate parents and what we should do when these patients enter the department. The results also appear to show that there is a correlation between the duration of first aid and the need for skin grafting. Whereas the longer you do first aid or the more you adhere to that guidelines of 20 minutes, the greater the reduction is, or the lesser the need for skin grafting. Anything over 20 minutes is felt to be detrimental to the tissue and is not really recommended. An area which there has been some concerns or questions raised is the use of other agents apart from cool running water, with the availability of burn spray and things like hydrogels that can be placed over the wound, particularly in a busy A&E department or pre-hospitally. So this was a really nice study in 2017 which assessed the use of cool running water, burn spray and a burn shield in order to look at the temperature reduction for these wounds. And if you think of why we're doing burns first aid, part of the reason is to reduce the temperature. By far and away, the application of cool running water had the greatest reduction in temperature, with the burn shield actually having an increase. So for me, there is no real rule for these in my emergency department, and we thoroughly recommend just using cool running water. Dressings are really important. So most of the dressings in our departments are done by our paediatric nursing staff. This in itself will be an extensive talk. All you need to know is that the burns dressing should be easy to apply, it should be done in a sterile manner and changed after 48 hours. These should be then changed every 3 to 5 days until they're dry, usually in your A&E department with your practice nurse. In terms of the need for referral to the burns team or the plastic surgeons, there is recognised UK guidelines. Now they're a little bit older, 2012, and they're usually adapted by each burns unit. So rather than go through each of them individually, I would say look at your own burns unit and see when or what injuries they would like to see. Usually it's guided by your TBSA, the depth of the wound, if it's in any special places, or particularly if there's any concerns about non-accidental injury. There's a few complications of wounds that we need to be aware about, and whenever we're discharging these patients, we need to give them good advice about the risk of toxic shock syndrome, particularly with the infiltration of staph and strep. So these can be very non-specific in the presentation. Most will have a temperature. You may see a wound that will increase in erythema, which has discharge, but sometimes the kid may present with symptoms such as vomiting and diarrhea. So good written guidelines from your department will help alert the parents to this potentially serious complication, which does carry a high mortality. We also must think about the use of tetanus for these wounds. In my department, due to vaccine hesitancy, we're seeing more and more children come unvaccinated. So whenever they have a burn injury due to the risk of tetanus, we're often vaccinating them in the ED. You also need to think about the role of prophylactic antibiotics. So my department continues to use this, and this is based on local case series. However, when you look at any of the international database, which does systematic reviews and meta-analysis, there really is no huge evidence base to support the use of prophylactic antibiotics in burn injuries. But again, you need to go by your own local practice. So we've discussed the management of kind of minor burn wounds, focusing on the importance of doing the basics well and ensuring that still occurs when they hit your emergency department. Now we're going to mention a few of the key principles for major burn injuries. Now thankfully these are rare events. There's been a huge amount that's happened over the last 20 years in terms of improved housing, change into how clothing fabric have been implemented, and the need for smoke alarms in homes that have certainly reduced the number of burns we're seeing in ED. The ones that I have seen recently are the ones who have used fire accelerants or aerosol cans with large flames or in bonfires. And these are trauma patients and they should be treated as such. So you need to adjust your algorithm and remember the catastrophic hemorrhage and think of C-spine immobilization, particularly if they've jumped out of a window of a house, or we've recently seen people in a tree house who've been playing with gas canisters when an explosion and have fallen quite a high height. So follow your trauma algorithm and work your way through it. So it's not only the burn injury that's going to cause problems with the patient, but it's the physiological response to the inflammation that occurs. In adults, to say anything over 30% and in pediatrics 10% can initiate a kind of almost cytokine storm with a release of inflammatory mediators. Now these have systemic effects. They can cause decrease in myocardial outcome, they can cause your capillaries to leak, resulting in pulmonary edema. You can get pulmonary edema as well, leading to ARDS. So multiple complications which may not necessarily be due to the burn itself, but to how the body responds to it. Specifically, we need to think about the airway of this child. So if they've been in a closed space or they've come with symptoms and signs suggestive of an airway injury, you need to get anaesthetics involved early. So this might be the child who has burns to their nose or the mouth, whose lips or tongue swelling, a hoarse voice, or is coughing up soot. And for these, you need to remember that the burn is not a static injury, but that it progresses with time. So what initially is a stable injury when they hit your emergency department, 30 to 60 minutes later may be a very difficult to intubate patient. So get anaesthetics involved early and have a discussion to what's the best place and way to manage these patients. The lungs can also be damaged, so particularly if they're in an enclosed space, that hot air is inhaled into the lungs, causing multiple damage. So the alveoli can leak, leading to pulmonary edema and leading on to ARDS. You need to be thinking about getting your carboxyhemoglobin levels. You need to be thinking of getting anaesthetics involved early and watching how these lungs progress. So always after B, we have C, so think of your circulation. And be aware of the burns patient that comes hypovolemic early. Usually the hypovolemic shock that I've seen in burns injuries presents between 6 to 8 hours later, and the ones that come in the door with a low blood pressure, you're kind of trying to rule out any other system failure. So remember there are traumas, so look for the usual places where blood may hide, the chest, the abdomen, on the floor, in the head, etc. And exclude other causes before just solely attributing this as a consequence to the burn. Adjust your fluids accordingly, so if it's a trauma patient, reduce down to 10 mils per kilo, trying to save that first clot, best clot. And if it's your more traditional burns, you may think of using 20 mils per kilo. I rarely use 20 anymore, I normally just use 10 mil aliquots and reassess. For the fluid management, you need to think about your use of boluses, you need to think about the Parkland formula and also your maintenance of these fluids, and monitor the urine output. So the Parkland formula, which we'll talk about in a second, in some cases may overestimate or underestimate, so you need to look at how your patient is doing with your fluid resuscitation. You can overshoot, which can lead to things like pulmonary edema and also peripheral edema, which can put that tissue at an increased risk of ischemia. So monitor these patients closely. In terms of your Parkland formula, it's 3 to 4 mils per kilo times the total body surface area. And this should be divided into two halves. So the first half is given in the first 8 hours. Now what's important to remember is that this is 8 hours from the moment of injury. So if they hit your emergency department at 4 hours, you've suddenly 4 hours to get your Parkland formula in if they meet the criteria. Your other half should be given over the subsequent 16 hours. Now finally, it's not a paediatric presentation unless we discuss non-accidental injury. And this is a growing field of literature that I was lucky to be involved in when I was working in a previous post in Cardiff. So the literature varies in that the number of cases related to NAI from your burns patients can be anything from 3 to 20% depending on the population that you look for. A really nice paper that came out of England with Chester, which is probably 15 years old now, was able to identify that the risk or that the distribution of neglect to inflicted injuries was 9 to 1. Another paper, UK-based paper, which came from Swansea, looked at a burn injury under the age of 3 and found that by their 6th birthday, they were 7 times more likely to be registered as a child in need as compared to a control group. So these injuries in young kids can be associated with long-term problems. And just as for all non-accidental injuries, if these are missed, they tend to increase in severity. So what can be a minor injury gets more and more significant until it does threaten morbidity and mortality. So these pictures look at the forced immersion injuries that we sometimes would see in kids who've been forced into a bath. So they usually have what's called a donut sign. So whenever you look at the buttocks, they've usually been pressed against the bottom of the bath, so therefore they're relatively spurred with more significant burns in the surrounding tissue. And then you also hear of the glove and stocking distribution that we would sometimes see in inflicted burns when these patients have been submerged into boiling water. There are ways in which you can help pick up these cases, and again I must say I was involved in the assessment of these two tools, so I do have a little bit of bias. But the BASAT is a burns and scalds assessment template that has been used in Cardiff and I think probably 14 or 15 A&E departments throughout the UK, which assesses burns injuries when they present to your ED. And the other one is a clinical prediction tool, the burn tool, which is to help clinicians differentiate accidental from inflicted burns. So finally, just summary, it's really important that we do the basics well. Treat the patient with decent analgesia. Remember to get burns first aid involved. If it hasn't been done at home, do it in your department. It's really simple. Cool and cover the burn, and then for all injuries in kids, always have a suspicion of non-accidental injury. Thank you.
Live.
Listen, thank you, Stephen, for great talk. A sort of short, concise look at management paediatric burns. Few questions just coming up, I suppose. One with regards to NII, so non-accidental injury. You talked a little bit about that at the end. Maybe if you just elaborate a little bit more on what sort of features or patterns of burns would raise suspicion of NII and sort of cause you to think that may be the sort of the method behind the infliction of the burns.
So I think for any child that comes in with an injury, it should be always in the forefront of your mind, thinking, could this be an inflicted injury or an injury due to neglect? And often for the injuries that we think are more pathognomonic of NAI, such as your fractures or bruising or abnormal marks, we often don't really think about paediatric burns, and it has been an area of an increasing research and literature. There's some really good UK studies which have been led by a group out of Cardiff, which has given some great information. So in terms of pattern, for the inflicted ones, you have to think about the agents, because you obviously have scalds and contact burns. And the inflicted agents, you classically would describe the ones with the glove and stocking burn whenever they've got a forced immersion into boiling water. Or else you see the donut sign whenever you've got the buttocks, which are completely burnt, and then two spurred areas around the bottom of the buttocks, because the bottom of the bath isn't as warm as the water. Now, those are rare, but those are the ones that we are probably more trained to see. And for any injury, you're trying to correlate what you see in front of you with the history given and to the developmental stage of that child. So it's really important that you take a clear history and that you're able to focus in your mind how this happened. And if you can't see it, ask somebody else senior to have a look. And take the developmental history, but also go and do a developmental assessment to make sure that it all correlates. In terms of contact burns, now these ones can vary depending on the agent that they're used, but things like cigarette burns have been very well documented, having multiple different small burns throughout the body. There's some other random case studies which will talk about spatulas that have been dipped in boiling oil and then put on the person's body. And then there's some horrendous inflicted burns about kids which have had extensive acid put in them, about small babies who've been put in microwaves, who've been put in ovens. So it really is an incredibly kind of nasty injury in order to get.
Yeah, and as you say, unfortunately, it's incredibly nasty. It's scary to think that happens, but we've all seen it, and it's something that needs to be on our radar, I guess, as pediatricians. And I suppose the other question that had come up there just as we were going through your talk was, so Parkland formula for fluid replacement and fluid management of patients with burns. There's a new modified Parkland formula. I just wondered if you mind sharing a little bit about what the differences are between the two formulas and any thoughts on why that's been adjusted.
Essentially, the percentage and the weight is the same, but it's the 2 or 3 or 4 mils per kilo, depending where you go to. So the traditional Parkland will go 3 to 4 mils per kilo, where some of the modified ones will go 3, or some will even actually say 2. Mm-hmm. For all the Parkland formula, it's really important to remember that it's the time of injury. So it's not the time that they arrive to you in the A&E department, but it's the time that the injury has happened or the burn. And from my point of view, there is a concern about sometimes overloading these patients with fluid. And it can be difficult to cut back. So if you have a little bit of leeway, it means that you can reassess the patient, look at how the heart rate's doing, the blood pressure, the cap refill. The extensive burns are going to be catheterized. You're going to be looking at mils per kilo per hour. And then if you're falling slightly further behind, you can catch up by giving boluses or increasing your fluid rate.
Good. Thanks, Stephen. And I think that kind of draws us to an end today. I'm going to hand over to Chris in a minute just for some closing remarks, but I'd just like to thank Chris on behalf of everybody who's tuned in and all of the faculty for all the hard work that's gone into organising today, particularly in getting the technological setup up and running. So thanks, Chris, and I'll hand over to you to close.
Thanks very much, Ben. Really, in closing, I just want to thank a few people. In particular, I want to thank all the speakers. When I asked the speakers to speak at this event, they were agreeing to speak at a physical conference back in June. And what they ended up doing was a live stream in November. So I want to thank, nobody dropped out at all. We were certainly working out of a few comfort zones. And I really just want to thank everybody for putting this together. I think we've got a great resource here. And I think certainly the knowledge shared is hopefully going to help make a difference to critically ill children around the world. Particular thanks to the guys who've sat on the panel today. I think the interactive bit on Zoom has made a real difference. So big thank you to the guys who've done that. Special thanks to Ben for chairing the session. I think he's done a great job with that. And that's really added to what we've done today. I'd also like to thank my wife, Michelle. She stayed behind the scenes helping me run the live stream today, and certainly she'll not come onto the camera. But I couldn't have done this without her as well. And a final word of thanks to our sponsors. Again, we couldn't have put the live stream on to this quality without their involvement and done that for free. A few final things to remember about. Remember to get your course certificate over on the Paediatric Emergencies website. Think about making that donation to Helping Hand. We've had over 1,000 people watching for most of the day. We're hoping to raise only just about £1,000. So if everybody was to make even a very small donation of only £1, we could reach that target. So it's a very cheap day's CPD. I think that's most of the main things I want to mention. If you've missed any of the talks out as the day has gone on, they are all going to be available over on the Paediatric Emergencies website on the conference homepage. So you can catch up with what you've missed, or if there's bits you haven't seen, you can watch those there. If you have any further questions that we haven't been able to answer today, leave them over on the individual videos, and hopefully the speakers will be able to see them and respond directly to your comments. Okay, so thanks very much, everyone, and we'll hopefully see you on next year's event.